you have to make me as a co-host. Okay.
Vishal bhai. Sachin sir, host, and Dr. Liu co-host. सचिन सर ने होस्ट बनाए तो
ठीक है उसने हम दोनों को co-host बना दिया है. No problem. That is okay.
वो मेरा नेसेसरी सेटिंग कर लो ना सर, उसके बाद आपको मैं दे देता हूँ होस्ट.
ठीक है. No problem. Prashant?
Yes, sir. Yes.
You have to start YouTube पर.
ये started, sir.
वो ऊपर जो YouTube का लोगो आता है वो ठीक है, मेरे को चेक करने दो. No problem. Yes, it is on.
I'd like to thank you for inviting me to this meeting. This video is a lecture on brain AVM surgery techniques, or 7 AVM's Surgical Masterclass. This slide summarizes my surgical experience with brain AVMs over my career. And you can see that I've managed to operate on many of these lesions. I've overtaken my mentor, Dr. Spetzler, in total brain AVMs removed. And it's worth noting that if you compare my individual surgical series with all of the surgical volume in the Aruba trial, mine is 50 times larger than that. This just gives you a bit of a perspective on what you're about to hear. Many of my thoughts from this talk have been summarized in my book, 7 AVMs. And I wrote this book because I wanted to try and make sense of AVM surgery. When I ended my training, I didn't feel as though I had figured it out and felt that a couple of things would be helpful. First would be a taxonomy for AVMs that transformed the wide variety of lesions into some recognizable system of subtypes. That way, when you come upon one particular subtype, then you wouldn't have to rethink the whole thing, but you could simply apply learning from each subtype to your individual case. Next, I wanted to conceptualize the surgical steps because I felt that breaking surgery down into specific steps in a very granular way was a real helpful learning tool. Finally, I felt that we needed to improve our technique and our results, particularly in the Aruba and post-Aruba era where we are under such scrutiny to be high performers. I like metaphors, and the metaphor I chose for this book was war. When I think about AVM resection, I think of the neurosurgeon as a soldier, the cerebrovascular anatomy as our battlefield, the specific AVM subtype as the enemy, and the resection steps as our battle plan. It's a very militaristic view, but I think it's very valuable. First is the issue of taxonomy. This slide is meant to depict the incredible array of different types of lesions. No AVM is identical to the next, and so it's very easy to say that you can't categorize or have a taxonomy that's applicable to this incredible spectrum of disease. If you think beyond that, you can really break AVMs down into 7 types and additional subgroup of subtypes. The 7 types have to do with the location in the brain: frontal, deep, parieto-occipital, periventricular, temporal, brainstem, and cerebellum. The subtypes have to do with the surface within that type that the AVM is based upon. And those different surfaces can be lateral, medial, paramedian, basal, anterior, lateral, posterior, what have you. It really depends on the region you're in, but it's this combination of type and subtype that allows you to really categorize or classify AVMs. So as an example, these are different frontal AVMs. You have a frontal AVM that's on the lateral surface. You can have another one that's on the medial surface. You can have one that's on the basal surface. And finally, one in the sylvian surface. There's also this additional one, what I call the paramedian, which lies at the confluence of the lateral and the medial right along the sagittal sinus. So these are the 5 subtypes within that frontal type of AVM. Another example is the cerebellar AVMs. The cerebellum has 3 surfaces: the suboccipital, tentorial, and petrosal surface. And so each of these 3 has a subtype. But then there are vermian and tonsillar AVMs, giving a total of 5 different AVM subtypes in the cerebellum. The next is the breakdown of the resection steps, ranging from exposure to subarachnoid dissection, to draining vein, to feeding arteries, then going into the different phases of resection with peel dissection, parenchymal dissection, and ependymal dissection, and then finally AVM resection. Just as an example, step 4 is figuring out the feeding arteries. This slide shows that there are many different types of feeding arteries. There's the terminal feeding artery that goes right into the AVM and ends in the AVM. This is an artery that you can simply occlude. There's the transit artery that feeds the AVM through branches as it courses through or next to the AVM, but also continues distally to supply normal brain. So this is an artery that needs to be managed differently from the terminal feeder. Then there are deep perforating arteries that feed usually the white matter portions of the AVM, and there are choroidal feeders that come up through the ventricle. Lastly, there are bystander arteries that appear to feed an AVM because they're near, but they give no branches and need to be carefully protected. These distinctions are important because once you identify these arteries according to these definitions, then you treat them differently. The transit artery is dissected from distal to proximal. That way it ensures that you save the distal outflow and allows you to then work proximally, taking all of the branches that then feed the AVM. The dissection steps really can be summarized in what I call the battle plans. These allow you to take those 8 steps, superimpose them on the anatomy of the AVM, which is diagrammed here as a cube, with arrows representing the feeding arteries and the draining veins, and then you can see these different steps of the resection graphically as you go through. This is just an example of the lateral frontal AVM that's fed by feeders off of the M2 segment of the middle cerebral artery, draining into deep and superficial sylvian veins, and how by splitting the sylvian fissure to get to those feeding arteries and working from below, you can nicely dearterialize the AVM early and proceed with the resection. I wanted to focus on what I call master concepts, and these are some of the more sophisticated ideas that go beyond these basics. I think this idea of the AVM as a cube is important. The cube is shown here in this illustration with the arterial feeders represented as red arrows and the draining veins as blue arrows. And no AVM is in the shape of a cube, but it reduces these complex shapes into 6 sides, and then you can regionalize the anatomy to the different sides, and it helps you anticipate where you'll find your anatomy and also where you'll find the eloquence that you need to be careful to protect. The AVM box gets you thinking about the feeding arteries, the draining vein, and the eloquence. The feeding arteries and draining veins are diagrammed with those red and blue arrows. The eloquence is diagrammed with these color maps of critical function, and the AVM box is a way to really get all of these different elements organized conceptually as you begin your thinking about your surgical plan. The other important idea about the box is that it segregates the different dissection phases. The AVM, when it's thought of as having 6 sides, it will have a superficial or peel side. It will have 4 parenchymal sides that dig into the brain tissue. And finally, it'll have an ependymal side, which doesn't necessarily go down to the ventricle, but it gets down to the deep portion of the AVM or the tip of the cone. These different phases of dissection correlate to hippocampal region. On this next slide, you can see the cube with the feeders from PCOM, anterior carotid artery, and P2 diagrammed on that medial side of the cube, and the venous drainage going posteriorly through the basal vein of Rosenthal. When we look at the illustrations to the right, you can see how we really want to get to these feeding arteries early, so this is going to demand that we do a transsylvian exposure, an orbitozygomatic approach, to really bring us to the anterocoroidal and posterior communicating artery early on in the case. Here is the video that shows the dissection along the third nerve. The temporal lobe is to the right, the frontal lobe is to the left, and I'm dissecting along the third nerve to get that sylvian fissure split. With a little retraction, you can now see the anterocoroidal artery. This is an enormously dilated anterocoroidal artery, and as I dissect along its course, you can see the normal branches that are going upwards to supply the internal capsule and very eloquent structures, but then a larger trunk going to the AVM. As I dissect along the tentorial incisura, I come across feeders from the PCA. As you can see here, these are nicely cauterized. And this takes out these feeders at the very early points in the case. This is the division here of the draining vein. You can see the AVM has been circumscribed, and now I can remove the AVM en bloc. And this is a very straightforward resection, having dearterialized this AVM so early on. This is a nice overview showing the preservation of PCOM, preservation of anterocoroidal artery, preservation of its feeders. You can see the postoperative angiogram with a clean resection and good preservation of the anterocoroidal artery. The ependymal dissection is really sometimes the hardest part because it's so deep and difficult to see. The dissection of this side of the AVM requires some retraction on the brain, some retraction on the nidus. It can require the use of these AVM microclips, and it requires careful decision-making about getting all the way underneath the tip of the cone of the AVM and not cutting it short and leaving residual. Here's an example of a paramedian frontal AVM. You can see it's quite large, and this case is meant to show the difficulty in dissecting that deep plane. Here is our cube with the anatomy detailed and the different resection steps also detailed. Now we go to the operative video, and you can see the AVM has been circumscribed. The inferior basal surface of the AVM is exposed to the medial surface adjacent to the falx. You can see these large feeders coming in that are being cauterized and divided. More feeders here on that deep medial side of the nidus. And the AVM is really nicely dearterialized by taking these feeders. But to get those remaining feeders requires that the AVM start to roll out of the resection cavity. So here I'm mobilizing the AVM laterally. I can access this pocket of encephalomalacia that's underneath the nidus. You can see also these really dramatic dilated venous varices and venous channels. And as I mobilize the AVM, these come into view better. But also you're seeing that I'm really moving the AVM quite a bit to bring these into view, and this is the difficulty of the ependymal side. You really have to start to move the AVM, mobilize it around, and here finally, as we come across the bottom side, it all comes out and you can extract the nidus. The postoperative angiograms showing a nice result. The next concept is the use of gravity, retraction, and trajectory. On the left, with conventional thinking, we typically put the AVM on the downside. We allow gravity to open up this interhemispheric fissure for the medial frontal AVM, and it brings the AVM quite close to us. Everything's in view, and we've got a AVM that's very reachable. However, the hardest part of the dissection is getting around that lateral surface, which is shown with the star. If we are able to reverse our thinking and approach this contralaterally, this puts the AVM on the upside. As we go across the midline, we can then go over the top of the AVM, and the AVM starts to fall into our surgical corridor, which makes it much easier to get around that lateral border of the AVM. A contralateral approach puts the AVM a little bit further, but it improves our trajectory, gives us a lot of assistance with gravity retraction. Here's a side-by-side comparison of the AVM down on the left and the AVM up on the right. If you put the AVM up, you can see that you need to create that falcine window with those incisions in the falx. But if you look at the illustrations on the bottom, show how when the AVM is ipsilaterally, you end up having to pull the AVM up into the surgical corridor, which makes it more difficult to get around that lateral plane. On the opposite side, you can see how when gravity is pulling the AVM into your corridor, it makes it much easier to get around that lateral border. Here is a case example of a corpus callosum AVM. A small nidus, it drains down into septal veins and internal cerebral vein, and it's a very simple case, but it demonstrates the principle. Here is our AVM box with the anatomy. You can see our surgical steps, which involve skeletonizing the pericallosal vessels and carefully preserving those draining veins. Here is the surgical video. The patient's nose is to your right, and as we come down on the corpus callosum, you can see a very dilated pericallosal vessel, and this is skeletonization, cauterizing those small branches that come off of the pericallosal artery as they go into the AVM. Here I'm dissecting the medial border of the AVM from the corpus callosum, and you can see how the AVM is nicely dissected. Here's a draining vein crossing over, so we have to preserve that. And now I'm working on this posterior margin. I'm in the ventricle below. I'm getting deeper into the corpus callosum, and as I work my way around the nidus, you can see how this draining septal vein is coming into view. As I go more laterally, the AVM starts to fall with gravity into view, so it's making it easier for me to get around the portion of the nidus that's furthest away, this lateral border. And I'm dissecting around, I'm cutting these bands, and the AVM starts to fall into view. So this is where gravity retraction starts to help you. This is where you get this nice view of that lateral border. And now the AVM is almost completely free. As we look inside the ventricle, you'll see the septal vein here, right there. It's now blue, running down the septum, and we can cauterize the draining vein and remove the nidus at this point. So there's the draining venous pedicle, cauterized, divided, and the AVM nicely removed. Here is the postoperative angiogram showing a nice result. And for these high eloquence AVMs, sometimes full resection can be risky. And so this idea of occlusion in situ has been very useful, particularly for lesions like brainstem AVMs. The AVM nidus is dearterialized, meaning the borders are circumferentially dissected. And when the arterial input has been shut down, then the vein is occluded either with cautery or clip, so that there's this combination of dearterialization and venous occlusion, and that prevents having to dissect adjacent to these very eloquent nuclei and nerves that might result in increased morbidity. Here is a case example, not of a brainstem AVM, but one in the thalamus. It's a Spetzler-Martin grade 3 and a Lawton-Young or supplementary grade 3. You can see from the angiogram that the feeders are primarily the choroidal vessels. This will be a interhemispheric, transcallosal, transventricular approach, and this gives us perfect exposure of the nidus. Here is our video, and I'm dissecting down the interhemispheric fissure. You can see the pericallosal vessels. Here is the corpus callosum. That glistening white structure is then opened, which gets us into the lateral ventricle. And as we come down on the surface of the thalamus, you can see the tuft of the choroid plexus. You can see these dilated feeders that come through the thalamic structures itself and get to this strip of the nidus, which really is residing in the velum interpositum. So these are these transthalamic feeding arteries that are so dangerous. If these were to start bleeding out of control, they can be very difficult to regain control of, and you can end up getting into critical thalamic structures. So you'll see I dissect these very carefully. I liberally use AVM clips. Here is the posterior choroidal artery that is quite thickened. I'm cauterizing and dividing this as it's running up the choroidal fissure, and that eliminates a large portion of the blood supply. But the real hard part are these transthalamic perforators. Cautery works quite well for many of these. You can see the choroidal fissure here opening well. We have to take very good care of the fornix, which is running on the superior margin of the AVM. So as the choroidal fissure opens more widely, we come on some more of these feeders from the ACOM and lenticular striate region. You can see once again the use of these AVM microclips. And this is this process of dearterialization. I've deprived the AVM now of most of its arterial supply, and as I go deeper into the posterior velum interpositum, the draining vein is coming into view. You can see that it's darkened. This is a view into the third ventricle now. This is coming across some embolized posterior choroidal vessels. You can see the onyx within. Draining vein comes into view in the back there. So you can see that it's still a little pink, and now we have a fairly panoramic view of the draining vein. It's turned purple. When we do our icy green, the dearterialization has been significant, and it makes the venous occlusion at this point very safe. There's the vein. I'm going to close this now with an aneurysm clip. I will leave the AVM itself occluded in situ. So here is the aneurysm clip going on the vein. Now the AVM has no ability to shunt flow, and even if there's a tiny little trickle of flow that gets to the nidus, it can't shunt, so the AVM poses no threat, and the AVM is left in situ. This preserves the integrity of the thalamus, it preserves the integrity of the fornix. This is a view of the draining vein posteriorly. Here is the nidus left in situ, and you can see the use of clips, both aneurysm and AVM. Here you can see the postoperative angiogram showing a beautiful angiographic result. There are limits to what we can do in taking out AVMs. I know, speaking for myself, I've tried to push that limit and find out what that operability limit really looks like. I think for people who have become reliant on the Spetzler-Martin grading system, most have come to the conclusion that Spetzler-Martin grade 4 and 5 AVMs are beyond that operability limit. I think that for those of us who believe in additional grading and combine Spetzler-Martin grading with supplementary grading, we can even better define this operability limit with the combination of a Spetzler-Martin grade, which is shown in the pink and yellows here in this graph, with the supplementary grades, which are shown in greens and blues in the top of this graph. And what this graph is meant to show you is that the real cutoff for operability is right at 6. 6 and below are really within the operability limit and should be considered for surgery. Those that are 7 or greater are beyond the operability limit and probably ought to be treated more conservatively. Now, when you really dig into this, there are some subtypes. There are what I call 6 pluses that are technically below that threshold for operability, but these are a little bit more dangerous than the others, and these are what I would call the 6 pluses. These are the AVMs that are larger and in patients that are older. These have size scores of 3 or 2 and age scores of 3 or 2. These are ones that require some careful rethinking. On the other side of that operability limit are some grade 7s, which I call 7 minuses. These are the patients that have the smaller AVMs, the AVMs that are a 1 or a 2, or the ages that are pediatric, less than 20, or in that middle age. It's important to really define this operability limit, and those help make the best patient selection decisions possible. This is a slide on experience. I had the hypothesis that maybe the more you did AVM surgery, the better you got, and the more you could push that operability limit. But when I pooled my outcome data with Dr. Spetzler's data and looked at the rates of neurologic worsening according to these AVMs that are right at that operability limit, what I find is that the trend lines are fairly flat. The more experience that you get, it still doesn't allow you to push the limit. And I think it's a reflection of just how formidable these larger and higher grade AVMs tend to be. To conclude this talk, I've been really focusing on boxes. On the left, you see the AVM box, which is that conceptual construct for thinking about how we attack these AVMs with our battle plan. But I think one thing that we don't talk about is the black box, the neurosurgical box. And that's really all of those traits that go into defining who we are as surgeons, our judgment, our selectivity, our knowledge of anatomy, how strategic we think about these AVMs, our technical skills, our courage, our stamina, how fearless we are, how risk tolerant we are, and what kind of support we have. These are the traits that I think can really make a difference in how well we do with our results. This has been what I like to think of as a master class, and I think it's important to think of our hands, our head, and our heart. Taking out AVMs is one of the most difficult operations that we do, so we have to develop our dexterity, our touch, our technical skill. Our head is so critically important because it's the strategic thinking, the creativity, and the judgment in selecting patients that really can determine the quality of your results. And finally, heart. These are really tough cases. It takes a lot of grit to get through some of these tough ones. Some of these cases don't always go so well, and we have morbidity, we have mortality. These are the ghosts that we carry for the rest of our career. In order to overcome that, I think we always have to strive for perfection as we move forward. To conclude, intervention for unruptured brain AVMs is now considered risky in the post-Aruba era. The surgical indications, though, in my opinion, remain strong for the low-grade AVMs, those with silent hemorrhage, and those that have ruptured. I view embolization as a preoperative adjunct, not a curative intervention. I reserve radiosurgery for only those deep and high-risk AVMs that I don't think are suitable for open surgery. And I would encourage all of you to really strive and maintain excellence through careful selection, meticulous technique, and an anatomical strategic way of thinking. Thank you.
Before start my lecture, just I want to introduce about Asian Congress. So the Professor Kano is the founder of the ACNS. He's the founder, president. He is Emeritus Professor of the Fujita Health University. So his philosophy is very strong to support YNS always. So understanding of the patient and the neurosurgeon as human beings in spite of all the complexities of our world. So Dr. Sano is another my mentor. He's also the Emeritus Professor of the Fujita Health University, very skillful neurosurgeon. In the future, a giant elephant might appear, but there won't be any more mammals. Dr. Sano is the mammals of the microneurosurgery. He loves microsurgery. Almost 24 hours. So this picture is taken at the beginning, the real beginning of the Asian Congress. At the beginning, we do not use the ACNS. Neurosurgery update for young neurosurgeon in Asia, so-called NUINA. So it was 1993. Professor Kano, he invited 100 YNS from the Asian countries. For 1 week, we stayed some dormitory to study and exchange their knowledge and also the social life and culture. Professor Kano always educates not only the YNS and also the senior doctors, Dr. Beni from the Indonesia. And every 2 years we have Asian Congress. So this is one Congress which was held in Hong Kong. We invited Dr. Yashajil. He is the talking the aneurysm grouping to the audience. So this is a picture taken some Congress of the Hong Kong. Professor Ramamurthy. He is the founder of the Indian Neurosurgical Society. He joined us. He made some speech. So this is one picture which was held in Mumbai, the President Mishra. And during that time, we had a women neurosurgery. Dr. Gale and some other lady neurosurgeon from Asia gathered in Mumbai. So this is 8th Asian Congress, which was held in Malaysia, and this is a group photographs. And this is 9th ACNS. In Turkey, Professor Mehmet was the president. It's the 10th Asian Congress, which was held in Kazakhstan. So many people has gathered, especially from Russia. We had a very nice gathering. So this is 11th, which was held in Indonesia. And this is 12th ACNS. Professor Imad Khan was the president. It's supposed to be held in Saudi Arabia, but he made a good place for the meeting. It was Dubai. It was 2018. And this is 13th Asian Congress, which was held, supposed to held in Russia, Kazan. Unfortunately, COVID-19 could not make this the big event. So this Congress was cancelled, unfortunately. So this is the table. So the next one will be organized by Professor Mao In. This is the 14th ACNS in next year in Shanghai. So this is the mission statement of the ACNS is educational courses and also the training centers that we have already more than 20 now. And exchange knowledge and dissemination to many people, and also the promote global improvement in the neurosurgical care. In the other hand, we have a Asian Journal of the Neurosurgery. So this is a priority for Asian YNS, get the publication, index in PubMed, online submission, official journal of the ACNS. This was started 2005. So this is the board member of the ACNS, the journal. And also the small donation, such as the microsurgical instrument, hopefully in the future, maybe in microscope, endoscope, so on. So future direction of the ACNS, just only one word, is education for YNS. We can make increasing the number of the high-quality young neurosurgeons through Asia. So the current status, face-to-face education activity, it is quite difficult because of the COVID-19. So the travel restriction. But in the future, I think vaccinated people, the increasing, then we can make once again the in-person meetings in the world. So during this COVID-19 pandemic, duration. So we can make non-technical skill online information, such as neuroanatomy, neuroradiology, operative approaches, neurosurgical atlas, the Rosen collection, the respective journals of the neurosurgical organization. So on the other hand, the technical skill providing, such as virtual reality, such as operating the room, and also the simulation of the hands-on workshop. So as for the virtual reality, so in cranial surgery, in spinal surgery, especially the minimally invasive procedures, and also neurovascular surgery. So maybe we can show the video to the buyers and they can learn how to do step by step. As for the hands-on workshop online, so we can show them the bypass, embolectomy, intracranial stenting, and image guidance, and robotics and spinal surgery. So today just I want to share coil versus kind of clip. So the cerebral aneurysm, the result of the ISAT, which supported the use of the novel endovascular procedures for the treatment of the ruptured aneurysm. So coiling for the ruptured aneurysm, the decrease the relative risk of dependence, death, when compared with the aneurysm clipping by 7.4% at 1 year follow-up. The national inpatient sample found that between 1998 and 2007 in the US, so significant increase in the number of the treatment of ruptured aneurysm. So this is the summary of the published RCT of clipping versus coiling for ruptured aneurysm. The 3 reports. The all reports said the surgery had a bit higher, poor outcome of the patient comparing with the endovascular treatment. The further technological advancement in radiological imaging and endovascular interventions. So endovascular coiling is a minimally invasive treatment without the craniotomy. Coiling versus clipping for unruptured aneurysm. The surgical clipping resulted in lower retreatment rates and was associated with a higher incidence of the complete occlusion. No significant difference in procedure retreatment rate. So significantly shorter the stay hospital in unruptured aneurysm patients treated by endovascular coiling than in those treated with the surgical clipping. Endovascular treatment is a lower rate of the complication comparing with clipping, especially ischemia. So this is the forest plot for post-op ischemia, the coiling versus clipping. So the ischemia is much lower in the endovascular procedure. The trend of the treatment modalities in Korea, the higher cost for clipping. There was a significant increase in endovascular coiling between 2010 to 2017. So this is aneurysm clipping versus coiling. So it almost comes together, the clipping coiling in 2012 in Korea. The right side is the new devices of the endovascular treatment. So wide base and also the large type of the aneurysm, the endovascular strategy can be treated when we selected case. So the development of the new endovascular devices for aneurysm treatment. So the coiling is increasing in 2016 comparing with the clipping. And also the device assisted the coiling is also increasing in 2016. The trend of the ruptured and unruptured aneurysm, the treatment in the United States in post-ISAT era, National Inpatient Sample Analysis. So these results tell us a total of the 50% patients were treated for unruptured aneurysm, 65.3% by endovascular and 34.7% by surgically. And also the almost 50% patient underwent procedure for subsequent hemorrhage, and the 56.6% by endovascular and 43.5% by surgically. So the endovascular treatment is more than the open surgery. The trend of the ruptured aneurysm treatment in the US. So definite the coiling is increasing already the year of the 2014. The trend of ruptured aneurysm, the treatment in the US, again the same tendency. In 2014, already the coiling is much big number of the open surgery. So from here, I want to show this the flow diverter. So indication of the flow diverter. So the large giant wide neck aneurysm and the fusiform type and the recurrent aneurysm after coiling. And also the blister-like aneurysm and the failed simple coiling. The development and the indications. The 2011, the first flow diverter approved for USA use in the United States, and coilable of the failed aneurysm trial. The wide neck, large or giant aneurysm of the intracranial aneurysm from the petrosal segment to superior hypophyseal artery ophthalmic segment. But criteria extended. A small or medium wide neck, sacral or fusiform aneurysm from the petrous to the ICA terminal. So mechanism of the flow diverter stent, how they can heal of the giant or the difficult aneurysm. The central diversion, so decrease direct jet blood flow into the aneurysm and promotes laminar flow along the stent in the direction of the parent artery. Decrease wall stress and stagnant flow result in aneurysm remodeling that ultimately promotes endothelialization. So the epithelium is very important across the aneurysm neck and the arterial reconstruction. So type of the flow diverter stent. There's so many types, but recently the flow redirection endoluminal device FRED is most popular now. So this is the small technique from the Korean neurosurgery. Complications of the flow diverters. So it is reported the complication rate of the unruptured intracranial aneurysm was 14%, and on the other hand, ruptured one is 30%. Before stent opening, the 3.6%, the intracranial hemorrhage, especially the remote ICH, around 3%. The bleeding is 1.8%. Migration and poor position was 5.8%. Ischemic event, 7.5%. So overall complication rate of 17%, with a permanent mobility rate of 3.7% and mortality rate of 2.8%. So this is reported in 2017, for 5 years back. But I think mortality, it's quite rare when we do the open surgery. So the endovascular treatment is much fantastic than opening surgery, but should be very careful in case the mortality. The complication rate for a ruptured aneurysm is 14.6%, was significantly lower than that for ruptured intracranial aneurysm, which is 30.6%. So this is a variety of the flow diverter stent. The red, the recent one is lowest, or P64 is lowest complication ratio. But the other one is sometimes close to the 30%. As for the delay complication, the rupture of the aneurysm after the flow diverter treatment is rare. So this probably reflects the balance between the complete aneurysm, the thrombus formation, and the thrombosis mediated inflammatory disruption of the aneurysmal wall. The reported incidence of the delayed rupture is slightly higher with the silk flow diverter than with the pipeline. Mortality, the range from 0 to 4.6% and 0% to 20% in ruptured cases. The complication of the flow diverter. The international retrospective study of the pipeline embolization device registry, the spontaneous aneurysm rupture in 0.7% were treated with pipeline alone, but the 0% when treated with a combination of the pipeline and the coil embolization. The coil embolization and the microsurgical clipping are viable treatment options for aneurysmal subacute hemorrhage patients. The therapeutic choice for poor grade aneurysmal subacute hemorrhage should be tailored to individual patients. The trend of the endovascular treatment is popular in the current era for both of ruptured and unruptured aneurysm. So, just I want to discuss a little bit more. So this is I'm talking about unruptured aneurysm. So the shape and the rupture ratio. So if the aneurysm has a daughter sac, it's a more frequent rupture in the future. And also the size of the aneurysm. The larger one is a high frequent rupture in the future. So this is a risk factor of the enlargement and the future rupture and ruptured aneurysm. The 5-year risk of the rupture is 3.4%, and the risk factor for rupture is more than 70 years old, hypertension, history of subacute hemorrhage, And the aneurysm size is more than 7 millimeter. The location is ICPC and ACOM aneurysm. And also the geographical region, the Finland and Japan is high frequent comparing with other countries. So unruptured aneurysm, especially the small unruptured aneurysm, diameter 3 to 6 millimeter. So if the aneurysm size is more than 7 to 9 millimeter, is the rupture time is 3.5 times, and 10 to 24 millimeter 9 times, and more than 25 millimeter, so-called giant aneurysm, would be the 76 times the future rupture ratio. And also the standard protocol for aneurysm clipping at our university. So that we do the ICG video angiography before and after, and also we check the endoscope assist or check especially blind corner of the aneurysm. And also we put additional the Dopplers and also the intraoperative monitoring such as MEP. So this is how we can do put the clip for a ruptured aneurysm. At the beginning, ICG and also MEP and also the CFD and also the ICG and the endoscope. So this is a very small, the ACOM aneurysm. The CFD tell us a bit the thin wall of the aneurysm. So this is ICG, and this is endoscopic observation. This part is very thin, which indicated by CFD. Then we put the clip. So this is a IC paracrinoid, the large aneurysm. The image of the CFD, that is the wall shear stress. So this dynamic wall shear stress we can recognize. It's very important. This is a before stenting. So this is the flow. And this is after placing the stent. So the inflow lamina is become very calm and very slow and very small. And this is after the putting the flow diverter, how the inflow has been changed. So this is we can predict before surgery. So it's very, very interesting how we can put the coil, how we can put the stent. So not only for the direct surgeon, but also the endovascular surgeon. It's a very useful information. So this is the 4D image of the CT. So we can recognize the movement of the vessels. So especially this is the ruptured aneurysm. So we can estimate the rupture point with highest change of the volume of the aneurysm, the wall. And this is exact surgical field. And here is a rupture point. So we clot we can recognize. So that this 4D image is another very important to estimate the thickness of the aneurysm wall itself. The reason that we start the CFD is superimpose of the aneurysm, the cartoon. So So this is the image of the aneurysm before surgery. So it's a good practice for a young neurosurgeon, the image of the intraoperative aneurysm and the location. So this is a 4 parameter of the CFD: pressure, the streamline of the vector. So we can superimpose the surgical cartoon. This is a very popular ICPC aneurysm, and this is a temporal, this is a frontal lobe, this is the left side, this is a third nerve, and this is a second nerve. So we can make such a basic cartoon and put the color. Then we can put the CFD, the aneurysm, on the surgical cartoon. So this is a real surgical procedure, and this is the preoperative, the image of the aneurysm. So that part is corresponding, this part, the scene of the aneurysm wall. The synchronized CFD, the parameter of the aneurysm. This is the pressure, and this is the red part is a very high pressure, and this is a wall shear stress, and this is a wall shear stress vector, and this is a streamline. So I showed the two cases. So this is the left bachelor SC aneurysm patient received the right MC aneurysm with the thoracic hemorrhage and a little bit high position of the SCA aneurysm. This is a 7 millimeter. This is a flow. So we drill of the anterocranial process. Then we can make the mobilization of the internal collateral artery. Then we remove of the anterocranial process. And we can cut the dura. Then this is a patient has also the small MCA aneurysm. Then we dissect of the cerebral fissure a bit, some other adherence because of this is the second time of the surgery. Already we can see the SC aneurysm. This is the third nerve. Third nerve is over the aneurysm. This is ICG, and this part is very thin. This is MCA aneurysm, about 3 millimeters, and this is a SC aneurysm. So we dissect of the perforators, all perforators, and branch from the aneurysm dome. So now that we are ready to put the clip, so this is a vector and the pressure, the flow inside of the aneurysm. This is ICG, and also the endoscopic observation. This is the third nerve aneurysm. This is the vertebral trunk, the contralateral third nerve. We can see that this is the brainstem and the small perforators. So many the spot of the squetic change. And the aneurysm is about 7 millimeters. And after place the temporary clip, we plan to occlude the aneurysm with the 2 clips. The first clip has been applied. Then additional remnant part, we place second clip. Then a reinforcement with the Surgicel and also followed by some clip, the MC aneurysm. So this is one more case. The two big aneurysms. One is the left MCA and the ACOM aneurysm. The patient has 7 aneurysms, and this is a CFD. So high pressure, and also the vector, we recognize a diversion. This is the ACOM cartoon, and this is MCA. MCA aneurysm has the several blebs. So the red part is very high pressure, so maybe the very small. So this is skin incision, and this is the open skull. So usually, when we want to the wide surgical field, we remove the anterior process, then we can remove the IC immobilization. And this is a dissection of the interhemiscopal fissure. Already we can see the aneurysm, and this is the left A1, this is the right A1. Some part of the aneurysm is, the wall is very thin. And back to the MCA part. So this is the MCA aneurysm, has several revs, and some part is the wall is very thin. So at the beginning, just we reduce of the intra-abdominal pressure of the aneurysm, then we place the temporary clip on the both A1, and we place the initial clip, the kind of pilot clip. Then we check the ICG. There's still some small flow remnants we recognize. Then we put the second one, adjacent to the first one. So when we dissect widely of the interhemiscopal fissure and the cerebral fissure, it makes a very less reflection of the brain itself. So finally we put the clip on the MCA aneurysm. Sometimes MCA aneurysm is quite difficult because of the neck is more than 2/3 of the main trunk of the MCA. So we need some tips and idea. Sometimes you should remember the fenestrate clip. So fenestrate clip is sometimes very useful. So this is the fenestration. So normal flow in the aneurysm. So this is almost the conclusion. When we decide the indication of the aneurysm treatment, either endovascular or direct surgery, So the direct surgery, we should consider the 3D simulation, ICG video angiography, endoscope, the low high flow posture fossa, the bypass. We need some techniques and practice. And also the endoscope. And also when we do the high flow bypass, just we can check of the radial artery condition. On the other hand, is endovascular surgery that we need to study the stent-assisted flow diverter, innovated coil, and the 3D DSA technology. So many things we should know, especially the device is developing day by day. And also the patient situation, they wish to have a less invasive treatment, kind of a minimally invasive treatment. So they, for the younger generation, they should have a hybrid ability, hybrid approach. They should learn, and also they must do, and also they must do for the patient. So the bypass and the endovascular, and the suction, the compression, and also the clip and coil, the rescue treatment. The consideration issue is prevention of rupture, alleviation of the mass effect, and avoid hemodynamic compromise, avoid pulmonary injury, avoid thromboembolic complication. So clipping or sometimes strapping, so with a bypass, and stent and coil, endovascular trapping. So what is your choice? How do you decide the indication? So all refers to the your patient. So thank you for your attention.
Hello, everyone. This is Arian. I'm a former fellow of Fujita. I'm joining you today from Toronto, and I'd like to thank the organizers for extending their invitation and having me join you today. My special thanks and gratitude goes to my mentor, Professor Kato, who always been a good friend to me. Today, I'm gonna share with you some notes on a case we have been working during my fellowship at the University of Vienna. Back then, I depicted this case, and then I'll move on to share some thoughts on the basilar tip aneurysms, the anatomy, epidemiology. What makes this case special is what I would discuss throughout our presentation. This is a multiple aneurysm case. We will move on with just the first surgery, how we planned and managed the treatment of the posterior circulation basilar tip aneurysm, some data on epidemiology, anatomy, and as well including history and surgical approaches to the posterior circulation aneurysms, and some discussions and lessons I've learned throughout these fellowships in recent years with vascular surgeons. We are going to start presenting a case of a 60-year-old female who presented with a significant history of multiple risk factors for cardiovascular diseases, but as well with cardiovascular disorders. She presented about 4 years before the posterior circulation aneurysm was treated, and at the time of presentation, she was in stupor and Hunton has 3 with CT angio at the time of the admission, diagnosing an ACOM aneurysm with a fissure 4, an incidental about 4 millimeter basilar aneurysm tip on posterior circulation was discovered as well. On admission, transcranial Doppler sonography did not reveal any vasospastic activity of the anterior or posterior, anterior and midline cerebral arteries. Pre-op images, you can appreciate here actually this is a better image of aneurysm dome projected anteriorly and to the left with a superior upward images showing here the incidental finding then of the posterior circulation aneurysm on the basilar tip. Through a left-pterygium craniotomy, large part of the clot was removed, blood from the subarachnoidal space as well was removed, and 2 clips were placed on the ACOM aneurysm. The surgery was uneventful. And moving forward, we plan to manage the second aneurysm with via endovascular means. In between period of this plan and management, the first surgery, and then later on was uneventful. But here are post-op images, so you see how a nice part of the pre-op clot was removed, placing of 2 clips, excluding the aneurysm from the circulation. So what we planned was not easily to move forward because the patient was of Jehovah's Witness. She refused every possible surgical treatment that would include blood, but accepted only cell-saving backup. And when these cases come, they are strange and challenging to every step. In a 4-year period of follow-up, the aneurysm dome was growing, the basilar aneurysm tip. So what we thought would be nicely approached via endovascular means, you can here see how the aneurysm is growing in a 4-year window from the clipping of ACOM aneurysm. That was not the case in our case. So aneurysmal subarachnoidal hemorrhage continues to have high rates of morbidity, both morbidity and mortality, and that's despite the advancements in medical and surgical strategies. Multiple aneurysms in your surgical career would be present in about 33% of all SAH cases, and that of the basilar tip are going to be about up to 8% of the cases. Size is no longer relevant. It is always clinic that determines how to move forward and when to move forward with surgical treatment or endovascular treatment of aneurysms, especially those of the posterior circulation. We used to thought, and I remember very nice work done by Dr. Ladignam Shekhar back then, and several works conducted back around 2008 and 2010, and with some highlights pointed out from Dr. Juha Hernesniemi, that the size is no longer the case. Throughout his work and series, previous surgeons thought the 7mm cutoff to be that line in between clip or endovascular treat or let it stay. Let it be was no longer the case. You treat aneurysms, and you make sure that you choose the right approach, that being surgery on endovascular means. With multiple aneurysms, the risk of bleeding is higher, both that being annual, cumulative, or individual rates per aneurysm. The anatomy of basilar artery remains the most challenging. It is consuming, and it's going to be so rightfully. This area is one with the highest density of the neurovascular structures per volume. As you can see, both the tip and the trunk are nested in between vital structures, surrounded by an array, a nest of vascular structures, standing nicely, resting posterior to clivus, anteriorly to diencephalic and under diencephalic structures, making it a challenge for the best of vascular surgeons to reach, approach, and treat those lesions. History has had it that the work started quite early, and it remains on the shoulders of those giants who have been helping us to move forward and how to approach those aneurysms, with Dr. Charles Drake from early 60s moving on throughout his career, an enormous work in how to treat basilar aneurysms. It was from him that we have the subtemporal approach, followed by Professor Yashargil's work with both the pteryneal approach and supracerebellar transtentolar approach, an amazing approach to both posterior part of the temporal lobe and posteriorly located lesions. And Kenji Sano in 80s introduced us with temporal polar approach. If you want to expand on your anatomy around the tip, Professor Dolenz in 87 with one of his fellows, Dr. Morina, currently the chief of neurosurgery at the Department of Neurosurgery at the University of Pristina in Kosovo, they introduced us with a transcavernous transcellular approach, a modified pteryneal approach, a work later expanded by Professor Krisht in Little Rock, Arkansas, one of the students and fellows of Dr. Dolenz, but remains again to be pointed out that the what we call half and half approach goes married to Professor Charles Drake in 1996, later, a paper published by him. Here's a layout of how you can reach the basilar aneurysm tip with two main approaches, pteryneal, subtemporal, and then how to expand in and around that region. Nicely laid steps here from the work of those giants. What we planned and how we managed to treat their aneurysms was not how it went through. So, studying the angio before the second surgery and using some knowledge of the anatomy, with the left P1 projecting inferiorly with the aneurysm sac of the basilar aneurysm tip, which was upward and posteriorly, we thought that we can still use the left pteryneal approach to reach there. But it was a challenge because dissecting the intercarotid oculomotor arachnoid planes was not practical. We had in our way two clips from the previous surgery and then some scarring of the arachnoid tissue from that very same surgery. So what we thought would be best is to use that approach, left pteryneal, but we go via supracarotid trajectory, and we identified and nicely clipped and excluded from the circulation a thin-walled aneurysm, just to confirm that aneurysm never stopped growing. So you have to be careful when you decide why not to treat an aneurysm that is there, that you have been identifying, either they being incidentally or through clinic. Our aneurysm, as it is in most cases of posterior circulation, and especially of the basilar tip aneurysms, was bilobular. And we made sure that the diencephalic, as it is the case in all surgeries of the posterior circulation, the encephalic perforators were dissected and were kept safe from clipping. We used endoscopy to assist us into confirming the safe tines clipped around the dome, but keeping the diencephalic perforator safe. I'll mention these throughout the videos and the recording. These are technical notes of how to approach and how to get there. As I mentioned, we had knowledge of the angio showing us how the P1 was projecting inferiorly, and the aneurysm sac was upward and posteriorly. So it was shown that the aneurysm morphology was a wide neck, bilobed. We used the same approach to get there. And once you open the Sylvian fissure, what you realize is the anatomy becomes readily available to you. I mentioned that we chose to approach the basilar aneurysm via supracarotid trajectory because the previous plans, intercarotid oculomotor approaches were scarred from the previous surgery. So once you have exposed the ICA, and you make sure to spend time into exposing that, you spend time into dissecting the arachnoid planes. As you can see, there is scarring in our case, but carefully removing those scars, coming around both the ICA and in between ICA and the second cranial nerve. You make space for you to get to the posterior circulation. Notes that I've had through fellowships that I've attended during vascular training is you follow anterior choroidal artery back. It opens this space of Lilliquist membrane, the arachnoid membrane separating the chiasmatic cistern and the interpeduncular cistern and prepontine cistern, which gives you the opportunities just by sucker and instrumentation without any brain retraction for you to get where you want and safely dissect the perforators. You direct your attention toward the ipsilateral. Once you have dissected through ICA and second cranial nerve to identify ACA, PCA on the same side, but as you expand the dissection of the arachnoid planes, you can have yourself visualize the ACA ipsilateral, and if you want to move on more posterior with the dissection, you can visualize the contralateral one. Here we are, safe clipping, endoscopy assistance. You see that the diencephalic perforators are safe, excluding the aneurysms and keeping those patent. Once you confirm that the neck is completely free from the interpeduncular vessels, the diencephalic perforators, you are safe, the aneurysms is safe, is excluded. But remember, if those perforators are caught in the clip, you identify, even without the means of endoscopy assistance or intraoperative angio, you can still do so once you expose the planes of arachnoid safe out of the aneurysm dome. You put your clip again, and you can come back. You remove the clip. You confirm that you are safe of keeping patent the diencephalic perforators, and then you put the clip to make sure that there is no morbidities related to what you are supposed to have as surgery. Here is the aneurysm excluded from the circulation. Once again, pointing out the nested lesion within an array of vital structures that you want to keep patent and safe. First surgery on the left slide, second surgery on the right slide. Discussions of side points that I've learned throughout my training is that high risk of rupture is associated with posterior circulation aneurysms. And the size, I want to point out, is irrelevant. It is the clinic. Once you have identified these incidental findings, and I remember from a short period of observation I had during the time that Professor Hernesiemi was the head of neurosurgery in Helsinki, he would clip those, even the small, tiny ones. He would exclude those from the circulations. Usually the posterior ones have daughter sacs, those small parents artery that come in and out because the anatomy on the corridors are so small. The aneurysm dome, as it expands, it gets into the way of the P1 perforators, ipsilateral or contralateral. Why wait? Treat the size is no longer a cutoff, what we used to think that it was so the case. What is the goal of treatment is that you balance natural history of aneurysm growth. It is never going to stop growing once it gets into its way, and those of the treatment-related adverse outcomes, as it was the case with our surgery. Dr. Gruber is a well-renowned, highly skillful vascular surgeon with dual training, open and endovascular surgeon. So we had both means in our hands to treat endovascular, but coiling is a challenge, and especially so with the aneurysms of the posterior circulation. And the coiling depends on the shape of the aneurysm's location. In our case, we deferred endovascular means due to the morphology, wide-based aneurysm, bilobed, perforators coming very close from the P1s at the junction. Aneurysm itself, risk of rupture is about 8%. work has been published on that. And basilar aneurysm clipping, in our case, as might have been was complicated by the presence of the 2 clips from the previous surgery. So in your work, and if throughout the practice you have to happen to find 2 aneurysms, multiple aneurysms, and as I've seen throughout the practice, when I attended my fellowship with Dr. Gruber, with Dr. Sano, Professor Kato as well had her experiences using 1 surgery clipping 2 aneurysms. It is logical to do so, and the logic has it that you choose to clip the most distant aneurysm. You can use 1 craniotomy when it's possible, and you can use the same craniotomy to clip contralateral on the opposite side. Work has been done. Professor Sano has work published. Professor Gruber, from his experience back in Vienna and then now at Linz University, has work conducted. So has Professor Spetzler, so has Professor Kato and Professor Lawton, with whom I have attended extended times of fellowship in vascular surgery. You choose to clip the most challenging, the distant aneurysm, have the clips out of your path, and then you come back to the closest to the craniotomy aneurysm. If both aneurysms were present at the same time in our case, excluding the fact that it was incidentally formed, it was logical to choose to clip the basilar aneurysm tip first and then moving with the anterior communicating artery first. And I've seen this done throughout the years of my fellowship. I remember cases, late night hours of work at Fujita with Professor Kader, relentlessly so, working through the anatomy, dissecting those planes, clipping the most distant ones, and then moving so to the closest one. So was Professor Sano's work. Lessons I learned from those masters that I've had the opportunity and the blessing and the gratitude to attend their work in vascular surgery. But I'll start with most recent one at Barrow with Professor Lawton. Advice is to study the case in advance and be redundant. It's never enough to study the anatomy because not 2 aneurysm domes are the same. As the aneurysm grows, it pulls with it, especially the posterior circulation, the encephalic arteries, which come into the way of your surgery. So do when you are treating those endovascularly. And I want to point out, as those seminars are directed toward the limited resources countries, not every clinic has the opportunity to conduct an endoscopic assistance clipping during the surgery or having the means of angiography intraoperatively, which was the practice with Professor Lawton or Professor Sano or Professor Kato. We would redundantly use angio during the surgery, but not in limited resources countries. If you know the anatomy, visualize it. Have your 3D planes before you go into the surgery. You have your surgical field, the corridors that you are going through, the planes of your surgery nicely drawn. So was the case with Professor San. I would never forget, and I have built on some files from his work. He would visualize the anatomy before its surgery. You choose the right approach, either that being for 1 aneurysm or 2 aneurysms, as recently published by Professor Lawton, a work of Professor Sano as well, and work of Professor Kato and Professor Gruber. Vascular surgery is here to stay, and the vascular is going to advance, but there are going to be cases where you would need your skills sharpened and keep those skills sharp. And you can do that by practicing, by knowing your anatomy, having the images of your case in your head as you move and advance with your approach. And what I've learned from some notes I've had from Professor Spetzler and from Professor Kato, you do not hesitate to stop the procedure. And I've seen this throughout my fellowship and time with them. I've seen them remove the eyes from the microscope, turn their head to see the anatomy that was present in the planes of the image, visualize it, and come back to trying to find the right and the safest approach. You're never enough redundant in visualizing your anatomy. See where the aneurysm stands once you have dissected the planes of the arachnoids, and where are those perforators coming off, which at times those are pulled out, back, forward from the aneurysm dome. You don't need a retractor. Most of the cases you would need your sucker and the instrumentation just to make way through your planes and use those to navigate through the anatomy to get you to the aneurysm. And what I've learned, something that stands and it's always going to be there, if you are not confident, you can always back up from that surgery. And what I remember in those private conversations when I was recently speaking to Professor Spetzler and Professor Vaikoti, the head of department in Berlin, back then they had to use knowledge of what was published, and that was limited. Today we have the opportunity of those, and I've pointed out some references with video recordings of operative techniques, not only for the anterior but as well posterior circulation aneurysms, how to approach and how to get there. And you have never enough redundancy into getting into those cases because consuming is always going to get into your way. Those are some cases I have kept safe from work when I was at Fujita with Professor Sano and Professor Kato, how nicely they have visualized the anatomy before each case, coming with the perforators, how the perforators would get into your way. I'm going to show here just a couple of here. Here is the dome of aneurysms, how the perforators have been pulled back with the dome of aneurysm. This is a multiple aneurysm case treated with one surgery. Professor Sano was so detailed, and I remember that being the case with any of those masters of surgery that I mentioned. They would come with the right clip before the surgery. They knew which size to use. So was the case with Professor Loden, which I've witnessed personally, with Professor Gruber, with Professor Kato. They knew what clip to use, how to use it, as you can see here. And here is another example of how to get your perforators out of your way and clip the dome of aneurysm. Use one surgery, one possible. Know the size of the clip right, what are you going to use and how are you going to use it. Lessons learned that are going to stay here with me, and I thought of sharing with you. Those aneurysms are consuming. The knowledge is never enough. This is a word that I wanted to share with you. I've been having these discussions with Professor Loden. He published a series of cases of challenging aneurysms of basilar artery. Started with his series when he was the head of vascular surgery at the University of California in San Francisco. We discussed that work when I was attending a fellowship at Barrow. Here are some notes of a work that is under patent that we are currently conducting in what we call the continuous flow bypass. I remember from Professor Sano and Professor Kato when I was back at Fujita, it was my first fellowship in vascular surgery, that tried to stay with clipping and excluding temporary clipping of vascular anatomy to stay under 9 minutes. That's not the case. Always, sometimes with the basilar artery vasculature, you have to stay under that and always clip and release, and you have to exclude some of those perforators from your way so you can move with aneurysms, clipping, and keep it safe. But the point is that you need to stop blood flow. Sometimes you have to remove it from your way. And what we thought is, how can we come up with a technique that would allow you to manipulate, keep the vasculature pattern while you are conducting the bypass, where you are suturing the ends of the anastomosis. And that's why we decided to call it continuous flow bypass. We'll be very happy to share with you further notes as we move forward with the work. A list of references, which is never enough, is shown here. Basilar aneurysms remain a challenge. The work is consuming. I started here with Professor Drake, and as I move forward, more recently I read work from some series published from Professor Kato, nicely so, publishing how to approach basilar aneurysms, and I've pointed here work from Professor Gruber. I want to point out how important it is to have your knowledge always up to date, your skills kept sharp, because open vascular surgery is here to stay despite the advancements of endovascular. And I speak from the point of view of masters in both fields. I owe an enormous amount of gratitude to both this man, Professor Knoss, back then was the head of the Department of Neurosurgery at the University of Vienna in Austria, and Professor Gruber, a dear mentor to me and friend who is a duly trained open vascular and endovascular surgeon, with whom I thought very often, how can you have both skills, open and endovascular, and still be unbiased when you decide to choose which is the best approach for your patient? And you can do rightfully so, because if you know your anatomy, you choose the decision, you make the decisions right, you choose the approach right, and you know which one is the best approach. And with this in mind, I wanted to thank you for having me here today. It has always been a pleasure to join you guys, and I wish you the very best and hope to meet you soon in person. And until then, all in good health. I want to say hi and bye from Toronto and hope to meet you soon. Thanks.
Greetings, everyone. First of all, I would like to welcome you and also to thank Professor Yoko Kato for the opportunity to be here. It's a great honor for me to be in this seminar and among such giants in neurosurgery. So today I'm going to talk about transient cardiac arrest induced by adenosine during aneurysm surgery. So first of all, a little bit of my background. I'm originally from Venezuela, where I did my medical studies and neurosurgical training. And then after that, I have been working all around the world. And now my current workplace is Zhengzhou, Henan province in China. So I work at the Henan Provincial People Hospital. And one of the important things here in Henan is that the population is around 100 million inhabitants. So I had nothing to disclose. And I'm just going to begin my talk with something that all of us we know and something that we're very familiar. And it's just going to show you one example of the clipping of a middle cerebral artery aneurysm. You can see here is an MCA bifurcation aneurysm here. And I'm just showing the steps of normal clipping, just exposing the aneurysm down. Now we have here the frontal branch of the M2. Then behind the aneurysm dome, we have the temporal branch. And I'm just trying to dissect this perforator that's on top of the aneurysm. And we know for that we had to find the M1 segment just to secure proximal control. And this normally we do with temporary clipping. Here we can see here the M1 segment of the middle cerebral artery. And you can see it's a very good vessel, no calcification, no atheroma. So we can place a temporary clip quite easily and then try to clip this aneurysm. So I place a clip just to dissect the perforator and to try to get enough space to put my pilot clip around the aneurysm. So you can hear, you can see it that it's just clipping the aneurysm under temporary clipping, and then after that just remove the temporary clip and then check whether if we have any remnant or if we compromise any vessels. So this is something we're very familiar. And then if we talk a little bit of temporary clipping, we know it's a well-known technique, and this we had seen, it has been used for a very long time. It can be frequently used, and it depends on surgeons. For example, in our center, we normally use temporary clipping when possible. However, as I mentioned before, it depends on the surgeons. I have been working in other places where the surgeons, they prefer to do just straight clipping instead of putting or placing a temporary clip. And one of the important things with this temporary clipping is it's simple, and it allowed us to have a complete isolation of the aneurysm, and it decreased and it softened the aneurysm, so we can place our pilot clip or final clip. However, it depends on several factors, and these factors are, or we know that they are, for example, here on the left side we have a internal carotid artery, but you can see it has many calcifications. So placing a temporary clip here is dangerous because we can break the vessel, or if it has atheroma, we can cause thrombosis because of embolus going. Also, we know it's difficult to place a temporary clip, for example, in a contralateral approach because it's a deep and narrow surgical corridor, or, for example, sometimes it's not possible to achieve proximal control on basilar artery to clip in an aneurysm because of the approach and so on. But one of the most frequent scenarios that we can have is this: when you have a completely red field, and it means like you're dissecting your aneurysm, and then suddenly, unexpected, you have a rupture or intraoperative rupture, and then you have a field complete full of blood. And in those cases that you don't have a temporary clipping, or you don't have proximal control what to do, either you try to compress the neck or to try to place a cottonoid and so on. So in these particular cases, adenosine comes very handy to use. So if we talk a little bit of adenosine, we know adenosine is just an endogenous purine nucleoside, which has a very short plasmatic life of around 20 seconds. So what are the effects of adenosine into the heart? So it causes negative chronotropic and thrombostropic effects. It means it decreases the heart rate, and also it decreases the transmission of the impulse from the sinoatrial nodes to the atrial ventricular nodes. So it decreases the conduction, the electricity conduction. And we know adenosine has been used previously in cardiac surgery, and also it has been used previously in embolization of arteriovenous malformations. So what are the indications to use transient cardiac arrest induced by adenosine? So the indications, as I showed you before, are small and deep surgical corridors where you cannot place a temporary clip, and we'll see along the talk. Also, when you cannot obtain proximal control, and this is what we call total control. When you give adenosine, then you have completely asystole or completely transient cardiac arrest, then it allows you to have some total control. And as I mentioned before, basilar artery aneurysms, complex aneurysms, or during intraoperative ruptures. And also, as I mentioned before, during contralateral approach aneurysms. And this is something that we have published some time ago when to use it. There are several publications regarding adenosine and its effects, also what is used intraoperatively and during aneurysm rupture and so on. This is just to show you some of the publications that have been in the literature. So what is the technique? This is something very important. You have to have a close collaboration with your anesthesiologist and talk beforehand whether you can use adenosine or not. So one of the contraindications when to use adenosine is patients where they have asthma or they suffer asthma, and when they have coronary cardiac disease. Those are the two contraindications. And the technique is very simple. This is just to show you one case. This is the left side ophthalmic artery aneurysm, very small. You can see we did it through a contralateral approach. This was done by Professor Hernesniemi, the regular lateral supraorbital approach. And this is just the regular craniotomy of around 4 centimeters. And you can see that the brain is very slack, and all the work here is done subfrontally. So we can see here the right optic nerve. And when you go through the contralateral approach, especially to the ophthalmic artery aneurysms, this pathway is extremely important. And this is the interoctave pathway or the prechiasmatic pathway, because this is where you have the space to expose the aneurysm and also to place your clip. So here that is coming close to the aneurysm. So we can see here the aneurysm neck here, and just coagulating a little bit the dura to achieve 2 or 3 millimeters space that you can place the blades of the clipping. And you can see here, just exposing the neck with your dissector, getting a pilot clip. So in this case, it's very difficult to have proximal control. So this is why we use adenosine. So in this moment, we just place the blades of the aneurysm clip close to the aneurysm neck, and then we talk to the anesthesiologist to give adenosine. And you can see here, once it's given the adenosine, it goes bradycardia and complete asystole. So at this moment, the aneurysm has no pressure. It's like what we call total control. So it's a very soft aneurysm, and this moment you can finish putting your clip. You can see Professor Hernes' name is placing the clip now. And then after the aneurysm has been clipped, you can see how the heart rate returns to normal baseline parameters. So this gives you around 20 to 40 seconds of transient cardiac arrest. And this is just showing you ICG that the carotid is filling, and that was the clipping. So we had talked about the indications of adenosine. So if we go a little bit of the literature review, we can see when it's used during intraoperative aneurysm rupture. So one of the first publications of its use in neurosurgery, it was published by Teemu Lohstarainen in Helsinki. So they combine or they study adenosine administration during intraoperative rupture, and they collected patients for 2 hospitals during the time of 2003 to 2008, and they identified 16 patients. And you can see 12 of these patients received 1 single dose of adenosine, and 6 patients received multiple doses. But one of the important things that we had to notice is here that all of them, they return to sinus rhythm, and also they have normal tension after adenosine administration. And what they conclude here is that adenosine did not have any effects on outcome over the patient of the outcome. So if we talk, we already had seen that it does not affect the patient's outcome during intraoperative aneurysm rupture. So what about elective clipping during the contralateral approach? This is from our series, and you can see here, preoperative, all our patients, they have a normal ECG. There was no arrhythmias before surgery, and also after surgery, there was no arrhythmia either. You can see, as similar to the previous publications, you can administer adenosine in a single or multiple doses. It depends how many times you need it. Or if you have an unexpected event, for example, intraoperative rupture, and you cannot manage, you can give the adenosine, try to put the temporary clip, control the bleeding. Once you cannot do this, try to make some compression, wait that the patient recovers to the baseline parameters, and then give adenosine again. So what were the characteristics that we identified in our series? You can see that the median dose was 22.5 milligrams. So the dose that we have given to the patients is 0.2 to 0.3 milligrams per kilogram. You can see the range is between 5 to 50 milligrams. However, there are some patients where you administer adenosine and you don't obtain completely asystole, you just obtain hypotension. In those cases, you have to increase your dose. But what is important here that we had an asystole time of 20 to 40 seconds. And you can see here also that it's important that your blood pressure before administration and after administration during the first 5 minutes is some hypotension. However, after 5 to 10 minutes, they return to the baseline parameters, whether the heart rate goes completely back towards normal after or during the first 5 minutes of administrations. So we can see here in patients that were treated electively during aneurysm clipping in our series, none of them, they have a different outcome. All of them, they have good outcome postoperatively at 3 months and 1 year follow-up. And you can see none of the patients underwent measurement of troponin T levels because there was no not abnormal postoperative ECG or any clinical signs of cardiac complications. So those were our cases or our studies, but we can also review some of the literature. And this is one paper from 2013, where they include around 400 patients. And you can see here, they wanted to compare neurological outcome and cardiac outcome in patients that receive adenosine versus patients that did not receive adenosine. So you can see there was no statistically significant difference between the two groups regarding neurological outcome, regarding cardiac outcome. There was no difference. So we can conclude based on this that it does not cause cardiac complications related to outcome, and also it does not affect neurological outcome. So there's another publication from 2018, also from the Helsinki group, where they compared cardiac arrest induced by adenosine versus temporary clipping. And they collected 65 patients, each group, so 130 patients. So group A has transient cardiac arrest induced by adenosine plus temporary clipping, and group B includes only patients with temporary clipping. And you can see there is no significant difference between demographic of both groups during the clipping of intracranial aneurysms. But what is important is that shows what were our indications at the beginning. So adenosine was given to the patients just to avoid stem cell bone work for temporary clipping, to replace temporary clipping in patients with atherosclerosis or small aneurysms that could be prone to rupture, to minimize dissection, or for patients with contralateral approach, or to combine or supplement temporary clipping. So what is important from this study is that you can see here that between the two groups, there was a significant difference or significant reduction when you use adenosine or transient cardiac induced adenosine on the temporary clipping time. You can see group A has a 2 minutes plus minus 0.27 seconds temporary clipping time, whether compared to the group B that it was only temporary clipping, it was 4.46 plus minus 0.35 seconds. And also what is important, it decreased the numbers of temporary clipping. And this was significantly important or statistically significant. And also it decreased the mean time for every episode of temporary clipping. So you can see adenosine, it decreased your temporary clipping time, and also it decreased the time that you place a temporary clip. So based on this, we can say that adenosine has some potentials, or transient cardiac arrest during intraoperative or during intracranial aneurysm surgery has some potentials. First of all, it gives us transient cerebral blood flow detention, which returns spontaneously to baseline circulation parameters. And this is because adenosine, as we remember, has a very short plasmatic life. So we don't need to give any drugs to go back to our baseline parameters. We had seen this in our video and also in several studies. And also we had seen that we can give adenosine multiple doses. I think in our series, we had a patient that received 6 times adenosine. But it also allows us to have a systole time for 20 to 40 seconds. So this is very important to remember, because it allows you to have some time to manage some unexpected situation. So once we talk about clinical outcome, we can say that adenosine does not worsen neurological outcome. We had seen that with several papers, and it does not cause permanent cardiac complications. So there's a big review or big paper with around 400 patients that show no difference. However, what is important is to have a proper selection of the patient, and it means talk to your anesthesiologist first, because he's the one who's giving the adenosine. And they need to know beforehand whether they can give the adenosine or administer the adenosine or not. And as I mentioned, contraindications for adenosine use are coronary ischemic disease and asthma. This just to show you the literature with several publications that it has been widely used. So just to remind you this, if we have a systole time between 20 to 40 seconds, this is enough for you to try to manage unexpected situations. For example, you have a intraperitoneal rupture and you cannot control any bleeding and so on, and you're desperate, you cannot place your temporary clipping because you have the carotid artery full of calcifications or atheromas. So the question is 20 to 40 seconds enough? We have to think that is enough in case to save these situations, because if this person can run 100 meters in less than 10 seconds, then 20 to 40 seconds is a lot of time for us. So thank you very much again for the opportunity to be here and to share some of our thoughts about adenosine use. Thank you.
Hello, ladies and gentlemen. This is Chunfu Lin. I'm a neurosurgeon from Taipei Veterans General Hospital, Taiwan. First of all, I would like to thank the organizing committee for giving me the honor to present surgical treatment of AVM and the chronic encapsulated expanding hematoma after gamma knife radial surgery. I have no conflict of interest to declare, and this is where I'm from. I'm from Taiwan, Taipei. Our hospital is located in Taipei City in the northern part of Taiwan, and we are one of the largest training centers here in Taiwan. As I was requested to make a brief introduction of myself, my main training background is based in Taipei Veterans General Hospital, which I am working now. And I did a clinical fellowship in Chicago, USA, and then UCSF, and finally in National Epilepsy Center in Shizuoka, Japan. So my main field of interest, as you can see from my training background, is mainly epilepsy surgery and cerebrovascular surgery, especially focusing on arterial venous malformation and bypass and aneurysm surgeries. And also I do brain tumor surgeries. These are my mentors, Professor Charbel in University of Illinois in USA. And also, while I was there, I learned from Professor Amin Hanjani also. And in 2009, I went to San Francisco, UCSF, while Professor Lawton was still there, and learned very much from him. Finally, I visited Shizuoka Epilepsy Center and followed Professor Inoue and also the neurosurgeon Professor Baba there. And that completed my training. While I was in Japan, I took the liberty of conquering Mount Fuji. And you can see that I was in very bad situation after struggling to the top of the mountain. And my situation is like Taiwan. Since last month, we are having an outbreak of COVID-19. And while we were very much deficient of vaccines. So on behalf of Taiwanese people, I would like to thank Japanese government and Japanese friends for helping us acquire coronavirus vaccine. Thank you. And we're now in the pandemic era. So that's why we're having webinars instead of getting together. I think, and I'm confident that we will win finally, but it's just a matter of time. I hope we can conquer this disease as early as possible. This is Taipei City, beautiful urban and suburban area. And this is Taiwan, the beautiful 101 building. I hope that after pandemic, we can get together. You're always welcome to visit Taiwan. And back to our topic. Today, I would like to talk about, firstly, cerebral AVM and its treatment options. Some of the content might have been covered by Professor Kato. And so I will focus mainly on surgery of post-gamma knife complications, especially chronic encapsulated expanding hematoma. Brain AVM, as most of you must have known, it's a congenital arteriovenous shunt. It includes feeding artery, nidus, and sometimes intranidal or flow-related aneurysms, and also drainage veins from artery to nidus to drainage vein. And there are some hypotheses of its pathogenesis, but I think that's not what we're going to cover today. And you can see from this beautiful illustration from Mayo Clinic, the normal structure includes capillary network, but AVM, it lacks capillary network. So the high pressure of the arterial blood caused the venous or nidus part to enlarge, which caused a later problem. The basic knowledge of cerebral AVM, I think we don't need to cover that too much. For the treatment options, first is surgery. It's been traditionally a main treatment initially, and it offers immediate elimination of the risk of rebleeding. And it's quick decompression in the case of ruptured AVM. And it might also improve seizure control. But the problem is that surgery removes the AVM, the AV shunts immediately. So we might encounter some hemodynamic change, which may cause normal perfusion pressure breakthrough. And nowadays, it's more and more common to do radial surgery for AVM. It can be performed on outpatient basis. It's less invasive. It causes a gradual reduction of AVM flow, which itself may be beneficial for the patients, so that doesn't cause too much hemodynamic change. But in some cases, we may require multiple procedures. And we need to wait until the complete of the duration of AVM occurs, which might be a couple of years after treatment. So the risk of rebleeding still remains before complete obliteration. And the other concern is that we are seeing more and more emerging late complications, which is what I'm going to cover later. And the third modality of treatment is embolization. And in my opinion, is usually reserved as a tool to facilitate surgery or radial surgery to do flow reduction. And although primary treatment is considered, but we have to be very cautious, especially after Aruba trial. And of course, there is always an option of observation only. But I personally don't like this option unless the patient is really asymptomatic and the AVM doesn't show any high risk factor. As for neurosurgeons, we think we consider treatment. Spectrum-Martin grading is always an initial tool of assessment so that we can assess the risk of the patients going through surgery. Size and eloquence and the venous drainage patterns. I think most of us are very familiar with this. And my mentor, Professor Lawton, later adds supplementary grading scale, which in combination forms the combined grade. As you can see, for combined grade 6 or below, the risk of improvement, risk of deterioration is really low, and most patients improve or at least unchanged. So that is probably one of the reference for our choosing for us to choose the patients. And the factors in consideration of treatment, of course, size and eloquence or not. And small size or non-eloquent location usually favors surgery. For large cases, either microsurgical resection in combination with the embolization or gamma knife treatment may be considered. And for treatment options, we need to consider AVM itself and the patient factor, whether the patient is really prepared or requires immediate cure, and also the surgeon experience and the institute's facility. So mostly for lower grade, Spitz-Martin grade 1 and 2, surgery is suggested first. For Spitz-Martin grade 3 and young patients, especially female considering childbirth, and then surgery would also be considered first. Spitz-Martin grade 4 and 5, in cases of hemorrhage with mass effect, surgery is also considered. Combination grade 6 or less favors surgery. And large AVM, then we need to do a very detailed consideration and discussion with the patient. My personal experience with AVM, either ruptured or unruptured. Mostly ruptured cases, and mostly grade 1 to 3 in Spitz-Martin grade scale. And if we consider that by combined score, mostly 6 or less, some cases 7, but never higher grade cases. And if we look at the pre and post-op MRS, you can see that above this line, these patients remain the same or improved. All of my cases, except one case that had mortality, improved. And most cases improved except one case, mortality. This patient is AVM with multiple aneurysms. We resected AVM and clipped one aneurysm, but the other aneurysm bled before we could proceed with staged treatment. So if we look at Aruba eligible cases, which is unruptured AVM, and then we can see all cases remain the same or mostly improved. So I think we should look at Aruba data carefully, because in my experience, most cases improved if we selected a case carefully. As for the second topic, the post-gamma knife treated complications. Gamma knife was first performed by Dr. Lexell on patient treatment in 1967. And in Taipei Veterans General Hospital, our pioneer is Professor Hongqi Pan. Dr. Pan went to Karolinska and brings back the gamma knife treatment concept, and also started treatment in 1993. We experienced many different models of gamma knife, and then finally came to perfection type. And you can see that as initially the case grows rapidly, but as there is more and more gamma knife machines available in other institutes, the case started to decline a little bit. But after Aruba trial, the case declines significantly. And also, if we look at the data, complete obliteration could be easily achieved in cases with small volume AVM. But in larger volume AVM, the complete obliteration rates declines. So volume is one of the predisposing factor. But as the volume grows or as the dose increase, we might also encounter some late complications. For cases with post-radial surgical rebleeding in a later stage, let's 0.6%. And in also similar proportion of patients, we might encounter cyst formation, which might occur years after treatment. Also, a later case might have a progressive vasogenic edema, which might also be related to our main topic today, chronic encapsulated in expanding hematoma, which is about less than 1% of cases, but it may develop many years after treatment. So this is a picture of the complications we might have after AVM radiosurgery. And chronic encapsulated expanding hematoma, also known as chronic encapsulated intracerebral hematoma, CEIH or CEEH. Also, I like Professor Carson's proposal of naming it pseudocarcinoma, because the characteristic is really a little bit like carcinoma, but it's not a tumorous new growth, but rather a post-radiation effect. And in their experience, it's male predominance, high frequency if basal ganglia is involved, and the longer interval from radiosurgery to development of CEIH, and high rates if there is residual nidus. And in the hematoma around the in the pseudocarcinoma, they found high concentration of VEGF, and pathologically it's composed of fibrinous deposit, irregular compressed capillary channels with some neovascularization-like channels. I will show you a couple of cases that we have. The first one is a 49-year-old male that comes with headache, dizziness, blurring of vision, left occipital AVM 50 milliliter. He received a gamma knife treatment in 2013. 3 years later, complete obliteration was confirmed by DSI. However, 6 years after gamma knife treatment, he started to have some symptoms of headache, dizziness, and also deterioration of the remaining vision, because he already has a right hemianopsia after initial presentation. That years later, the situation worsens. The cyst enlarged, also with some intracystic hemorrhage and progression of edema. So he came into our clinic for help. We did surgery in last year, and the patient was put on park bench position. This is a superior sagittal sinus and transverse sinus and the left occipital lobe. And because it's already confirmed to be completely obliterated, so the surgery may not look like usual AVM surgery. It's actually like resecting a cavernous malformation. The main part of it is actually like cavernous malformation, hard and not so bloody. And we found the drainage vein, previous drainage vein, which was already obliterated here. And then finally resected the main part of it. And also by resecting it, we unroofed all the cystic part, drained the cystic part. We can jump a little bit through it. After final removal, we must also remember to unroof all the cystic part, to open the cystic part, so that the patients may get its problem solved. That's after treatment, because the patient already have right hemianopsia, so there's no new deficit, and the cavity of resection remains, and we can see that the edema improved and the hemorrhagic cyst is removed. The midline shift also improved. That's the gradual progression on image. And this is the cavernoma. Pseudocarcinoma itself is about 4 centimeter post-resection image. And pathologically, it comprised of brain tissue that appears as radiation change. The vessel walls are thickened or obliterated, and there is leakage of protein-rich material from the vessels. And you can see some extravasation and also organizing hematoma in the resected part. Post-resection, no new deficit and headache resolved, so the patient improved well. The second case, a 47-year-old male having a AVM at left frontal region. He received gamma knife treatment in 2009. And this is the DSA on planning. So complete obliteration was noted 3 years later. But 9 years later, after gamma knife treatment, the patient started to have progressive headache, dizziness, and the clumsiness of right side limbs and with some weakness. We can see on the image in 2018, there is a chronic encapsulated hematoma and cystic formation with severe edema around it, which progressed gradually. So 1 year later, he came for help. Then we did the resection. This is patient was put on supine position, the superior sagittal sinus. This is the left frontal lobe opened. This kind of surgery is not so, does not require so delicate procedure. So I supervised my chief resident to complete the surgery. It may not be so delicate as AVM surgery, but we can complete it even by the chief resident. Should be no problem. And you can see the tumor, this pseudocavernoma looks like just like a common cavernomas. It's a large rubbery part, and removal of it also opens the cystic part. That's the final view. And this is before surgery. After surgery, you can see that the pseudocavernoma is removed, cyst is drained, opened, and the edema regressed. There you can see some neovascularization, organizing hematoma, but no AVM vessels. There are also some hemosiderin, collagenous part, fibrotic abnormal vessels, and some hematoma, old or fresh. This is the main part of the pseudocavernoma. Postoperatively, the patient became symptom-free. So what I would like to share with the treatment of pseudocavernoma is that usually, as you have seen, we try medical treatment first, initially with steroid for short term. But if the situation progressed, we may consider bevacizumab, as has been shown in many literatures. But it's not covered by our national health insurance. So it depends on the patient's financial or private insurance situation. But in cases that's refractory to medical treatment, I would usually do a contrast-enhanced MRI for planning of resection. Usually I treat it like radiation necrosis. We try to remove the enhancing part, namely the necrotic part or the pseudocavernoma part. I stress on this because in our hospital, the follow-up protocol for AVM does not include contrast-enhanced MRI, usually TOF, T2, and non-contrast part only. So for planning of resection, we do contrast-enhanced MRI especially. And we try to resect the enhancing part and unroof all cystic components. So my experience is that radiosurgery still remains a good option in addition to surgical treatment. And we need thorough discussion with the patients, especially after Aruba trial, which might cause some patients to refrain from treatment. And the gamma knife radiosurgery might cause severe brain damage in certain patients. So, but we must inform the patient that even a pseudocarcinoma is better than a potentially fatal AVM. So in case that has a severe radiation effect, we may consider medical treatment first. And if the medical treatment fails, resection of the enhancing part and fenestration of cyst may be considered to reverse the patient's symptom. Thank you for your attention.
Their wings off so they can fly, and oh, but she's so brave though, just like a tornado, she's taking us by storm. You can't stop the door from going, you can't stop the world from knowing the truth will set you free. You can't stop the door from going. You can't stop the world from knowing the truth will set you free. You can't stop the girl. They're trying to take our voices. They're trying to make our choices. So we scream loud, 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 and oh, I know you feel the and it's so exciting, so here we go. You can't stop the door from going. You can't stop the world from knowing the truth will set you free. You can't stop the door from going. You can't stop the world from knowing the truth will set you free. You can't stop the girl. You can't stop the girl. Oh, they're trying to shoot down angels. They're trying to pull their wings off so they can't fly. And oh, but she's so brave though, just like a tornado, she's taking us by storm. You can't stop the door from going. You can't stop the world from knowing the truth will set you free. You can't stop the door from going. You can't stop the world from knowing the truth will set you free. You can't stop the girl. They're trying to take our voices. They're trying to make our choices. So we scream loud, loud, loud. And it's so exciting. So here we go. You can't stop the thought from going. You can't stop the world from knowing. The truth will set you free. You can't stop the thought from going. You can't stop the world from knowing. The truth will set you free. You can't stop the girl. You can't stop the girl. Oh, they're trying to shoot down angels. They're trying to pull their wings off so they can't fly. And oh, but she's so brave though, just like a tornado. She's taking us by storm. You can't stop the thought from going. You can't stop the world from knowing. The truth will set you free. You can't stop the thought from going. You can't stop the world from knowing. The truth will set you free.
Good morning, everyone. Does anyone have any questions? I think it was a very informative and very good talks this morning by a lot of great neurosurgeons.
We have two of our speakers here, Professor Chun and Professor Aaron.
Yeah, I think there are a few questions here. Our panelists, are they around? I mean, the speakers, are they around you, all of them? No, right?
Yeah, two of them are here.
Okay. Raj, your questions is okay. To Prof. Hugo, is Prof. Hugo around?
No, Prof. Hugo is not here.
Yeah, so I think Raj will
is here. Yes.
Yeah.
And Professor Lin is here.
Yeah, Professor Lin, yes, he's here. All right, yeah, great. Professor Lin was a very, very interesting talk. I think that the present situation is everyone is still confused about the Aruba trial and how it affects the AVM surgery. So I think you sort of gave us a very good sort of an idea of how to manage. Do you want to say anything? Any last any conclusions, any words?
Yes. I think we should look at the Aruba trial very cautiously. Yeah. There is some disputes. I think after its publication, you can see many more articles. People try to review their data. In the similar group of people, patients, we get different results from Aruba trial. So the lesson we learned should be that we should never abandon surgery. It is still very important. And you also we need to start from simpler cases and then progress gradually to more difficult ones. And I would suggest that embolization itself should be reserved for an adjuvant or neoadjuvant treatment modality. Yeah, there are many brave endovascular surgeons trying to cure the AVM itself just by embolization alone, which is, I think, is still not so appropriate in a neurosurgeon's point of view.
I have to agree with you, Lin. Yeah, I think so. Definitely. Because I think they will send you questions on your email, so maybe then we have some interested young neurosurgeons would like to get feedbacks, maybe they'll send to you on your email chat.
And could I ask Professor Ling? Yeah, good morning from Thailand. Yes, Professor Ling, can I ask you about the deep-system AVM location? Do you have an opinion to send the patient to perform gamma knife in how many cases in your experience to send the patient?
Sorry, Prof. The next session is starting now.
Okay. And in our hospital, I think it's we work in a different way. Mostly patients came to our hospital for gamma knife initially. And the gamma knife group will have a conference, and if they think this case is difficult to be treated or has high risk of bleeding before they get cured by gamma knife, then they will refer the patients to my service. So usually smaller AVM, younger age, and the superficial location are those that will mostly be referred to me. And sometimes you can see from my data that I also operate on some higher grade patients because they think these AVMs will not be cured by gamma knife alone. So then they will ask my opinion. In some case, if there is high risk of bleeding, then I will proceed with surgery if the patient can take the risk. And also we have many
laminoplasty,
working
excision and biopsy,
and they will consider treatment
and other procedures. Our prime purpose in this life is to help others, and if you cannot help them, at least don't hurt them. Dalai Lama. Endoscopy in intraventricular tumors mandates to go through a tedious learning curve, and you should be in command of the morbid anatomy. Your concern will be your tools to have a bipolar forceps, endoscopic ultrasonic aspirator probe, a holding system. You use a port technique, a cylindrical transparent conduit to have a straight trajectory and be able to do bimanual dissection and hemostasis. And you resort to hemostasis by doing profuse irrigation, balloon pressure, the small chamber irrigation technique and dry field technique. You have to be selective in your cases. Size will be around 2 centimeters, hydrocephalic, with the consistency of the lesion preferably soft, and if solid, better avascular. Throughout these procedures, you might do endoscopic inspection, endoscopic surgery, endoscopic assisted microsurgery, endoscopic controlled microsurgery, or microsurgery. Persevere, hope for the best, but sometimes you have to convert and plan for the worst. Now this is a cavernoma blocking the foramen of Monroe, solved by endoscopic excision. You start by coagulating the lesion and then piecemeal removal with a tumor forceps and doing your coagulation, and sometimes you resort to balloon pressure in order to find your way through the foramen. And you continue this piecemeal procedure until you do excise and remove the cavernoma. And you'll get a foraminoplasty done. You can see the foramen now. And this is how it looks post-endoscopic procedure. Another kind of cavernoma blocking the aqueduct of Sirius was solved mainly by doing an ETV to solve the hydrocephalic problem, and then adjuvant therapy was given to this patient and the problem was solved. The visual confirmation of your ETV. And you can see the capilloma very clearly. Now this is what to do in cases in and around the foramen of Monroe. You start by your Kocher hole, and this is an interesting case with hydrocephalic changes and with a tumor with a ball and socket valvular problem, the tumor with a pedicle and obliterating the foramen of Monroe. And you could see it was separable from the foramen of Monroe, and this is why we resorted to a mini craniotomy, which you can do if the tumor is posteriorly placed backwards or forwards. And this is very easily separable from the fornix and just blocking the foramen of Monroe. You excise this tumor microsurgically, and then you use the endoscope again to do some exploration to find, astonishingly, some sort of an ulcer here inside the third ventricle, which definitely gave you a clue about the nature of the disease, and that an adjuvant therapy was mandatory in this case. Now here, this is a velum interpositum cyst that you can solve with the endoscope to get this picture thereafter. And this, in this case, a biopsy was taken and the cyst was evacuated for further adjuvant therapy. But you could, in this case, have gone posteriorly more and removed as much as possible. We thought this was the best decision then. Colloid cysts, extremely challenging. From 0.5% to 1% of all primary intracranial tumors. We all know that they are epithelium lined. They have dark green to brown content, mucin, viscid, gelatinous, containing retention embryonic cysts. Origin, primitive ventricular neuroepithelium of telechoroidy. Migration of tropical spiratory epithelium. The site, most commonly anterior third ventricular, yet quite oftenly so in the septum pellucidum, mainly, or both septum pellucidum, septum virgin, the fifth and the sixth ventricles. Very rarely posterior third ventricular, fourth ventricular, cerebellum and frontal. The size ranging from 0.5 centimeter to 4 centimeters. The presenting age from the 4th to the 7th decade, 80%. No sexual preponderance. Youngest in our series, a female, 14 years. Pediatric age group, 9.1%. They are usually less than 2 centimeters. Solely fluid contents. Incidental discovery, asymptomatic in 60% of the cases. proven by CT, MRI, or postmortem. They are smooth, spherical, and well defined. The main complaint is usually headache, that there could be visual symptoms, short memory, lost drop attack, normal pressure hydrocephalus. Alarming would be a disturbed level of consciousness, sudden death up to 20%. Symptoms increase with young age, size, ventriculomegaly, and contents. The main issue in colloid cysts are the size, the contents, the capsule, the ventriculomegaly. Should we wait and see? Is it too small? Stereotactic aspiration, is it advisable? Resection of the tumor, of the cyst. It all depends on the presence of the site, as you see, and the size. Here it is a tucked up one. Here it is in the third ventricle, pushing itself upwards. Here it has already transgressed within the two septi. And here it is very small, with even small ventricles. What to do when? This is very important. The site, the size of the ventriculomegaly, and the relationship. You see, this is a tucked up with major, with quite sizable hydrocephalus. And this is how it looks endoscopically. This is a small one, very small one, foraminal, third ventricular, and not completely blocking, yet causing hydrocephalus. Another small one, but not causing hydrocephalus. A bigger one causing hydrocephalic changes. And again a smaller one and causing hydrocephalus. So the relationship between all the three is not clear so far. The variables affecting the strategy of knowing a colloid cyst, whether to do it solely endoscopically or endoscopic assisted microsurgery by manual, the port of entry. We prefer the Kocher-Burr hole as a standard port of entry. The ETV, whether you do an ETV once you're there and you have a displayed and stretched third ventricular floor, whether to put an EVD post-surgical, the radicality versus the safety, the minimal invasive concept, and the tailored approach. And again, would you use such a mini craniotomy and extend the small burr hole 1 inch forwards or 1 inch backwards, and you're still safe? You aspirate the content, or you remove the contents in a piecemeal fashion. You use combined balloon squeeze and aspiration for more viscid contents, as you can see in this video and in these. You squeeze with the balloon and you use your aspirator to suck the contents, as you can see clearly here in this video, when you do your ETV. An ETV once done, and this is the pre and the post, and the pre and the post. Once done ETV, you can have a quiet night after the surgery. These are all the forms of colloid cysts that you might be faced with. coapted, displayed huge presentic foramen of Monroe, large foramen of Monroe, divaricated foramen of Monroe, dilated foramen of Monroe, recurrent case, an adherent case, and a small tucked up case. You can have a quick look on all these cases and what to do. This one was a very interesting, huge colloid cyst in a medical student in his last year, and we definitely had to resort to microsurgery. Now this is another case to show you the decision, endoscopic versus endoscope assisted microsurgery, small cochlear blur hole. This is how it looked. Very difficult to remove solidly endoscopically. So the decision was to enlarge anteriorly the mini craniotomy, do a mini craniotomy. This is postoperatively with an EVD. The site of the EVD, immediate postoperative CT, the site of the craniotomy, the mini craniotomy, a postoperative 1 week CT, and a 6 weeks postoperative MRI. Minimally invasive surgery. What you don't see, you always see these kind of pictures, pre-operative, post-operative, beautiful pictures, but you don't see what you do. Whatever minimal invasive you are, this is something you'll be faced with. The post-operative complications in these cases, limited post-operative chemical meningitis due to spillage, transient, ongoing memory disturbance, 3 to 6 months, due to injury to the fornix, unilateral of course, intraoperative bleeding, cerebrospinal fluid leak, subgaleal pocket and some drainage, recurrence with a residual, different contents, yet no mortality, although 3% and more reported. Shunt dependency depends on what you're going to do, BTV and EVD, if it was a billion or if it was peritoneal shunt. Endoscopic options for triventricular hydrocephalus. Your advice here is to go in. Sometimes you're faced with a seeding, yet it is doable. The target area is still there and you can do it. Another case of a binary tumor. We prefer to do an ETV and do a tailored approach thereafter. And this is reinforcement tumors pushing the brainstem and the basilar artery forwards, yet an ETV was doable. We're going to discuss this in detail later on, when to do and what would be the best algorithm for all the posterior fossa lesions. Always visual confirmation. This is a case where you're there and you can't do anything about it. This is not doable with all the seeding in and around the target area. This is a biventricular hydrocephalus. The balloon third ventricle was due to a choroid cyst. It was avulsed and removed. The problem was solved. Actually, foraminal plasty was done. And this is the proximal intracisternal obstructive hydrocephalus. With visual confirmation. These are cases you are confronted with after posterior fossa, fourth ventricular tumor surgery, and you get this type of proximal intracisternal obstructive hydrocephalus, and this is curable by ETV endoscopically. An algorithm for management of posterior fossa lesions with hydrocephalus. This was applied on 247 cases. This is one of 3 series until we reached finally our algorithm. Intraventricular lesions, we usually do intraventricular fourth ventricular lesion, we usually do an ETV, which have proven beyond the shadow of any doubt to be quite helpful and would prevent any disasters post-operative, and maybe in some cases, in most of the cases, you will not do a ventricular peritoneal shunt. Another study was done on 185 posterior fossa tumors with only 55 conforming to the inclusion and the exclusion criteria, mainly focusing on fourth ventricular tumors in pediatric age group with moderate to severe hydrocephalus without any pre-hand CSF diversion. The exclusion criteria: any deterioration of level of consciousness more than 24 hours, waiting period, limiting factors, availability of meticulous, well-trained and experienced neurosurgery targeting total excision. The 3 types were approached with medulloblastomas, ependymomas, and exudative brainstem gliomas. Because fourth ventricular tumors, you have local mass effect, you have secondary CSF pathways obstruction. These are your main 2 problems. 2 groups with direct tumor excision or with external ventricular drain prior to the tumor excision. And at the end of the day, what was found, and as an algorithm that we really do advise, management of fourth ventricular tumors with hydrocephalus. We could do an EVD, tumor removal, ICP monitoring, ETV if needed, or ventricular peritoneal shunt if the ETV fails. All this is debatable. Intraoperative neurovascular injury, braditachycardia, cardiac arrest, thermal damage, surgery, all these are the complications of intraventricular surgeries, especially endoscopic intraventricular surgeries. Subdural collection, CSF leak, infection, transient fever memory, loss of memory loss, endocrinological disorders, cranial nerve affections, seizures, delayed sick leave, which would be the failure of the procedure. And this is just some of these things, bleeding, and all the problems that you might be faced with. And how to solve them with irrigation, a small foramen Monroe, and how to go through without injuring the foramen Monroe by sliding the sheath forward and guiding it through. And all the tips and tricks that you do use for colloid cysts, using the balloon catheter to squeeze the contents out, especially if they are sticky and not as fluidy as you would have wished to be. Complications of brain endoscopy, injury, infection, hemorrhage, mortality, an overall of 2.7. They are categorized by their onset, immediate, early, late, their course, cured, stopped, ameliorated, worsened condition, duration, the transient and permanent, severity, mild to severe, the procedure, single, multiple stage, and especially in the course, it is procedure and not disease dependent. At the end of the day, it is a set of mind, knowledge, skill, which is the learning curve, tool, which is the endoscopic equipment, and this is how you should tackle endoscopic surgery with for intraventricular lesions. Having all the three in mind, interacting both, all the three of them, to get your best result. Take home message: educate one to save a few, educate a few to save many. Patient safety comes first. This is another very important take-home message. If you have to resort to microsurgery, it is not the end of the day, by all means. Thank you very much.
Ladies and gentlemen, my name is Nasser El Gandour. I am second vice president of the World Federation of Neurosurgical Societies. I'm general secretary of the Continental Association of African Neurosurgical Societies, and I'm president of the Egyptian Society of Neurological Surgeons as well. First of all, I would like to thank Professor Yuko Kato and all the organizing team for giving us such opportunity to have such wonderful collaboration with the Asian Congress of Neurological Surgeons. Let me start by this introduction about the African neurosurgery. Let me speak about this paper which I published in the Neurosurgical Focus, and it was evaluating the challenges or obstacles which are facing the development and the promotion of neurosurgery in Africa. Among these obstacles are the lack of resources, shortage of facilities and basic equipment, problem of training, and rapidly increasing population. There is very fast increase in population in Africa, much more than any other continents. Obviously, this is reflected in an increase in the pediatric age group. The World Bank estimates that 44% of African population is under 14 years old. This leads to increased incidence of pediatric neurosurgical problems like hydrocephalus and meningomyelocele. This shows the Pediatric Hospital of Cairo University, to which I'm affiliated. This pediatric center offers all medical services free. It had been constructed in 1983 as a donation of JICA. What is JICA? JICA is the Japanese International Cooperation Agency, which had been constructed in 1974. This photo shows the headquarters of this organization in Osaka. This organization is concerned about global development, and it offers many health and education programs and projects. My speech for today will be about endoscopic third ventriculostomy versus ventricular peritoneal shunting in the treatment of obstructive hydrocephalus due to posterior fossa tumors in children. Hydrocephalus associated with posterior fossa tumors in children is a life-threatening condition. Hydrocephalus is one of the main factors influencing the outcome. Children are very sensitive to intracranial pressure elevations, and its treatment should have an utmost priority before any considerations are given to the surgical approach of the posterior fossa tumor. Authors claim that 1/3 of children with posterior fossa tumors require post-operative cerebrospinal fluid diversion. As we all know, the classic management of advanced hydrocephalus due to posterior fossa tumors in children is temporary cerebrospinal fluid diversion through inserting an external ventricular drain prior to definitive tumor resection. However, an important question arises: what are you going to do if you receive a patient with posterior fossa midline tumor associated with severe hydrocephalus, and you do not have access to perform urgent tumor excision due to lack of the required facility, or due to lack of the required surgical expertise, or due to patient waiting list, as is occurring in many centers in sub-Saharan Africa. Our objective in this study is to evaluate the role of endoscopic third ventriculostomy in the management of obstructive hydrocephalus associated with posterior fossa tumors in children as compared to ventriculoperitoneal shunting. This is video of the surgical procedure of the endoscopic third ventriculostomy. This video will not be too much exciting for you because it is a classic procedure. However, it's important to stress that some authors claim that tumor will displace the brainstem anteriorly and obliterate the interpeduncular cistern, and this will make the endoscopic third ventriculostomy procedure technically difficult or impossible. Our findings did not support such claims. We operated in all our cohort of patients by doing endoscopic third ventriculostomy, which was performed easily and successfully in all our patients. This table shows the preoperative findings in our cohort of patients who were divided into two groups. The first group operated by endoscopic third ventriculostomy, whereas the second group operated by ventriculoperitoneal shunting. Important to mention that all our patients had severe hydrocephalus. It shows the surgical findings between the two groups, and as you can notice that the endoscopic third ventriculostomy is superior concerning the duration of surgery and the duration of hospital stay, and the difference between both groups was highly significant. Medulloblastomas and ependymomas were selected because they are the most vulnerable to produce obstructive hydrocephalus among all posterior fossa tumors, and in order to have homogeneous sample of patients. This table shows the difference in morbidity and mortality between both groups, and as we can notice that the ventriculoperitoneal shunt has the highest incidence of mortality, and the difference between both groups is highly significant statistically. Let me show you some cases. This 3-year-old girl with huge ependymoma and advanced hydrocephalus, which occurred acute, as evidenced by the presence of periventricular cerebrospinal fluid permeation. Post-operative CAT scan performed 3 days after endoscopic third ventriculostomy shows considerable improvement in hydrocephalus, as evidenced by the decrease in size of the ventricular system, the resolution of periventricular edema, and opening of the subarachnoid space. Another case of 5-year-old girl with huge medulloblastoma compressing the fourth ventricle with advanced hydrocephalus, post-operative magnetic resonance imaging axial views performed 3 days after the endoscopic third ventriculostomy procedure, showing marked improvement in the hydrocephalus. 5-year-old girl with huge medulloblastoma compressing the fourth ventricle with advanced hydrocephalus, post-operative CAT scan showing considerable improvement in hydrocephalus. 6-year-old girl with huge ependymoma involving the fourth ventricle with extension into the lateral recess and cerebellar peduncles, causing marked hydrocephalus, post-operative CAT scan showing considerable improvement of hydrocephalus. This is sagittal image, magnetic resonance imaging. This is very interesting image because, as you can notice, this is the perforation performed in the floor of the third ventricle, communicating the third ventricle with the interpeduncular cistern. Images on the right side show pre- and post-operative CAT scan of this 8-year-old girl with huge posterior fossa medulloblastoma and obstructive hydrocephalus. Flow velocity graph showing systolic, diastolic unidirectional flow of cerebrospinal fluid from the third ventricle to cisterns. Axial flow gated magnetic resonance imaging showing cerebrospinal fluid flow signal void at the site of endoscopic third ventriculostomy. Intraoperative findings during tumor removal 1 to 2 weeks later on showed that the dura was lax, what we call it slack posterior fossa. Ventricular tapping was not necessary. Cerebellar retraction was easy, and good tumor exposure and dissection was possible. This table shows the difference in results between both groups, and as you can notice that the incidence of post-operative failure was very high among the ventriculoperitoneal shunt group, and the difference in incidence between both groups was highly significant. In other words, all the patients operated by endoscopic third ventriculostomy were shunt independent all through the average mean follow-up duration of 27.4 months. Kaplan-Meier survival curve shows more decrease of cumulative survival in the ventriculoperitoneal shunt group. There was higher survival time for the endoscopic third ventriculostomy group, more than the ventriculoperitoneal shunt group. The log rank test was highly significant with p-value less than 0.01. This good outcome in the group of the endoscopic third ventriculostomy patients, I can attribute it to three causes. The first reason, hydrocephalus in these patients is usually acute, and accordingly, the floor of the third ventricle is thinned out and can be easily perforated. This is in contrast to the floor of third ventricle in patients with myelodysplasia, where you can find that the floor of the third ventricle is tough and resistant to perforation. The second reason is that the anatomy of the third ventricle is undisturbed, and the incidence of anatomical variance is very minimal. The third reason is that these children have normal subarachnoid space with very good cerebrospinal fluid absorption capacity. As we can see from this table, that endoscopic third ventriculostomy has the advantages that there is no shunt dependency, there is no risk of seedling, there is no risk of upward herniation. It is a procedure which can be done under vision, and it's a minimally invasive procedure. Indications. When to use endoscopic third ventriculostomy in these patients, I recommend doing endoscopic third ventriculostomy in the treatment of obstructive hydrocephalus secondary to posterior fossa tumors in children in two conditions. The first condition for high-risk patients who have high risk of developing postoperative hydrocephalus. These are the children who are younger than 3 years of age. Many papers reported that these children have about 80% incidence that they need postoperative shunting, or due to the presence of preoperative marked hydrocephalus, which makes these patients at high risk as well. The second condition, if emergency tumor excision is not feasible, like in low resource settings, either due to lack of required facilities, lack of experienced neurosurgeons, or waiting operation list. We published our results in the child nervous system. And now we can have an answer for the question I was just asking at the beginning of the presentation, what you are going to do if you receive a patient with posterior fossa midline tumor associated with severe hydrocephalus. I recommend, and you do not have access to perform urgent tumor excision, I recommend doing endoscopic third ventriculostomy, which will be a proper choice and life-saving procedure for these children. Why endoscopic third ventriculostomy? Because it is safe, associated with low morbidity, it's effective, it relieves intracranial pressure, it's technically easy due to undisturbed anatomy, it's minimally invasive and not associated with abdominal incision. It is a completely visible procedure which is done under direct vision in contrast to ventriculoperitoneal shunting procedure, which is a blind procedure. It is physiological and no shunt dependency occurs in these patients operated by endoscopic third ventriculostomy. It is a rapid procedure. The average time duration was 15 minutes, and it's low cost because no device is needed. Why physiological? Because what keeps the endoscopic third ventriculostomy working is the pressure gradient existing between the third ventricle and the basal cisterns. And so after tumor excision and opening of the cerebrospinal fluid pathways, this pressure gradient will be no more existing, and endoscopic third ventriculostomy will be expected to be no more needed, and it's not going to be working at such time, and so it closes spontaneously. However, in the second group of patients operated by ventriculoperitoneal shunting, these children will become shunt dependent. I sent a proposal when I joined the membership of the World Federation of Neurosurgical Societies Neuroendoscopy Committee. This proposal, I was saying, my aim is to make endoscopic third ventriculostomy a simple traditional procedure that can be performed by junior neurosurgeons, the same like in ventriculoperitoneal shunting procedure. And so we have to work hard in order to train as many young neurosurgeons as possible so that they can perform endoscopic third ventriculostomy with elaboration. We are organizing hands-on workshops about neuroendoscopy, both ventricular and skull-based, both basic and advanced in Egypt many times each year. I am more concerned about basic procedures because I believe that for young neurosurgeons, if they practice doing the endoscopic third ventriculostomy, and they can develop a good learning curve, and after some time, they will be able to do any other complicated endoscopic procedures. That's why usually I am focusing on educating young neurosurgeons the basic endoscopic procedures more than the complicated endoscopic procedures. Trainees are welcome to join our hands-on workshops in ventricular endoscopy. This is my email. We are also offering scholarships concerning food and accommodation to African candidates and to candidates from developing countries. This gathering photo was taken during a WFNS hands-on workshop, which was held in Egypt 2018, and it shows President of the World Federation of Neurosurgical Societies surrounded by me and faculty and African candidates after the workshop. Another workshop organized about neuroendoscopy in Cairo, March 2019. It's also important to announce about this important meeting, which is the meeting of the Mediterranean Association of Neurological Surgeons, the three-man's Congress, which is going to be held next year in 27 to 30 October 2022. And all of you are invited to participate in this important event. Maybe it's going to be a good opportunity to visit the old Egyptian Museum and to visit together the Grand Egyptian Museum as well. Thank you very much.
Dear all, again, it's a great honor to be a part of speakers in this summer seminar of WFNS Foundation and ACNS. I will talk about pediatric neurosurgery in developing countries. Before, we have some message for our young neurosurgeons. Education is theoretical education, workshops, cadaveric dissection, researches, and this is important for everybody. However, there are some differences for developing countries, since we have to adapt our guidelines according to our mean, according to our environment, and we have to place the clinical researchers first online, since many developing countries don't have fundamental researchers. Since I'm belonging to Africa, just some information. It's the youngest continent in the world with a middle age of 19 years. And all the pathologies are present, not only hydrocephalus and spina bifida, but you can see that also brain tumors and trauma. In 2019, trauma were one of the first causes of mortality of the young people in Africa. Words about neurosurgery in Africa to show that in 1988, in sub-Saharan Africa, we have a very, very low ratio of neurosurgeons. And in 2060, this ratio has been raised, but it is still now under the needs of the continent. And this was reported in a book written by our professor Abdeslam El-Khamlishi from Morocco. Pediatric neurosurgery in Africa, we have only 2 countries that have a real fellowship in pediatric neurosurgery, which are Egypt and Republic of South Africa. There is also beautiful experiences in Cure Children Hospital, Uganda, and in Algeria, Morocco, Tunisia. We have in many departments, pediatric divisions where general neurosurgeons use to deal with children. Just few words about the parameters of safety of pediatric neurosurgery. Of course, the age, the skills of the medical team, the tools that are available, the healthcare system, and also the familial and social environment. This is the ideal for practicing a good pediatric neurosurgery, and what is very important is a very, very good anesthesiologist who is dealing with neonatology. For hydrocephalus, many classification, several causes, and of course, ETV was a revolution in the management since it has diminished the complications of shunts. However, we have a high rate of failure in babies under 6 months. And there remain a substantial of patients who still needs shunt. Management of shunt infection is classically removal of the shunt, EVD, and antibiotics, new shunt, but it is an important cost. What about antibiotics? Impregnated catheters can maybe decrease the rate of infection. I don't know. For the mechanical complications, many clinical forms for the shunt failure seems common to all types of shunt. Very well known. Overdrainage is maybe overstressed this last years. Maybe it's a problem of marketing and manufacturers. A lot of shunts have been proposed, such as programmable, which is very questionable in some babies, and gravitational also. But it is very expensive comparatively to classic shunts. In Africa, the current situation, fear of infection and mechanical complications are more important and very often life-threatening. And so ETV has been proposed as first treatment in patients under 6 months, and more developed in Africa, with 55% of success in Nigeria, and 65 for Professor Bouyoussef in Algeria. And it seems that it be safer than shunts in subset of countries. The prevention of shunts has been also studied by Professor Kazadi Kalangu, and he achieved a very, very good rate of infection just by simple methods, and really this paper is very interesting. For myelomeningocele, of course, antenatal diagnosis is the best, and with organization of delivery. The timing of surgery, we know, decreased drastically infections rate. And treatment of hydrocephalus currently in most cases are shunts. But the discussion is about timing of shunt. Currently, some tolerance of ventriculomegaly with clinical and imaging monitoring is sometimes recommended. And we can monitor this kind of patient with a close clinical and ultrasound monitoring. Antenatal surgery is more and more developed in many developed countries. Here are the advantages, but now it's not sure that the results of moms can be predictable, since protocols are quite different from an hospital to another. This is, you can see in a ventriculomegaly with macrocrania and bulging fontanelle. This patient has not shunt, and you can see 1 year after and 5 years after, there is no need for shunt. This is also a good option. In Africa, timing of presentation is very often late. Antenatal diagnosis is sometimes done, but we have a high rate of infections, the problems of closure. Fortunately, many neurosurgeons close alone large defects because the lack of plastician and lack of collaboration. And for Africa, I think it's not the moment to think about antenatal surgery. The priority is to improve antenatal diagnosis, organize the networks for delivery, and develop anesthesia for neonates. For shunts, it's better to delay the placement to rule out all infection before. This is an example of a patient operated by a neurosurgeon alone. This patient in post-operative have no skin lesions and no necrosis. For the brain tumors, we have assisted to a major improvement in many fields, and particularly in molecular biology and creation of multidisciplinary teams. Close of follow-up for a long time. Now we know that many tumors need follow-up very long, as pilocytic astrocytoma. And we have some teams that have begun to adapting their protocols regarding biology of the tumor. Everybody knows now this differences between biologic group of medulloblastoma, of ependymoma, craniopharyngioma, and low-grade glioma, with particularly the BRAF V600 mutation. And this confers a poor outcome with conventional therapies. And some people are beginning to think to propose BRAF inhibitors for this kind of tumors. This is the difference between different biologic subgroups, same tumors, but same pathology, but probably a difference in biology. And what is also important is the impact of the socioeconomic conditions in treatment of craniopharyngioma, even in the teams that are for the radical resection, because it is a real burden that sometimes can be supported by the family. In Africa, several levels of development, lack of microscope in some countries, the monitoring of brainstem is very rare, and biology is available only in North and Republic of South Africa, not always routinely. So very few pediatric neuro-oncology groups. The follow-up is very difficult to have, and the risk in the future is that our patients will not be treating according to new protocols in many countries. This is a very beautiful example of the Children's Cancer Hospital 57 in Cairo. You can see that they have a huge number per year of tumors. They have all the technologies, and which also very important is that they have an international fellowship in pediatric neurosurgery very soon. And also something very interesting is the creation of African Pediatric Neuro-Oncology Society. For trauma, we have seen that we have a high rate of death. So neurosurgeons must be totally involved in prevention. This is their job. So the future direction, of course, is before everything increased number of neurosurgeons. More and more of our young students are trained in Africa by African. We need also more opportunity for fellowship in pediatric neurosurgery inside Africa. Also, convince authorities and investors that neurosurgery is also a priority, is mandatory, and also, of course, creation of adequate environment of neurosurgery, particularly in anesthesiologists. Sometimes, as I said, guidelines are important, but sometimes not applicable regarding environment. We need more and more publications in the field of hydrocephalus and spina, because we have a huge experience and so many cases not seen around the world. And what is important to say that African neurosurgeons must trust in themselves. Thank you very much for your attention. Alors.
Good morning, everyone. My name is Professor Jafri Malin Abdullah. Together with Dr. Zaitun Zakaria, we'll be presenting on a topic, intraoperative monitoring of pediatric lipomeningocele, what is to expect and how to respond. We would like to thank the WFNS Foundation ACNS Summer Web Seminar Committee for inviting us to give us this talk. In this presentation, we will be running through pediatric patients with lipomeningoceles and what we see during surgery of different type of lipomeningoceles, their interpretation of the physiology of intraoperative monitoring, and we will discuss a case as a representation. The objectives of this presentation is to correlate embryological development and IOM in the pediatric OT, and then to present common clinical presentation and investigations, and correlate basic monitoring during IOM in these patients. And most importantly, how to respond when there are changes during the IOM reading in the operating theatre. Is also very important. The maturation of the PNS occurs more rapidly than that of the CNS. The peripheral nerve diameter increases in close association with myelin sheath thickness, begins at 15 weeks gestation, continues through the first 3 to 5 years of age, doubling of axon diameter between 5 months to 5 years of age, and the myelination of intracranial tract is completed by approximately 24 months. This means that IOM reading has to be correlated very, very, very carefully with the patient's age. Similarly, urinary sphincter is still evolving in these children. Newborns and infants typically uncoordinated dextrosal sphincter pattern occurs several times daily, and the adult coordination is acquired between 1 to 2 years, and the complete control is obtained between 3 to 4 years. Urodynamic study is important to detect urological impairment. So the learning point is that preoperative urodynamic studies allow baseline assessment, and pre-op deficits will correlate with IOM reading. Prophylactic surgery with a radical approach did not enhance the post-operative risk of motor deterioration, and this was published by Valentini et al. where they found that the increase of the percentage of patients apparently asymptomatic but already harboring a urological deterioration hidden until a urodynamic study was performed. Urological protocols are recommended. IOM of the bulbo-cavernous reflex is valuable and may not be available in most developing countries. The clinical presentation of these patients come from skin changes, lower limb and foot deformities, constipation and or neurologic fecal incontinence, voiding dysfunctions and or recurrent urinary tract infections, upper motor neuron symptoms from mechanical rostrocaudal traction and ischemic damage to the cord and even pain. So the important information that we have to elicitate is to look at whether there is a motor problem, a sensory problem alone, or a mixed motor and sensory problem. The pre-operative evaluations which are very important. Number one is history from the parents, the progression of event, emphasis on development, giving clues if brain MRI is needed, motor and sensory findings, giving clues if whole spine MRI and even MRI of the peripheral nerves are needed. Urinary and bowel control, and also the socio-economic status, as this happen mainly in those who are not very affluent. Pre-operative evaluations requires a multidisciplinary team, ERG, regardless of symptoms. The physiotherapist has to do baseline assessment. The radiologist will have to do X-rays, MRI, and other relevant assays or radiology investigations to see whether there is any incidental findings. Neurology sensory system. Sensory root starts the myelinating process at 24 weeks gestation and finishes at 6 months postpartum. Latency of the cortical median SSCP as compared to adults are different. Longer in the newborn and younger infants up to 3 months, decreases 18 milliseconds at approximate 4 to 8 months with spurt of myelination, decreases to 50 milliseconds at 2 to 3 years, and gradually increases to adult values. Thus, it is important to run baselines before surgery, even in the wards, and this will show you expected differences on both sides. The transcranial motor evoked potential MEP is most appropriate technique to assess the functional integrity . The EMG electrode couples inserted into both sides for monitoring shows here a list of recommended muscles and nerves that have been used and published by Valentini et al. In 2005.
Good evening. So now we are going to move on to the case presentation. I'm going to give you a case based on the surgery that we had done recently. This is a 5-year-old boy who presented with a 2 years history of a bilateral lower limb pain on exertion and also suffered from constipation. The MRI finding at that time showed an area of lipomyelocele of L1 to L3 level with a low-lying and tethered spinal cord. However, the defect itself is actually up to the level of a T1. On examination of the patient's back, we can notice 3 areas of a dimple, and the most upper part correlates with the level of T11. Hence, for the IOM planning, this should include from T11 and below. So why is T11 is important? Because T11 is supplied by the rectus abdominis muscle that is innervated by the intercostal nerve. In children, this is very important because it involves with the trunk flexion. It compresses abdominal viscera during the defecation and micturition, and it also involves in the forced expiration. Further weakening of this muscle when the child is growing up can cause a direct or acquired inguinal hernia. So when we're monitoring the area of T11 for the rectus abdominis muscle, then important that the electrode should be inserted below the umbilicus. Many centers have different techniques for the IOM reading. For our center, we use the MEP and we use both the upper and lower limb SEP. I know that some centers only use the lower SEP since the deficit is just the lower limb. However, the upper SEP is also important as this can be used as a baseline reading. And then once the patient is turned into the prone position, then we inserted 5 electrodes that will monitor the rectus abdominis muscle for your T11 area, then your vastus lateralis that is supplied by your femoral nerve, your gastrocnemius muscle, The abductor hallucis longus, and the last one is your anal sphincter that comes from the S2 to S4 of the cord. Some centers also monitor the bulbo-cavernous reflex. However, we do not have that in our center. Then once all the electrodes are inserted, first that you have to look for is your raw EMG or your free EMG. On your left side, it's coded as a LM1 to LM5. L stands for the left side, and on your right side is coded as a RM1 to RM5, and R represent your right side. The baseline or the raw EMG should have a normal state. This is because of absence of any muscle activity, and there shouldn't be any activation during the surgery. I will show you an example later on once we pick up an activation during the surgery. Then we move on to your MEP reading. Always put the MEP reading up to 100% sensitivity. When you do that, we will notice that there is a signal, and this is what you call the signal to noise ratio. IOM is very sensitive to the background noise, such as from the anesthetic machine, or when people's talking, or when we're using the monopolar or the bipolar. Hence, it's very important to minimize the background noise as much as possible. Then once we are looking at the SCP reading, this is a color coded. The black one is ongoing, the red one is your baseline, and the green one is a one stimulation before. An example is that in these photos, we can see the SCP trace. Your top left is your SCP of the lower limb, the top right is your SCP of the right lower limb. The bottom left is the SCP of your left upper limb, and the bottom right is the SCP of the right upper limb. Notice quite a similarity of the reading between the three coded color, and this should be your baseline. As the surgeon continues during the resection, that usually start from the cranial to the quadrant area, and once we started to see the nerve root under the microscope, this is when the triggered EMG is used. Usually, the triggered EMG is start at 0.5 milliampules and then gradually increase up to 8 milliampules. Always inform the neurophysiologist and the anesthesiologist what you are doing. This is an example of your triggered EMG. Once we see the nerve root, we use that to identify. And in this scenario, on the right side, we can see that the CMAP is triggered for the rectus abdominis and the vastus lateralis, which correlates to your RM1 and the RM2. Once we identify this nerve, we protect the nerve as possible during the lipoma resection. As the resection goes on, once the lipoma of that area has been resected, then we use the triggered EMG again to identify if there's any damage to the nerve. And again, we notice that the CMAP is detected on this area. Hence, we know that the nerve is not injured. As we further goes quarterly, we continue to use the triggered EMG. And in this case, then we notice the activation of the L5 and S1 roots, and see that on the RM1 and RM2, the nerve is not activated because this nerve is further up compared to the L5 S1 roots. So then, how do we respond when there is a changes in the reading? What should we do when the neurophysiologist tell us there is a percentage of a drops in terms of the SCP or the MEP reading? There are several tips that we can use. The first one is that prior to surgery, use the pediatric bispectral index monitor. This is important to monitor the depths of anesthesia, because the anesthetic drugs can interfere with the reading, especially if you use the inhalation sevoflurane. that tends to be used in a child, this can cause a false positive alert. And also important during the surgery to maintain a similar concentration of the drugs, because in children, they are very sensitive to the anesthesia. When there is a changes during the IOM reading, another option is to use the dexamethasone solutions, because sometimes during the surgery, the patient can have a cord edema or can have an irritation to the nerve roots. You have to be patient if the neurophysiologist mentioned to you that there is a continuous drops of the percentage of the either the MEP or SEP, you stop the surgery and you wait and you irrigate the area either with a normal saline or irrigate with the dexamethasone solutions. Wait for, it can be up to 10 to 15 minutes or it can be up to half an hour. This is the part where the surgeon has to be very patient. If you think that there is a problem with the electrodes, then you stop the surgery and check if there's any malposition of the electrodes. One should be aware as well that there is sometimes it can have a neurotonic discharge. This usually occurs when there is a response to mechanical and metabolic irritation. It's a warning to the surgeon that there is a nearby motor axons that were being stimulated or being manipulated. An example that I show you is this. During the surgery, remember that the raw EMG should have a flat baseline because there shouldn't be any activation. But during the resection, we were noted that there is an irritation to the bilateral L4 and S1 that is represented by your RM4 and the LM4 reading. So at this stage, we stop the surgery. We irrigate with the saline solution, and after 15 minutes, this raw EMG has returned to normal, and we continued the surgery. How do we identify a true finding in the SSCP reading? The important part is that you always compare with the baseline. In infant and a young child, especially in less than 3 years old, the SSCP represent a broad morphology and low signal-to-noise ratio in comparison to the older children and adult. They tend to have a longer absolute latency. So it's important to have a pediatric neurophysiologist so that they know when there is these changes, this could be a normal finding. In infants, they are more susceptible to the cortical SSCP loss due to the anesthetic agent. Some centers tend to use the cervical potential over the cervical spine rather than the cortical SSCP reading. When we see an asymmetrical SSCP finding in infants, this can also be normal. The reason is because of the maturation of the large fiber sensory system are not symmetrical in infants compared to adults. We recommend to use the bipolar rather than the monopolar stimulation because of the smaller surface area. Sometimes in infants, there will be a higher threshold for the CMAP during the triggered EMG. The reason is because of the effect of the anesthesia and the asynchronous myelination. This is an example of the baseline lower limb SSCP for the patient. And when there is an irritation of the nerve root, we can also appreciate on the left side that there is a prolonged latency during the reading. So you look at the black coded wave, you can see that the latency is longer compared to the baseline, which is the red coded wave. However, as the surgery continues towards the end prior to closure, we can appreciate that the latency has returned to normal compared to the baseline. In summary, most of the patients in the Southeast Asia presented quite late. When they presented, most of them tends to have a neurological deterioration. Therefore, it's very important for this patient to have a preoperative assessment. And this should be correlated with the IOM reading. Special attention should be given to the pediatrics neurophysiologist rather than adult neurophysiologist because the reading is completely different. Thank you.
Hello, Professor.
Can you hear me?
Yes, can hear you, Prof. Any question from the audiences? Prof. Azmi, our moderator today. Professor Azmi, is you online?
Good morning, everybody. So there was some, I think, disconnection in the last presentation. But do we have any question from the chat box first?
So far, no question from chat box.
Good morning, Azmi. How are you?
Very good morning, Prof. Ahmad. Long time no see. How are you?
Yes, I'm fine, thank you.
Yeah.
I had to stay awake, and I was watching the Copa America, Brazil and Argentina, to keep awake and join you for the chat or whoever has any questions. And I don't know, was the program on time or what? Because I was listening to something quite different than the endoscopy, etc., and pediatric and neuroendoscopy.
Yeah, I think they just finished the pediatric and neuroendoscopy session. So we have not started the neuro spine and peripheral nerve yet. So this is still a session, I think, before they can conclude. Liu, Liu, are you there?
Yes, Prof.
Okay. The panelists for the previous session, endoscopy and pediatric, are they around? We are going to start the new one.
No, I am still watching. Now is the advertisement on the streaming.
Okay. So now it's the QA session on the previous session, or we are going to start the neurospine shortly?
Not yet. I'm still watching it, but we can have short Q&A session now.
Oh, okay. All right. So because I joined in the middle, so I missed the initial part. So maybe the speaker still around. We have Prof. Jafri. We have a Prof. I think Nasir. Are they still there? Okay, maybe still Prof. Ahmad is still around. So maybe we start with question for Professor Ahmad Zodi. So are you going to take question?
Yes, I'm ready.
Okay, thank you very much for everyone. I think this session is meant for the young neurosurgeon, especially for beginners. So neuroendoscopy become one of the most important tools that everybody should learn. So is there any tips and tricks for you to share with them, especially endoscopy in children?
Well, additional to what I have presented in, concerning the endoscopy intraventricular lesions, I'll focus on that. And the most important thing is that it is, I wouldn't say it is now, after around 3 decades of neuroendoscopy, that everything can be done with the endoscope. It's always better, as you have just mentioned, to use the endoscope as a tool. There is no such thing as a neuroendoscopist. And this is what I want to stress for the younger generation. We've been through all that. The pendulum took us to struggle and to persevere and and we found out that the endoscope is much of greater use if you use it as a tool adjunct to the microsurgery. The learning curve of the endoscope is very tedious. It takes a long time, but at the end of the day, it is very beneficial. And as I have shown you in the presentation, there are things which you cannot solve but with the endoscope. But don't get dragged and be obsessed of using the endoscope And you always can convert back to the microscope if you don't feel at ease, because the safety of the patient comes first, especially with lesions. And whenever you have a major bleeding, okay, there are tricks and tips that I have mentioned in the presentation, but at times you still have to resort to the microscope and use all the armamentarium that you have. So the motto is safety of the patient comes first. We are here to help and not to harm the patients by persevering for a tool or with a tool that might be actually injurious. I'm not putting an alarm on the endoscope. No, of course, it is a very, very beneficial tool. It has solved a lot of problems. It has showed us a lot of hidden corners and helped a lot to solve problems that could have never been solved without the endoscope. This is in a nutshell what I always try to convey as a message and to preach, especially the young neurosurgeons.
And you aware that a lot of new development, for example, like endoscopy assisted attached to the robotic microscope like Kinovo, for visualization, and also contact endoscopy. So what is your comment on that?
No, I am not. I do not practice this type. Of course, endoscopic assisted I do much more than endoscopic controlled microsurgery. And I still, for example, the colloid, I converted from being solely using the endoscope for removal of colloid cysts to endoscope assisted. I always go in first and then I design my flap accordingly, what I would like to do. I go through a standard Kocher burr hole and then I do a thumb-sized mini craniotomy, whether a little bit more anterior, a little bit more posterior accordingly. And then I go with the tubular retractor or the mini spatulas, and I remove the colloid totally and microscopically, and then go back again with the endoscope to check. I don't use any robotics in this sense.
Okay, thank you very much. So is there any other question from other panelists? Maybe Sachin? Okay, do we have still time for Q&A?
Yeah, still have time. The advertisement is still running.
Okay. So do we have a speaker from Malaysia, Zaitun or Prof. Jafri, pertaining to the IOM in lipomyelomeningocele?
Zaitun is not here. Prof,
she left
I think
already.
Prof is also not here.
Okay. All right. Maybe I think continue to Prof. Ahmad. For beginners, especially in developing country, I remember when I I came back from Germany, I learned so many things, but I go back, we start with nothing. So sometimes the enthusiasm lost when you don't have appropriate equipment. So maybe you can share, I think in developing country, maybe Egypt or not all centers are very developed. So what will be the step in order to maintain their enthusiasm, at the same time accelerate and maintain the safety, so that the young neurosurgeon can use endoscope and learn as they goes on despite limitation?
Well, the most important thing is the total command of the anatomy, of the endoscopic anatomy. And to get acquainted of using the endoscope, once you push in the endoscope or the telescope inside the brain, you don't see behind you. Okay.
Sorry to interrupt, Professor. I think we are starting our next session.
Oh, okay.
Okay. Thank you very much, and see you soon, Azmi.
Professor.
Thank you very much.
Prashant, can you share the screen?
Walaikum salam. Bye-bye. Bye-bye.
Bye-bye.
Yes, sir. Yes.
Prashant, can you share the screen?
Yes, sir. I'm doing that.
Prashant?
Just a second, sir. Doing that.
This is a horse, as we know, this is a full-leg animal. When it runs, the pressure on the legs.
Are you able to get it?
I'm trying, sir. Just a second.
The pressure on the spine is quite big and quite long, right, and strong. So
Prashant? Hello?
Is my screen is visible, sir?
No, we can't see anything.
Okay. I think.
Prashant?
Yes, sir.
Yeah, just open it on your browser and share that browser. Share that window of browser which has that video playing. You got the video playing on your browser?
Yes. I got
Yeah, so only share that browser.
I don't know. It's playing my in system also, but not you won't be able to see. I don't know why this is happening in my system.
You stop the share. Stop the share and reshare it again. Stop the share. Did you stop it?
Yeah, already stopped, ma'am, sir.
Now first click the share screen button.
Done, sir.
Then that share audio option you have to click, and after that only that window of your browser which has the video, that window only you have to select. Are you able to get it?
Yes, sir. I have shared something. If you can able to see this.
We can't see anything.
You can't see anything.
Okay, I will share my screen now.
Years, we have got several hundred cases where we have not done transoral decompression, we have done craniovertebral junction realignment. Rotatory dislocation, the only treatment that was described in the literature was decompression. So we introduced the concept that rotatory dislocation can be realigned and the neck can be straightened by opening the joint, manual manipulation of the facets, fixation of the facet, and you can give a new long neck and new human being. Disruption of the joint and disruption of the atlas over axis due to trauma, the only treatment that was discussed was decompression and fixation. So we introduced the concept that you can manually realign the facet and do a fixation. So realignment by manual manipulation of facet was a new concept at that time. Now it is quite popular. So this kind of rotatory dislocation can be treated by opening the joint, manual manipulation of the facet, and reduction, and leading to a straight and long neck. This entity of fixed atlantoaxial instability was a very common entity discussed in the literature. So in the year 2005, on the basis of long experience and large number of cases, we introduced the concept that there is nothing like fixed atlantoaxial instability. You open the joint and reduce the dislocation. And we presented this article in the year 2005. And those who are in this business of craniovertebral junction know that this concept has completely revolutionized craniovertebral junctions. Flexion and extension, there is no change in odontoid process. Open the joint, manipulate the facet, and realign the cranial. By reduction. This kind of basilar invagination, the only treatment was decompression, and still in the whole world probably decompression is the only treatment. But we identified that even when there is no atlantodental interval disturbance, there can be fascicle listhesis of this kind where the C1 is dislocated behind the facet of C2. This dislocation, and this is an unstable situation, and you have to do fixation and you give new life to the patient. There is no need for decompression. Another remarkable thing that we introduced was even when there is no atlantodental interval disturbance, there is no facetal malalignment, presence of Chiari and presence of syrinx and basilar invagination, assimilation of atlas, cervical fusions are all indicators of an unstable spine you do fixation, the syrinx will reduce, the tonsil will go up, and you will get a new human body in the immediate post-operative period. So instability is due to muscle weakness. Instability is due to disuse or misuse or injury of the muscles of the nape of neck, and you can get long-standing instability leads to protection. Basilar invagination is due to long or subtle instability, and basilar invagination is a response to that instability. So basilar invagination group A and group B are both unstable, and stabilization is the treatment, and these are my articles on the subject. So you see there is no atlantodental interval disturbance, but there is a facetal instability type 2, and there is syrinx. You do fixation, the syrinx goes, the tonsils goes up, and the patient improves remarkably. Even when there is no atlantodental interval disturbance, there is no facetal malalignment, presence of basilar invagination, Chiari malformation are indicators of unstable spine, and you have to do atlantoaxial fixation. There is no need for anterior decompression. There is no tight posterior cranial fossa, and there is no need for doing posterior decompression in such cases. Over the years, we have got several hundred cases where we have treated Chiari and syrinx of this kind: no atlantodental interval disturbance, facetal malalignment, atlantoaxial fixation, and the result is new human body, a new human being without any symptoms in the immediate postoperative period. The syrinx will go in 100% of cases if you do an imaging after 1 year. Syrinx can go in the immediate postoperative period in about 20% of cases within 2 weeks of surgery. So this is in the early postoperative period, and this is the delayed postoperative period. There is no decompression, and there is only fixation. So atlantoaxial instability is the cause. Basilar invagination, syringomalia, Chiari malformation are secondary. Secondary and natural protective. I call them children of one father, and that father is atlantoaxial instability. And there are several children like basilar invagination, syringomalia, Chiari formation, assimilation of atlas, bone fusion, platybasia, spina bifida, C1 bifid, os odontoideum are all response or all children of one problem, and that is atlantoaxial instability. So we introduced this article in 2013 saying that atlantoaxial instability is the cause of Chiari malformation and atlantoaxial fixation is the treatment. And we recently wrote this article with 388 patients with Chiari and treated by fixation. And you must read this article where I mention 100% recovery from all symptoms. So Chiari is not a problem, it is a solution, it is a protective airbag. It is introduced to protect the human body from odontoid process, and it is not a malformation, it is a natural protective formation. Cervical fusions are also children of atlantoaxial instability, and they are secondary and they are protective response. When there is bifida, spina at C1 bifid, it is also bifid is also protective response to atlantoaxial instability. You do atlantoaxial instability, that is the treatment. So when there is multi-level spinal fusion, there is spina bifida or C1 bifid, the treatment is one, and the treatment is atlantoaxial stabilization. Os odontoideum is also a protective natural phenomena. In a response to atlantoaxial instability, you do stabilization of atlantoaxial joint, and that is the treatment. There is a cyst here, retroodontoid cyst, and that cyst is also a protective phenomena, and this we wrote in our article on the subject. So C1, C2 fixation is the treatment. Syringomalia is another child of atlantoaxial instability. It is natural protective. It is secondary. You don't have to treat syringomalia. You have to treat the father, and that father is atlantoaxial instability. Idiopathic syrinx, nobody knows what is the treatment, but treatment is atlantoaxial stabilization. More important than reduction of series syrinx is a remarkable recovery in symptoms. All these musculoskeletal changes like short neck, torticollis, and various other spinal fusions are reversal. There can be a reversal following atlantoaxial stabilization. These are also secondary, and these are also protective. Short neck, torticollis can reduce, the neck can increase in size, the neck can become straight by only procedure, and that procedure is atlantoaxial stabilization. So we have got several cases like this where we have made them small neck to short neck, crooked neck to straight neck, and no smile to big smile, and the treatment is only fixation, and that produces the magic of a kind that we have never seen. Kyphoscoliosis and presence of syrinx and Chiari. Kyphoscoliosis is also a child of atlantoaxial instability. You do only atlantoaxial fixation. So now my concept is kyphoscoliosis of all kinds, of all types, does not need direct treatment. Always central atlantoaxial instability is the cause. Even in the absence of syrinx and Chiari, you do atlantoaxial fixation and you can get a straight body in a very early postoperative period. So atlantoaxial instability is the cause of spinal alteration and dorsal kyphoscoliosis. So when there is basilar invagination, facetal instability, kyphoscoliosis, you do atlantoaxial stabilization and you get a straight back in very quick without doing any direct fixation of the spine. So this is a very important thing. You can give smiles, you can give body, you can give limbs, and you can absolutely give birth to a new smile, and that smile is following atlantoaxial instability. Central axial atlantoaxial instability is when there is nothing that can be indicative of atlantoaxial instability by validated parameters of radiology, but there is the atlantoaxial joint is unstable. In this situation, there are several indicators of atlantoaxial instability that we have to learn and we have to understand. So there is no compression here. There is nothing that can indicate atlantoaxial instability, but there is one little evidence of spina bifida C1, which is an indicator of C1, C2 instability. You do fixation and you give magic. Spinal kyphosis is also an indicator, no compression, but you see multi-level stabilization, and the hand was not moving up. The hand moves up in the very early postoperative phase. Shoulder was dropping. Shoulder is now back in action. So foramen magnum decompression surgery, anterior transoral surgery can both become historical without any doubt. Now I want to take the same concept on to cervical spondylosis. We have done anterior approaches for a very long time, anterior surgery, anterior decompression, multi-level decompression, anterior instrumentation. I had introduced tricortical screws long time ago. So we were very good and very happy with what we were doing with anterior cervical surgery. But then we realized that it is not the disc which is the problem. It is the muscles which are the problem. And it is these muscles relate the problem to the facets. So facetal instability at the facet, vertical spinal instability is the issue. In craniovertebral junction, arthritis, nobody has ever mentioned about craniovertebral junction degeneration. When we talk of degeneration, we talk of C5-6, C4-5, C6-7, but never C1-C2. I have to say that C1-C2 degenerative spine is the most common form of spinal degeneration. Bone formation in the craniovertebral junction is secondary. Reduction of the joint space. You see very carefully this slide. Reduction of the facetal space. Buckling of the posterior longitudinal ligament, osteophyte formation are not primary events. They are due to vertical spinal instability, and they are not, the treatment is stabilization. There is no need to remove this osteophyte or to remove this buccal posterior longitudinal ligament. Bone formation in the apical ligament is an indicator of unstable atlantoaxial joint. You have to do stabilization. No decompression is necessary. Another remarkable thing that we introduced in the literature for the first time is that retroodontoid pseudotumor is like osteophyte in the subaxial spine. It is an indicator of atlantoaxial instability. There is no need for anterior decompression or posterior decompression. There is a need for atlantoaxial stabilization. So atlantoaxial instability is the cause of retroodontoid pseudotumor, and the treatment is atlantoaxial stabilization. Retroodontoid cyst, the problem is not the cyst, problem is unstable spine. You do stabilize the spine, and there is a possibility of immediate postoperative disappearance of retroodontoid pseudotumor. So this is a huge concept. There is unstable spine, there is cyst, you stabilize, and there is no need to touch the cyst. So this treatment is quite an important thing. In rheumatoid arthritis, pannus, we all know that pannus decompression by transoral route was the favorite treatment of rheumatoid. But we said that pannus is due to buccal posterior longitudinal ligaments, due to vertical collapse of C1, C2. You do stabilization, and the pannus will disappear in the immediate postoperative period or maybe in the subsequent postoperative period. So this is the intra-articular spaces we described for rheumatoid arthritis and for other craniovertebral junction stabilization. So these spaces, those who do craniovertebral junction know this. So similar concept we introduced in cervical degeneration. You see the facets are the strongest part of the subaxial spine, much stronger than the vertebral body. So we introduced the concept that retrolisthesis of the facet is the bottom line of degenerative spine, not the disc, due to muscle weakness of the back. So there is listhesis or telescoping of the spine. So we introduced the concept that reduction of the disc space, bulging of the disc, osteophyte formation, multi-level disc bulges are not primary phenomena. They are secondary, and they are indicative of multi-levels or single-level spinal instability. So vertical instability due to muscle weakness is the issue. In the year 2010, we published this article that open the joint, distract the facet, and the ligament, this osteophyte will disappear. There will be increase in the disc space height. There will be bulging, ligamentum flavum will disappear. So osteophyte is not primary. Ligamentum flavum bulging is not primary. Disc space reduction is not primary. It is primary is the listhesis. Due to muscle weakness, you distract the facet, and you have the potential to completely reverse the process of spinal degeneration. You see multi-level spinal osteophytes, multi-level ligamentum flavum bulging. We have done multi-level spinal facetal distraction, and you see the spine has completely, the curvature has gone, the osteophytes have gone, the ligamentum flavum bulging has gone, and there are new disc formation, new disc. So this is a remarkable concept, disc herniation, and we have distracted, the ligamentum flavum is tight, the disc is gone, and there is multi-level spinal facetal distraction. So you can do multi-level spinal distraction. The neck movements are not very much affected. Ultimate aim is instability is the problem, and stabilization is the treatment, like we do for basilar invagination. Stabilization, distraction, reduction. I show you another case of multi-level spinal osteophytes, ligamentum flavum bulging, and you see here immediate postoperative, there is new disc, the osteophyte is gone, the ligamentum flavum bulge is gone, and after some time there is arthrodesis by multi-level facetal distraction. This is another case. You see multi-level facetal distraction, there is arthrodesis here, there is disc herniation, that disc herniation is gone, and there is bone fusion and arthrodesis. So we introduced this concept that primary issue is instability. All the other things are secondary and protective. I am saying osteophyte is protective. I am saying ligamentum flavum is protective, that bulge, and arthrodesis and stabilization is the treatment. So we have got several hundred cases like this where we have not done any kind of decompression and only arthrodesis or stabilization by distraction, reduction, and fixation. You can see the osteophyte is gone, there is new disc formation, and there is these are things which are happening, and there is arthrodesis of this area. So there intrafascical, intra-articular spaces was a new concept that we presented. So this was my article in 2011, which was published as cover page of Journal of Neurosurgery. Open the joint, distract the facet, and reverse. And this is an alternative hypothesis of spinal degeneration, which I believe is a revolution in the field. So these are my spacers, and these are my patents in various, there are 22 patents that I have on the subject. In the presence of a disc herniation, you see this is a disc herniation, the whole world will come and do the decompression and resection of the disc, but in presence of intact posterior longitudinal ligament, you can do distraction and fixation. The disc can go back in the immediate postoperative period, as you can see, and you must read in this article where I have shown several cases of immediate postoperative reduction of the disc. So the disc herniation may not be directly attacked or treated. There is a process of indirect treatment. Same concept we took to lumbar canal stenosis. Multi-level spinal stenosis or degeneration can be treated by multi-level spinal distraction with facets. And I wish you can go and read my article on this subject in the year 2011, where we introduced the concept of no decompression and only fascial distraction as the treatment. We studied several anatomical and biomechanical issues regarding this. So the issue is decompression of the compressed and deformed neural segment has been the basis of treatment. So what I'm saying is there is no need for decompression. This is an unstable spine, and only fixation is the treatment. So we introduced this concept of only stabilization without decompression. And more recently, we published this article on the basis of our experience of 215 cases, where we have said that muscle weakness related spinal instability is the cause of spinal degeneration, and spinal stabilization is the treatment. So this is multi-level degeneration. You do only fixation. There is no need, and you have to go and see which joints are unstable beyond this on the basis of radiological parameters and clinical parameters, and do stabilization. And this patient has got a new life. Unfortunately, she speaks Indian language, and you will not understand. This boy also speaks in Indian language, but he has got a new life. There is no decompression. This spinous process are used for bone reconstruction. And you see this herniation is completely gone in the immediate postoperative period. By only stabilization, there is no decompression and no indirect decompression by fascial distraction. You see, this is multi-level, and the whole system has become normal. These osteophytes have disappeared, and there is only fixation as the form of treatment. You see this beautiful osteophyte. You will definitely like to come from front and remove, but there is no need to do all that kind of removal. You do only fixation. I am saying osteophytes are secondary. I am saying osteophytes are protective natural procedures. Multi-level osteophytes, and these have gone after only fixation. Osteophytes have disappeared, only stabilization. There is no decompression of any kind. So degenerative cervical myelopathy, the issue is unstable spine, like basilar invagination, and stabilization is the treatment. Instability is the cause of symptoms, and stabilization is the treatment. There is no need for decompression. It is not neural deformation or compression, but instability that is the cause of spinal degeneration. We use transarticular screws, which Camille had described, and we have modified it by using 2 screws in selected cases at each level by transarticular fixation. What are the indicators of spinal instability? You must read this article of mine, which gives you a complete, see this osteophytes. The osteophytes have disappeared, and there is arthrodesis, and there is no decompression, and you see the patient has completely improved in the symptom. This is another case with multi-level degeneration. The whole spine has come to normal without any decompression, and you see the arthrodesis. there's another case, and this is only arthrodesis as treatment. So this is an absolute revolution in the treatment of spinal and lumbar degeneration, where there is no need for decompression, there is no need for anterior surgery, very simple, straightforward Camillase technique of fixation, and you can have a very solid fixation. So this is the technique, but there is no time to show multi-level spinal degeneration treated by only fixation and arthrodesis without any form of anterior surgery, without any form of spinal decompression, without any. So this is, sorry for this, there is some repetition here. So what is the atlantoaxial joint? We always ignore in spinal degeneration. My concept is atlantoaxial instability is very commonly associated with multi-level spinal degeneration. Atlantoaxial instability, particularly when the symptoms are more pronounced. You see, there is multi-level degeneration. There is no compression, but there is a type 2 atlantoaxial instability, and you have to do atlantoaxial stabilization. If you do not include atlantoaxial joint in this stabilization, you are certainly not going to improve this patient. You see, there is facetal instability. There is a issue of central instability at the atlantoaxial joint, and what the treatment is atlantoaxial and subaxial stabilization without any form of degeneration. Particularly when there is severe myelopathy, atlantoaxial joint is almost always unstable, and you have to include atlantoaxial stabilization and subaxial stabilization, and you give wonders to these patients. When there is C1, C2 instability, when there is C2-3 fusion, assimilation of atlas, there is an issue of atlantoaxial instability. You see multi-level instability, you have to do C2 has to be included. In C2-3, this article I'm showing is alternative technique of atlantoaxial fixation by C1, C2 stabilization by C2-3 fixation. You must read this article. Like to fuse C1, C2, you can do C2-3 fixation. So this C2-3 fixation is as good as atlantoaxial fixation. So this is an alternative technique. You have to, of course, cut the C2 spinous process muscles. So multi-level instability with bad myelopathy, there is atlantoaxial instability, and you include C2-3 joint in the fixation procedure, and you can only see magic, and that magic you have never seen with any kind of anterior surgery or any kind of decompression surgery or any kind of corpectomy surgery or any kind of laminoplasty surgery. So we have got several cases where we have resorted to C2-3, which is as good as atlantoaxial fixation, and there is multi-level subaxial fixation. When you have done anterior fixation and the patient has not improved, like you have done this kind of fixation and the patient has not improved, and even when there is no compression, there can be atlantoaxial instability. You do atlantoaxial stabilization, and this is, I call, adjacent segment atlantoaxial instability, and you certainly produce magic. You see, there is a fixation here. Patient has not improved. So there is a central atlantoaxial instability. I have done atlantoaxial stabilization, and this patient here has a magic. I cannot show you the video due to short of time. Same concept you can use for lumbar canal stenosis. You read the title, Analyzing the Role of Stabilization and Futility of Decompression. There is no need for decompression in lumbar canal stenosis. This is multi-level lumbar canal stenosis. The whole world will do decompression. I am saying this is an unstable spine. These bulges are due to secondary reduction in the disc due to the unstable spine. You do multi-level spinal stabilization, and you have not to do any kind of decompression, which is a wrong surgical method. So lumbar canal stenosis is not primary. Lumbar canal stenosis is due to weakness of the muscles. This claudication pain is due to weakness of the muscle when you walk for a distance. And these are secondary indicators of unstable spine. And we have got several patients and articles on the subject. I wish you read, where we are saying that lumbar canal stenosis should not, stenosis is a wrong term. Multi-level spinal instability is the best term, and you have to do multi-level stabilization without doing any kind of degeneration, and these osteophytes will eventually reduce or disappear. And there are several patients where we have done this kind of treatment without any, and I have no hesitation to say that this will create a revolution in the field of understanding of lumbar canal stenosis, cervical canal stenosis, and the treatment is only fixation. And we have my several articles relate to this issue, and I wish that you read my articles. Lumbar canal stenosis in old and lumbar canal stenosis in young are all different kind of issues. Degenerative spine and spinal scoliosis are indicators of multi-level spinal instability. You don't have to do any kind of osteotomy in these cases. You have to do only stabilization, and you will see absolute new patient in the immediate postoperative period that you have never realized with any kind of treatment. So is it necessary to remove the osteophytes in degenerative spine? No question. It is. Osteophytes are divine interventions not to be treated directly. We recently wrote one article on osteophytes as to what happens, and we said that osteophytes disappear following fixation. Is the term spinal canal stenosis a misnomer? Absolutely correct. This kind of spinal kyphosis are manifestation of multi-level spinal instability. Several of these cases have central instability. So you have to treat by only stabilization. Decompression is not the treatment. I will like you to read my article to get more details of what I'm talking about, but I am saying that decompression of any kind from front or back is not a good option. And we have got several cases of this kind of kyphosis where we have treated with atlantoaxial stabilization, with subaxial stabilization. You see the C23 is like atlantoaxial stabilization. Now I take you to another magical statement. Prolapsed disc. I'm saying prolapsed disc should not be treated by discoidectomy. I'm saying prolapsed disc is a result of unstable spine or results in unstable spine, and stabilization, only stabilization is the treatment. This kind of disc herniation, you do only stabilization, the disc will disappear in no time, and there will be no disc after 3 months or 4 months. And of course, this you have to really read this article to get this concept that facetal fixation arthrodesis in spinal cervical radiculopathy without discoidectomy. This lumbar disc, whole world will jump on the disc. I am saying you do only stabilization and the disc will disappear. And that is a magical form of treatment and a revolutionary form of concept. So we are having, you see the disc, and this disc has disappeared. There is disc herniation. The disc has disappeared without directly touching the disc. So obviously this is a new kind of philosophy, a new kind of thought, and it will provoke many people, and it can lead to various controversies in various minds. Same concept we have introduced for lumbar radiculopathy, where the disc herniation was treated by only stabilization. So ossification of the OPLL is another very controversial. Nobody knows what is the problem and what is the treatment. So we have said that ossification of OPLL and cervical spondylosis, the cause is the same and the treatment is the same. So OPLL, several people have treated by anterior decompression and posterior decompression and fixation. We had described oblique corpectomy for this kind of procedure. You see oblique corpectomy for the first time. So we were doing anterior surgery for a long time. But now we have realized that atlantoaxial instability and subaxial spinal instability are the cause of OPLL, and only stabilization, like this kind of OPLL, should not be treated by anterior surgery or posterior surgery. It has to be treated by only stabilization and no decompression. So this is my article on the subject. And I wish that you read this article to get more details of treatment, because it is magic. It is revolution. And recently we published our experience with 52 cases where only fixation has been shown to be a very effective form of treatment. Many of these cases, atlantoaxial joint is included in the fixation procedure. And the OPLL will eventually reduce in size and will disappear. You see anterior surgery for this or posterior surgery, a very controversial and confusing concept. You follow this concept, you follow this revolution, only fixation of the spine. And we have got several patients like this, and we have published on several occasions. I wish that you learn this technique of Camilla's technique, and you learn my modification, and you get this double insurance fixation, and you do beautiful. So in short, atlantoaxial and subaxial cervical fixation, can it revolutionize the treatment of cervical degeneration and OPLL? I am saying yes. I am saying absolutely. Anterior surgery, decompressive surgery, decompression, corpectomies can be completely become historical, and only fixation is the treatment. Anterior form of surgery and can find a space in history books. So all these procedures are possible to go in backdrop and in history. So from only decompression to only fixation, it has been a century-long journey for treatment of spinal spondylosis. So the concept is compression is never primary and decompression is never the treatment. So thank you, ladies and gentlemen.
At the outset, let me owe my debt of gratitude to my old friend, Professor Yoko Kato, for inviting me for this WFNS Foundation ACNS Summer Webinar, jointly organized by WFNS Foundation, ACNS, and Neurosurgical Societies of Algeria, Egypt, Mongolia, and Uruguay. And my congratulations again to Professors Mentor, Sawat, Federico, Enkabar, and very, very special thanks to Professor Nasser, and again to Professor Kato for conducting this educative webinar for neurosurgeons of South America, Asia, and Africa. My talk will be on intramedullary tumors, pitfalls in diagnosis and management. I have no disclosures, and I will be giving my talk, addressing during the course of my talk all these things which are listed here. How easy it is to diagnose an intramedullary tumor from history, how to distinguish tumor from its mimickers, deciding nature of tumor from imaging, and planning a surgical strategy. Are we allowed to give radiation without histology? Best route of entry into the spinal cord? What is the role of frozen section in an intramedullary tumor? How much tumor to be removed in astrocytoma? Strategies for ependymoma and hemangioblastomas. What is the role of neuromonitoring in intramedullary tumor surgery? Is there any role for adjuvant treatment, and how to avoid complications? I will start with the clinical vignette. This is a 51-year-old lady. She has presented with several months' history of progressive bilateral weakness of both lower limbs. She had numbness just above the breast at a clinical level, at D4 level. She had muscle aches, cramps, spasms, urinary incontinence, saddle anesthesia. This patient had a sensory deficit inferior to T1 bilaterally, decreased rectal tone. She had paraparesis, increased tone, hyperreflexia, positive plantar upgoing. And the imaging shows, this picture shows a patchily enhancing lesion inside the spinal cord, very minimal swelling of the spinal cord, and subarachnoid space around that lesion is very well preserved. Obviously, the diagnosis was from this history, from that imaging with a clinical level. They thought it could be an inflammatory lesion, and patient CSF study didn't show a oligoclonal branch. So, what is the next step? Again, we are back to square one, whether it could be a tumor or a demyelinating lesion. And considering the history of lower limb progressive weakness, it is not acute or subacute weakness, and imaging which was consistent with the intramedullary Cori tumor at D1 level, and oligoclonal bands were negative, it was thought that probably this lesion could be a glioma, and it was decided to proceed with a laminectomy C6D2 and to attempt a biopsy or resection of the lesion. So a midline myelotomy was done. The lesion was found to be firm tan tissue, but the frozen section came as inflammatory infiltrate. And this is the picture, the pathology report. It was an inflammatory lesion. Later, it was found to be multiple sclerosis, first episode of multiple sclerosis. No further surgical intervention. Patient was sent to neurology for management of multiple sclerosis and was followed up there. Now, the question is, can we determine with the confidence an abnormality in the MRI, whether it is a tumor or something else? But all of us know that cord appears enlarged when tumor is present, while the inflammatory lesions, they have a normal or a mild increase in cord size. So, but there have been publications like this publication which has come, the authors report 5 cases where the history and clinical symptoms suggested an inflammatory process in the spinal cord. But the MRI characteristics were those of neoplastic lesion, something like the case which we had seen. And what the authors go on to say that whenever in doubt, just a follow-up MRI after a month's observation will be more prudent unless the patient is rapidly deteriorating. So there have been case reports of non-neoplastic intramedullary spinal cord lesions mimicking tumors, as well as a spinal cord astrocytomas mimicking multifocal myelitis. So these type of presentations are common. Here to the left, you see the common neurosurgical problems, glial neoplasms, non-glial neoplasms, cavernomas, spinal dural arteriovenous fistula. These are neurosurgical problems, while to the right, you see more of inflammatory infectious lesions, which are a neurological problem. So can we identify these lesions on MRI? Can we identify non-neoplastic intramedullary spinal lesions on MRI? This picture shows the sectorial involvement is more common. You can see in white that it could be either a demyelinating lesion, very rarely a ischemic lesion or a vasculitis, and very, very rarely only astrocytoma, which will produce a sectorial involvement, while it is very common with a demyelinating lesion. Multiple sclerosis, transverse myelitis, neuromyelitis optica, and acute disseminated encephalomyelitis. This is again another picture which shows the multiple sclerosis. It can present in any corner of the spinal cord, sectorial involvement, while transverse myelitis, neuromyelitis optica can have a cross-sectional involvement, while even anterior horn cell ischemia, vitamin B12 deficiency, they also have characteristic MRI pictures of sites of involvement. Here, this picture shows say a short segment or a long segment involvement, sectorial involvement, is more suggestive of inflammatory lesion. But if you look, if it is associated with enhancement and swelling, tumor comes as a differential diagnosis. So these are some of the differential diagnoses which one should consider if they are not considering a tumorous pathology, which could be sarcoidosis, tuberculoma, dural AV fistula, demyelination, so on and so forth that listed here. But what is more important in tumor, usually they are present with slow growth, symptoms precede tumor discovery, sometimes even up to a period of 2 years, and pain is usually the earliest symptom. This happens in tumor. But tumors can also have these types of presentation, where there will be progressive relapsing course, as in multiple sclerosis, secondary progressive course, or primary progressive course. Tumors can also present like this. These are the presentations classical for an inflammatory lesion. But what is more important is an acute or subacute clinical course. Usually in the presence of systemic involvement, as we have for some autoimmune diseases like SLE, Sjogren's disease, rheumatoid arthritis. So if a patient has a acute or subacute course with a long segment, a cord lesion, it is usually suggestive of a demyelinating process. But one should keep in mind that sometimes demyelinating illness can have a recurring course. So what is characteristic in intramedullary spinal cord tumors? Cord expansion. Cord expansion is one of the characteristic features of spinal cord tumor. If it is absent, it more suggests a non-neoplastic etiology such as a demyelinating disease, sarcoid, amyloid angiopathy, pseudotumor, dural AV fistula, cord infarction. Second is enhancement. Although all spinal cord tumors show some enhancement, the converse is not true. So the absence of enhancement does not exclude an intramedullary neoplasm in the presence of cord expansion. So if cord expansion is there and there is some enhancement, it is more suggestive of a tumor. And what is the pattern of this enhancement? It could be uniform enhancement as in ependymoma, or a patchy enhancement as in astrocytoma. And sometimes you can see a mural nodule as in hemangioblastoma and pilocytic astrocytoma. And next is, where is this location of the tumor in relation to the cord? Usually it is a central location in ependymoma and it is an eccentric location in an astrocytoma, while it is pile-based in hemangioblastoma. And all of us know that the cysts are of two types. It could be a tumoral or a non-tumoral cyst. Cysts located at the poles of the solid portion, they are always the tumoral cysts. And these cysts are not part of the tumor itself, and they just represent a reactive process. So tumoral cysts contained within the tumor itself, and frequently tumoral cysts are usually within the tumor. And they tend to be more commonly seen in astrocytomas and ependymomas. But polar cyst, as I have told you, is always suggestive of a reactive process. So what is more important is significant cord enlargement is rare with no neoplastic lesions. Ring enhancement, even though it is very common for a glial neoplasm of the brain, it is uncommon for spinal cord tumors. Spinal cord tumors usually will not show a ring enhancement. If it is a ring enhancing tumor inside the spinal cord, it is more suggestive of a cord infarction or a radiation myelopathy if patient has had radiation. Most intramedullary neoplasm, as I told you, will demonstrate homogeneous or heterogeneous patchy enhancement. Non-neoplastic lesions have more rapid presentation, generally over days to months, whereas neoplastic lesions tend to present for months to years. So this is our classical ependymoma, usually seen in adults, and it is the most common intrinsic tumor in the adult population. Matrixin, it can occur anywhere. As opposed to astrocytoma, this is more common in children. If they can have more, sometimes a hollow cord involvement, and there are various grades of astrocytoma. And these are some of the different characteristics in location, morphology, enhancement, hemorrhage in between astrocytoma and ependymoma. And all of us know that ependymomas are centrally located, astrocytomas are eccentrically located and more ill-defined. And hemorrhage and other characteristics are more common for Ependymoma, an enhancement is usually intense or focal in ependymoma, while it is patchy and irregular for astrocytoma. And this is the third important tumor with neurosurgency. It is a hemangioblastoma. And sometimes it is associated with von Hippel-Lindau syndrome. They are typically posterior in location, and they person marked enhancement of the solid component. They usually associated with polar cyst. And sometimes you can see even arterial flow voids in the MRI. Now look at this scan. Here, one is astrocytoma and one is ependymoma. It is very difficult to differentiate these MRI characteristics, whether it is a tumor, ependymoma, or tumor based on MRI. So this is before. So what is the role of surgery in a patient who has an incidentally detected tumor? So what I do is, if the patient is totally intact, I always wait for first neurological signs to develop before putting my knife. And this is what is more in the management philosophy of intramedullary tumor. So one should never, as I told you in one slide before, that it's very difficult to conclusively tell whether the lesion is astrocytoma or MR or ependymoma based on MR. So always one should go with the assumption that, this tumor is a benign ependymoma, I should plan a total removal. And while operating, one should look for a clear dissection plane, and surgical gross total removal should be the goal if surgeon can enter into get a fine, clear dissection plane and attempt total removal if intraoperatively a good plane is identified. And another thing is, never send a patient for biopsy a spinal cord lesion. Never send a patient for radiation without biopsy if you see an intramedullary lesion. So there is no role for radiation without biopsy. And what is the best approach? Is it through posterior midline or directly on the side where the tumor seems more superficial? So ependymoma is usually a midline approach, while astrocytoma, it depends on what is seen on imaging, clinical disability and intraoperative finding. Usually a midline approach if it's directly dorsally exophytic. And it could be through the root entry source if in patient has a non-functioning hand. And what about midline draining veins? They are usually not in midline, sometimes to one side. So one cannot predict that midline based on these dorsal veins. But how you distinguish it between, you can approximate the midline by looking at the root exit zone on either side. So you can approximate the midline. And midline, you always see a vertical array of veins through the posterior median septum. So spinal cord, so where you perform myelotomy, it is usually at the thinnest area between the tumor and spinal cord. And myelotomy should be made in a linear fashion to spare vertically running white matter tract. These are some cartoons. Usually one do a midline myelotomy. Usually it is at the site of greatest enlargement. We should extend over the whole length of the tumor. Myelotomy is deepened by spreading the forceps in a longitudinal direction. Then if the tumor poles are identified, the polar cyst, if it is there, one enters there because dissection is very easy from the site where there is a cyst, polar cyst. One should make a bold myelotomy and enter into the tumor before taking biopsy. Pile traction sutures are placed and then biopsy is taken. If the biopsy report shows it is a malignant tumor, then one should not do aggressive surgery. Some of the differentiating features at operation between ependymoma and astrocytoma. Ependymoma is red, dark gray as opposed to astrocytoma, which could be gray, clear margin for ependymoma. Usually these margins are not seen for astrocytoma. And ependymoma is lobulated and it is unencapsulated tumor. So they are lobulated, they have variable vessels of the tumor. while these things are not there for astrocytoma. So if the polar cysts are present, removal is started from the cyst area. Polar cysts are absent, then the tumor is started from the midline portion. And there is no effort to carry out the tumor removal en bloc. En bloc resection leads to too much manipulation of normal cord. So this is what we do is you can decode the center of the tumor with the CUSA, ependymoma, the lateral margin folds in, you can get into a good plane and you can retract the tumor and with sharp dissection, and lastly the attachment to the anterior raphe is coagulated and divided. What about astrocytoma? You know that priority is for preservation of neurological function. There is no effort to define a plain tumor removed inside out until glial tumor interface is recognized. So what is controversy is how much astrocytoma what could remove. Several studies have shown that there is no correlation between extent of resection and incidence of recurrence or progression-free survival. But some studies have shown that there is some increased survival with radical resection rather than with partial resection or biopsy. So what is recommended is as radical a resection as dictated by tumor plane and changes in electrophysiology in benign lesion. So how do we monitor? A combination of motor evoked potential and D wave is what is all we do for while doing intramedullary tumor. This monitoring cannot it cannot predict, it cannot prevent neurological insult, but it can predict neurological recovery. Like, you know, if a MVP is lost, you know that patient is definitely going to have a neurological deficit. But as long as the D wave is kept above 50%, you know that this deficit is temporary and patient will improve. So these are some of the examples. This is astrocytoma which I operated some time back in a nursing student. You can see it extends right from medulla to the whole segment of the spinal cord. And you can see the whole girth of the cord is filled with tumor. And this is the operative video. I have already done a myelotomy of the cervical region and decompressed the tumor. Now I am cutting through the medulla. So this tumor was extending from the cervical cord up to the medullary region. And you can see the astrocytoma, sometimes you get a very good plane of cleavage, as it happened in this patient. Now I can see normal cord appearing. And this tumor, I could remove in virtually in total. Now the part of the tumor extending to the medulla. I am again making a myelotomy in the medulla and removing the rest of the tumor which is in the medulla. Ultimately, I could remove this tumor. You can see the whitish cord appearing on the floor of the medulla and the spinal cord. The whole tumor could be removed, and ultimately I could take out this tumor totally. And this is the tumor bed, and this is, you can see, and this is after removal of the tumor. And this is this patient immediately after surgery, didn't develop much neurological problem, virtually was well preserved and discharged. So some of the astrocytomas, you could get a good plane of cleavage. So one should not chase for a plane. If you get a plane of cleavage, one can remove it in total. And this is again another patient which I operated, again happens to be a nurse. You can see the full girth of the cervical spinal cord and medulla is full of tumor. And this patient, again, this is putting pile traction sutures after doing a myelotomy, and I'll run it a little faster. And here you can see again ependymoma as expected. You get a good plane of cleavage. And I could remove this tumor totally. And you can see the tumor bed there. Tumor has been removed totally. Tumor is you can easily get into the dissection plane. And this forceps is the SS forceps which I use for acoustic surgery, where you can do very sharp dissection for the tumor. Ultimately, whole tumor could be removed. You can see the a tumor, but totally devoid of tumor. And this is the post-op scan of the patient, and sorry for that image. This patient also did well, but had a tracheostomy in the post-operative period. This is yet another patient. You can see a case of ependymoma in the cervical cord, just to show you that you don't have to do a laminectomy. You can do a laminotomy, and again we are opening the dura. After that, splitting the dura open, and after that doing dissecting the veins away, midline veins away, doing a midline myelotomy, and then developing the plane of cleavage between the tumor. You can see the tumor there. Cord has been retracted with pile traction sutures, and you can see very good plane of cleavage in this ependymoma, and ultimately whole tumor could be removed, and after that closing the arachnoid back. And this patient did extremely well, as seen in this picture, and total removal. This is yet another case, large tumor. Say again, one can dissect the tumor out, as I have shown. This is ependymoma, where I could remove the tumor in toto, and patient did extremely well. This is one of my precious cases. This is an engineering student who refused surgery after detection of this tumor. You can see the whole cervical cord, girth of the cord. You can see in the lower left picture, whole girth of the cord is filled with tumor. They refused surgery. When I told that patient can have some problem after surgery, but they refused. And this patient, when she had respiratory distress, came to me, and you can see the right sided picture. Whole tumor was removed, and you can see the atrophic cord. And this is this patient after 4 months, was on ventilator for close to 2 months, and slowly recovered totally well. And that happened to be a case of ependymoma. This is the last tumor which I want to show. This is a case of hemangioblastoma in a BHL case, a very sick patient. First, my colleague removed this cerebellar hemangioblastoma. This we embolized, and he removed it. And after that, this is the spinal tumor, large tumor. Patient is very sick, and I decided to go for it. We did the embolization of the feeders. And what is the strategy is in vascular lesion, where we attack is directly where the tumor is seen in supine location. As seen in this video where we are dissecting, I will run it little faster. And then here, unlike ependymomas and astrocytoma, one cannot enter into the tumor and debulk the tumor. Hemangioblastomas, one way it is good is usually they have a polar cyst. One can get into the correct dissection plane if we start opening the cystic end, and then after that one can easily find the plane of cleavage and cast the feeders as they come by. And here you can see the hemangioblastoma getting slowly dissected out, and we could remove this tumor in toto, and one can see here the whole tumor is coming out. This is the tumor, and this patient also did, after surgery, this patient also did extremely well. This is again, I'm sorry for the image, but patient did very well. So what about polar cyst? Should we put a drain? No need to put the drain in the cyst if you have removed the tumor in toto. And what is the outcome in astrocytoma? One should look at the neurological outcome and also oncological outcome. If you do a gross total resection or a subtotal resection, they don't make much difference in the long-term outcome, but partial resection is usually they don't do well. And oncological outcome, even if you do a gross total resection and leave some residual microscopic fragments, usually they don't grow. You can follow them, they remain dormant. So any excision that exceeds more than 80 to 90% is as good as 90 to 100% in terms of long-term progression-free survival in astrocytoma. What is the role of radiation therapy in intramedullary tumors? Should we irradiate low-grade glioma? Yes, if ependymoma one is partially removed, leaves most of the tumor there, you can send them for radiation. And astrocytomas also, where one has done only a biopsy. One should send them for radiation therapy. And as I was telling, astrocytoma, if it is minimally resected or biopsy and high-grade lesion, or there is rapid recurrence after total removal, these are the three indications where you send astrocytoma for radiation, usually 50 grade given over 25 doses. And ependymoma is offered only for incomplete resection. So these days, even palliative chemotherapy is coming up for astrocytoma. So what about progression-free survival? And you can see grade is the most important predictor of long-term survival. And most of the astrocytomas, low grade, they survive 5-year survival of 80%. Ependymoma survival is very good, total resection. 10-year survival is more than 90%, as opposed to a biopsy where it's only 25%. So what are the problems of surgery? This aesthetic pain, usually it won't improve. If it improves, but takes some time to improve after surgery, after our midline myeloctomy. And many of the patients, they remain stable. And even if they develop some preoperative deficit, they improve over a period of time. Now, most important part is how to avoid Maslow's hammer. Maslow is a carpenter who goes around with a hammer, thinking that whatever inside is for surgery. So neurosurgeons should never have that mentality. As I was telling you, sometimes these intramedullary lesions could be a demyelinating lesion. It is treacherous to operate a already inflamed cord, and how can we avoid that? And the next few slides I will show you. I was in a webinar. I was in a workshop in Delhi some time back, and this was posted for transsulcal removal surgery for this young boy of around 20-25 years. You can see a deep-seated thalamic lesion. There was an international faculty who wanted to do a transsulcal approach, minimally optimally invasive surgery for this patient. And very funny, this patient presented with hemiparesis, and this was a lesion, large lesion. I was in the auditorium, patient was being wheeled to the OT, enhancing lesion. But what surprised me was this patient, they said it is a multicentric glioma. And then I was also a little bit worried because the clinical presentation patient had bilateral weakness of lower limbs, which could not be explained by that lesion in the thalamus. And the MRI shows a hyperintense lesion inside the cord. Then I knew that this patient is not a case of tumor. It is a case of acute disseminated encephalomyelitis, which comes after a viral illness or vaccinations. I immediately told my point, this is unlikely a tumor, this is a inflammatory pathology, and surgery was withheld. The patient was referred to the neurologist. So what are those lesions one neurosurgeon should think when they are not unsure about the tumor? In MRI, they are demyelinating illnesses, especially multiple sclerosis, neuromyelitis optica, acute disseminated encephalomyelitis, as I was telling you, and sometimes idiopathic transverse myelitis. So what is prudent is, it is very, very important if in doubt to image the brain, because in multiple sclerosis and neuromyelitis optica, you could see brain lesions as well, which will clinch the diagnosis. So whenever in doubt with the intramedullary tumor, if you are suspecting it is not a tumor, just image the brain. And this is neuromyelitis optica, where one should, they are inflammatory demyelinating lesions, usually seen in Asian, African, and Indian descent patients. And these patients can present with concomitant simultaneous optic neuritis and transverse myelitis, but this happens only in 15 to 40% of the cases. Usually they present with a longitudinally extensive lesion, which can mimic a tumor. But what is more important is if you do a MR of the brain, you can see involvement of the optic chiasm along with this longitudinally extensive myelitis. And this myelitis usually extends to the Roswell, to the fourth ventricle area. But clinically, they can have nausea and hiccups, which are uncommon for intramedullary tumor, and they can have other brainstem symptoms like vertigo, vomiting, hearing loss, etc. And these are FLAIR images showing abnormalities in and around the third ventricle, and also showing lesions near the fourth ventricle extending to the middle cerebellar peduncle diencephalic involvement. So these imaging features are there with a longitudinally extensive spinal lesion. This is characteristic of neuromyelitis optica. And other lesion one should suspect if in spinal cord lesion is multiple sclerosis, where you can have periventricular dorsal finger as seen in this patient. It is also important that neurosurgeon should see the fundus of the patient if to look for any signs of optic neuritis, optic atrophy with the disc pallor, which is more common in these inflammatory pathologies like multiple sclerosis and neuromyelitis optica. And this is the fundus picture in such a patient. And also one should look for central scotoma, sometimes canal blindness, even field cuts, paracentral scotoma. It is prudent for a neurosurgeon just not to chase the spinal cord lesion. If he suspects if it is a inflammatory lesion, you should do a proper clinical examination, which should have an ophthalmological examination as well. The other lesion I was telling you is acute disseminated encephalomyelitis, which can present with both cord and brain lesions. And the last one is transverse myelitis. Usually it comes in the setting of inflammatory pathology like Sjogren's disease or SLE, and sometimes even with sarcoidosis. But idiopathic transverse myelitis, they will not have any of these lesions. So this picture shows that in MS and neuromyelitis optica, brain will show some lesions sometimes. And this is the last pathology which I want to tell, which can fool a neurosurgeon, is dural arteriovenous fistula type 4, where draining veins into the spinal cord can have this hyperintense lesion, which can mimic a tumor. And the clue to this is dural enhancement, which is seen in the MR, and also angiogram will show the draining vein. And this is one of the cases which we treated at my institute at Trivandrum, where external carotid angiogram shows a occipital artery is showing the draining vein, which was embolized, and just after embolization, the cord signal change, even the dural enhancement disappeared. Now, last part of my talk, what is the role of spinal cord biopsy if the preoperative laboratory and imaging studies are diagnostically inconclusive? Is there any role for biopsy to identify what is the spinal cord lesion, and especially if the patient has a progressive symptom? So these are some of the conditions where neurosurgeons should lend help to the neurologist to establish a diagnosis. Especially, it is not a tumor on imaging, but if the neurologist suspects bacterial, fungal, tuberculous or parasitic lesion, it is best to treat by a surgical decompression in addition to systemic therapy. Also, sometimes in isolated primary sarcoid, which can be diagnosed sometimes with biopsy only, neurosurgeons should help the neurologist. And isolated intramedullary MS sometimes is very difficult because it's first time presentation. Nobody will suspect multiple sclerosis. A biopsy can sometimes help to establish the diagnosis, and they also respond well to systemic therapy. And very rarely, inflammatory pseudotumor also will respond to surgical resection. So conclusion is, always quality of life depends on accurate diagnosis, MRI with tractography, preoperative status of the patient, experience of the surgeon, meticulous microsurgery, collaboration with neurophysiologists, intraoperative monitoring, and avoidance of complications. So my last slide is, surgeon should not work with Maslow's hammer. He should not think that anything in the spinal cord should be operated. A mind with Crabtree's budgeon will avoid Maslow's hammer. Crabtree's budgeon is, say, if there are multiple dots, a good neurosurgeon can always join all the dots together. and surgeon should never have a Dunning-Kruger effect. Dunning-Kruger effect is a cognitive bias in which unskilled individuals suffer from illusory superiority, mistakenly rating their ability much higher than accurate. And thank you very much. And thank you very much again, Professor Cato, Professor Nasser, for giving me this opportunity.
Dear friends, it's my pleasure to be part of WFNS Foundation ACNS Summer Web Seminar. My topic today is Evolution in Spinal Metastasis. I'm grateful to the WFNS Foundation and ACNS, and especially Professor Yoko Kato for giving me this opportunity to speak on evolution in spinal metastasis. It's been a pleasure working with both WFNS Foundation and ACNS over the years. I come from Pakistan, and this is the land of amazing beauty. These are the plains which are at the level of 4,000 meters high, and amazing areas up in the northern part of the country. Well, spinal metastasis, we know, is a very important topic for us. Bone is the third most frequent metastatic size of distant spread of carcinoma. Classic primary sites include breast, lungs, prostate, kidneys, and thyroid. Vertebral column is the most common site of skeletal metastasis. 10% of patients with metastatic disease will develop spinal mets, and 1/3 will become symptomatic. 2.5% of these will develop spinal cord compression. Dorsal spine is the most common site, followed by lumbar, then cervical. Spinal cord compression is expected in about 1/5 of these cases, and 5% will present with intradural metastasis and less than 1% with intramedullary metastasis. The causes of neurological deficits could be mechanical vascular instability. Mechanical could be direct compression of the tumor, compression due to vertebral column collapse, and vasculature incompetence due to ischemia and venous congestion. Multiple problems. Loeffler came up with this integrated decision by an interdisciplinary cancer team for optimal clinical management of these patients, and that includes medical and radiation oncologists, spine surgeons, other healthcare professionals, including rehabilitation team, nurses, and other involved medical specialties. Workup that may be required in such patients according to NICE and evidence-based guidelines and according to Dutch National Working Group on Neuro-Oncology includes the minimum of CT, MRI, and a PET scan. Decision-making in these patients is tough. There's urgency to prevent paralysis and potential of post-surgical morbidity in weak patients with a limited life expectancy is a problem. Dilemma in these decision-making is because of tumor load, life expectancy, not knowing the exact pathology, functional status of the patient, age, comorbidities, the bone quality, would it receive the hardware or not, instability if it's present or absent, progression of the disease, and the treatment options available to you when you're treating these patients. The quality and quantity of life is important in that way that you could have a patient who's alive and well, and you can have a patient who's alive but miserable. If the survival is less than 6 months expected, would you consider surgery or not is the question, or would you just do palliative surgery? Prognostic factors include functional status, number of visceral metastases, primary tumor pathology, and age. So you have a scenario like that in this patient with multiple metastases, with mets in lung and liver. Obviously, these patients would have a poor outcome no matter what you do. Direct decompression, surgical resection in the treatment of spinal compression. So Batchel came up with this landmark paper way back in 2005 and showed that direct decompression plus postoperative radiotherapy is superior to treatment with radiotherapy alone for patients with spinal cord compression caused by metastatic cancer. And this is what they showed, that these patients ambulatory after treatment. So the whole thing changes when you had surgery as well as surgery plus radiation. So then there are tumors with high-grade epidural spinal cord compression, and these can be treated in different way. So if you have surgery, radiation, so you can see the surgery patients are overall much more ambulated. A duration of these patients 122 days. Recovery after leading to ambulation is 60% versus 19% in radiation. Continence, then going on for 155 days. Much less requirement of the narcotics, and the survival time 126 days versus 100 days. So clearly a difference between radiation and surgery in these patients. Short-term survival obviously depends on the age, Karnofsky's performance score. Long-term survival, tumor histology, vertebral levels obviously can play a role. Palliative goals of therapy, neurological function of the patients, so spinal cord compression, stability, pain control, and local tumor control due to radiation, either by SRS or external beam radiation. Options can be multidisciplinary, systemic therapy. Nowadays, more and more new targeted immunochemo hormonal therapy are available. Radiation therapy, including conventional brachytherapy, image-guided, and besides that, obviously, gamma knife, cyber knife are available. Then surgery is becoming minimally invasive as you go along. Anterior, posterior combined, in block, intralesional, percutaneous cement augmentation. So Loeffler again came up with this norms decision-making framework in 2013, along with our other friends. And they devised a score as a Memorial Sloan Kettering Cancer Center, and they simplify the treatment decision for metastatic cervical tumors. And this is based on 4 fundamental considerations: neurological, oncological, mechanical, radicopathy. Degree of epidural spinal cord compression was taken into consideration. Oncological tumor histology, were the radiation or chemosensitive or not, instability, and then systemic and medical comorbidities. So for example, and if you look at this favorable, intermediate, and unfavorable outcome of different types of tumors for external beam radiotherapy, and this is from 2009, and this all has changed since then. Because what's happened that all these unfavorable tumors have slowly and gradually become favorable if you're using special kind of radiation, especially some radiation maneuvers that we can do with the help of gamma knife and cyber knife. So previously, what we used to have that favorable tumors were obviously given radiotherapy because they were radiosensitive, and these were generally considered for surgery. Bilski and Loeffler again showed that spinal cord compression validation system, is it possible? Can we use this? And they looked at this special epidural spinal cord compression from high grade to a lower grade. And they divided this basically into 4 scales where the tumor was confined to bone, which was 0. Tumor extension into the epidural space without deformation of the spinal cord is 1. And then, with no deformation of thecal sac, with or without spinal cord abutment, and then deformation of thecal sac with spinal cord abutment, but without compression. Whereas then grade 2 was spinal cord compression, but CSF was still visible, and grade 3 spinal cord compression without visible CSF. So here we can see a low grade epidural spinal cord compression, whereas the high grade in which the compression is much, much, much severe. So you can see a no CSF space seen there. So the neurological and oncological assessment include, was this patient radiosensitive or radioresistant? So if it was a low grade epidural spinal cord compression, what you did was if the radiosensitive, you give radiotherapy, radioresistant, SRS, plus minus surgery. High grade, external beam, and then if it's radioresistant, then surgery plus radiosurgery. So radiosensitive tumors include, if there's a low-grade epidural spinal cord compression, then if it's radiosensitive, obviously external beam or radiosurgery. So for example, a patient like this who had treatment on the 22nd of the 7th, and you see within 9 days' time, There's not much of tumor left in this patient, although it was a high-grade compression, but very radiosensitive. Neurological assessment is critical in determining what you're going to do. So epidural spinal cord compression, if it's high-grade, but the safety of delivery of SRS require 2 to 3 millimeter margin on the spinal cord in order to avoid radiation myelitis. So most commonly SRS used is restriction to tumor confined to bone or minimal epidural impingement. So that was the idea. But all this changed when separation surgery was started in many centers in US, and then slowly spread to all over the world. And the idea was to decompress the spinal cord in order to reconstitute the spinal fluid space in conjunction with long screw rod instrument fusion. And what they did was they had 186 patients, and they looked at the cumulative incidence of recurrence of 16% in 1 year after 1 year. This decompression provided a safe margin to deliver a cytotoxic radiation dose to the tumor within the constraints of spinal cord tolerance. Molding reported the outcome using high dose, 18 to 24 guys, a single fraction SRS after separation surgery, resulting in local disease control rates with an estimated 1 year local recurrence of only 6.3%. So all this continued to improve and evolve over time. So if you've got a patient like this, in which separation surgery was done, screws were put in, and the space was created. So you can clearly see this is a myelogram showing the space was created. So you see this patient, a 38 female with liposarcoma, separation surgery was done, followed by radiotherapy, and you see brilliant results. So what is the mechanical instability, what we're going to be talking about? In mechanical instability, it's an independent indication for intervention because obviously you can take care of pain. At the same time, neurology improves as well if there's no movement, and the decompression obviously plays a huge role as well. So the scoring system was brought in, which is called SINS, Spine Instability Neoplastic Score. This integrates systemic literature review with expert opinion. It's reliable, high inter and intra-related reliability. It can be validated and has been validated in many studies. So what is SINS? SINS was initially proposed by the Spine Oncology Study Group, and this was way back in 2010 by Fisher and a big group. And what they had was, if it was location, it was junction, you got 3 points, mobile, you got 2 points, semi-rigid, you got 1, and rigid, you got no points. So the higher the grade, obviously, the unstable patient is going to be. Pain, yes. So you get 3 points, occasional non-mechanical pain 1, and no pain 0. Lytic lesions will get 2, mixed will get 1. Alignment, subluxation, transdiction, you get 4, an extra point. De novo deformity gets 2, the normal gets 0. So if the collapse was more than 50%, you get 3, less than 50%, you get 2. No collapse with more than 50% vertebral body involvement, you get 1. And then posterior lateral involvement, that is the posterior elements that are bilaterally involved, unilateral or none. And you get tallied score from 6 components, and we call it 0 to 6, stable, potentially unstable if it's 7 to 12, and unstable if it's 13 to 18. So for example, this patient, a 53-year-old female with breast cancer, bilateral mastectomy, 5 years back, chemo on Herceptin and pertuzumab, and patient is complaining of neck pain, no other metastasis. And if you calculate, location gets 3, the pain relief with recombinant pain with movement, none. Type of bony lesion is lytic, and radiographic alignment is normal. Vertebral body collapse, none. And posterior lateral involvement, you get 3. So you get total score of 6. So this is a stable patient, and you don't need to do anything here to stabilize this patient at all. So respective evaluation of relationship between mechanical stability in response to palliative radiotherapy or symptomatic spinal metastasis. So they looked at SINS of 155 patients with painful thoracic, lumbar, or lumbosacral metastasis from 2 tertiary hospitals, and the patients reported pain response prospectively. Of these patients, 16 patients experienced a complete response and 65 experienced a partial response. A lower SINS indicating spinal stability could be associated with complete pain response to radiotherapy. So you've got a patient who's completely unstable, so you can clearly see, so you get a vertebral body involvement without a collapse, but obviously at the same time, you've got a junction, you've got complete malalignment. So all this will lead to an unstable score of 14 and should be operated because this patient is unstable. So the percutaneous posterior fixation has come in routinely now to stabilize patient and give them radiotherapy just by doing separation surgery. And then you would use high-dose gamma knife, which is especially in radiosensitive patients, something like multiple myeloma with a SIM score of 12, which is intermediate. So you do this, fuse this, and you aggressively give radiosurgery for a brilliant outcome. External beam radiation could be equally effective. So this was the basic scoring for with norms, and I'm going to move forward with this. Takahashi score and other prognostic factors in 260 patients with surgery for vertebral metastasis. This study showed that time from cancer diagnosis to metastatic diagnosis synchronous, less than 2 years, 2 to 5 years, or more than 5 years, will tell us regarding the survival difference. So we looked at surgical treatment, treated spinal metastasis, and we looked at do any prognostic scores have a role. So we had 63 patients, and we analyzed Tomita, Tokuhashi, modified Bohr, and SINS. And we used these different scoring systems. So for example, Tomita, especially looking at the primary tumors, visceral metastasis, and bone metastasis, and getting a score. Revised Tokuhashi, obviously general condition comes into play here, performance status, number of extraspinal bone metastasis, number of METs in vertebral body, METs to major internal organs, primary cancer site, and this is important, and PULSI will lead to a score. And if you've got a score of 0 to 8, it's conservative treatment, whereas with less than 6 months survival. So 9 to 11 score gives you, again, more than 6 months, but again, palliative therapy. Whereas if the score was high between 12 to 15, you think about excisional surgery. And so this was the Tokuhashi revised score with, again, inclusion of degree of paralysis, and these are 6 parameters easy to evaluate. Then came in modified Bohr score for metastatic spine tumor prognosis. And here, the good thing was that you did not need a diagnosis of where exactly the primary tumor is, but if there are no visceral metastases, no lung cancer, primary tumor, breast, kidney, or lymphoma, or multiple myeloma, you get score of 1. And if you had one solitary metastasis, extraskeletal metastasis, then you give those points. When we looked at all these scores, we found that Tomita score provided the highest statistical significance, followed by Bohr and Tokuhashi. SINS was identified as a predictor of instability. Besides that, we had individual factors like age, preoperative neurology, vertebral levels, visceral metastasis, and they showed positive correlation. So all these are important for us. So in conclusion, the Tomita scores provided the highest statistical significance, followed by Bohr and Tokuhashi, while SINS showed no significant correlation in predicting patient survival. So in conclusion, in our study, we showed that all these factors are reliable for outcome, and SINS for instability, and separation surgery may be the way forward for patients who are radiosensitive and in patients who have got multiple comorbidities. And we did another study looking at disease factors and patient factors, and and we looked at the predictor of prognosis, and we showed that in spinal metastasis, disease factors were more significant than patient factors in determining the overall survival. This study, which was published way back in 2015, showed that prognostic factors in patients with symptomatic spinal metastasis and normal neurological function, obviously pre-treatment albumin, their defense mechanism, was a significant prognostic indicator for survival. The tumor cancer site, Karnofsky score, and number of visceral metastases were also associated with survival in this study. So this there was this phase 2 clinical trial of Saber by immediate vertebroplasty for spinal metastasis showed that radiotherapy plus immediate vertebroplasty compared with historic controls, and to observe whether subsequent late vertebral compression fractures can be avoided. They basically showed that the 3-month pain response was significantly improved in radiation therapy oncology group. And the freedom from vertebral compression fracture was 90% or 2 years. So then we looked at the study, which looked at the comparison between minimally invasive spine stabilization with and without posterior decompression for management of spinal metastasis. And again, it showed the minimally invasive procedure had a better outcome, less blood loss, high rate of discharge to home, lower in-hospital mortality, indicating a procedure with lower invasiveness. Risk factors of pathological fractures and metastatic epidural spinal cord compression in patients with spinal metastasis. This study from 2018 showed that patient with osteolytic spinal metastatic lesion causing pain greater than 25% occupancy of the vertebral body, involvement of vertebral end plate, or all 3 columns could be considered for prophylactic or therapeutic decompression and stabilization of these patients. And again, the study showed that the only significant factor predictive of local control were related to actual dose of the radiation given by the stereotactic radiosurgery, and that has shown again and again to be very, very effective with radiosurgery. If you look back at our history of spinal metastasis treatment, so we used to have radiotherapy alone in these patients before Paschal came up with his idea of trying both surgery and radiotherapy versus radiotherapy alone. So when we were using radiotherapy alone, only 27% of these patients had improvement. And then we came with spinal cord compression, laminectomy with or without radiotherapy, and it improved from there to only 28%. And hence when we move further, we had this treatment of spinal cord compression, posterior decompression and stabilization, and the whole thing moved to 55%. And then when we had vertebral body resection and stabilization, this moved up to 62%. And when we had stereotactic radiosurgery, then we had controls of approximately up to 80% in majority of the series that we have seen. So this progression improvement is really mind-blowing. So spinal oncology study group recommendation for surgery is that strong recommendation is made that patients with high-grade spinal cord compression due to solid tumor malignancy undergo spinal decompression and stabilization followed by radiotherapy. Neurological and functional outcome, pain control, complication, thoroughly documented how we're going to go about this surgery. From the neurological and oncological perspective, surgery is reserved for patients with radio-resistant tumors, which have high-grade spinal cord compression. Surgery is used to preserve or restore neurological function and stabilize the spine. Mechanical instability is an indicator for surgical stabilization, regardless of tumor radiosensitive or histology. In-block resection and metastasis. So if you had a tumor which was invading vertebral body and you do in-block resection and to avoid local recurrence and to improve long-term survival, then that is a very nice way of going about things. Potential indications may include a solitary metastatic tumor in the setting of a well-controlled primary cancer. And this has been shown to be very, very effective in many studies. So in conclusion, stereotactic body radiotherapy revolutionized spinal oncology through delivery of durable local tumor control regardless of tumor histology. Currently, the major surgical indications include mechanical instability, high-grade spinal cord compression, when applicable, with surgery providing notable improvement in the quality of life and functional status for appropriately selected patients. Surgical trends include less invasive surgery with emphasis on durable, long control, and spinal stabilization. I thank you all for listening to me throughout this presentation. And if your questions are most welcome, and you are most welcome to Pakistan at whatever stage you can come. Thank you.
Good day to all the participants. Thank you, the organizers of the WFNS Foundation of the ACNS Summer Seminar. My lecture is coined Pediatric Neurosurgery, Decision More Important Than Incision, or what we have changed in the last 25 years. This is a slide from the visit of President Kennedy in the famous prison of Alcatraz. So when they took all the inmates together to listen to him, he didn't know how to start his lecture. So he said, "I'm happy you're all here." So I'm also happy you're all here. I want to show you a case. This is a 10-year-old with headaches and papilledema due to this posterior third ventricular lump. She underwent an endoscopic third ventriculostomy, and you see actually here an MRI on postoperative day 1 showing a very nice flow void at the floor of the third ventricle. I did not take a biopsy. It was early in my career and I chickened. And the next day after the surgery, she's perfect. She has absolutely no symptoms, no papilledema. What to do next? What to do? Give an advice. So I did what I do very commonly. I consulted with 3 of my mentors at that time. The first said, wait and see, she is well, follow the tumor. The second, more cowboyish personality, said, let's operate and take it out. The third one said, let's do a stereotactic biopsy. So I consulted 4 more. My colleague from Tokyo said, let's irradiate it as a test dose and see if this is a germ cell tumor. From Paris, with the same philosophy, let's give a little bit of chemotherapy and see what happens. We don't do that anymore. Another colleague from New York said, let me do a redo endoscopy. And a 7th one said, let me operate. So from 7 esteemed pediatric neurosurgeons around the globe, I got 6 different opinions. Who should take the decision? Is there a right choice? How do you communicate with the family? I usually tell the family, choose a doctor rather than choosing a treatment options, because they are lost in translation and in all the options that we can provide today. This is from one of my famous mentors, Sir John Gottfried, who said, you can teach a monkey how to operate. You cannot teach a monkey when not to operate. You certainly cannot teach a monkey when to stop the operation. These are my mentors, Fred Epstein, Saul Laurel, Wise Young, and Vedran Delitis. Without our mentors, we would be nothing. I gave this talk first in India, so I put this slide of Bibi, who just lost the election, and Modi in India, and I made a little comparison between Israel and India. So this is little Israel, this is Tel Aviv, where I work, and this is India, where I gave this talk in Bangalore and Madurai, and later on in the Calcutta area. So I superimposed the shadow of Israel on top of India, and look at the comparison of surface area, 20,000 to over 3 million square kilometers. This is when you superimpose Switzerland, for an example. What about birth rate? In Israel, 170,000 new births per year. In India, over 18 million new babies per year. And this is Europe, by the way, about 5 million per year. So over 18 million children born in India a year, over 30 million children born in Africa every year. It is clear that by the year 2040, 85% of the new children in the globe will be from Asia and Africa. So we put this figure, it's a trivial figure, it's on the cover of our journal, Child's Nervous System. On the left is the population of children and patients who need our help. In the middle is what the medical facilities and neurosurgeons can offer. And you see that the overlap is only about 10%. And this is what we're doing right now. We're trying to push these 2 circles together so that the overlap will be bigger than what it is today. This is the Tel Aviv Medical Center. This is the Dana Children's Hospital. This is where my clinics is today. We try to build the clinics in a way that the patients would feel at home rather than in a cold hospital. Why children? Well, children have a different presentation, different pathological spectrum, different philosophy, different treatment options, The technical aspects are not that different for children. But in a child, you've got to create an atmosphere of a children's hospital because you're treating a tribe rather than a single patient with a single family. Children are strong. They're strong biologically and emotionally. An adult brain tumor experience is probably irrelevant to children from the molecular level, biological behavior, response to treatment, and long-term effect. Look at this comparison between pediatric high-grade glioma on the upper row to adult high-grade glioma. Just to see when you compare EGFR, P10, and P53, they go in totally different directions. So the same tumor under standard staining, hematoxylin eosin, is molecularly very, very different. Low-grade gliomas in adults will always undergo malignant transformation. In children, this is extremely rare. In fact, most of the low-grade gliomas in children over time tend to slow growth rate, and some of them may even involute. Again, the same tumor under standard staining behaves in totally different biological directions. This is the Stupp study showing that concomitant temozolomide to radiotherapy in GBMs of adults has an effect, a modest effect, but has an effect. In children with high-grade gliomas, the addition of temozolomide probably does not add anything. And also the long-term effect. When we looked lately at a couple of hundreds of our graduates, 10 years after the operation, 4 out of 5 live. So when we make a treatment plan, we have to think about the long-term effect. We have over 2,000 graduates of pediatric brain tumors in my department. This is a huge traffic because they do MRIs, they have questions, they have queries, and you have to accommodate this community of graduates from our department. The traffic is enormous. I'm sure that my colleagues around the globe are sharing the same problem. Before, a neurosurgeon was single, a wolf. Now it is different. It is different. We work in teams and we've got to get the teams synchronized. The revolution in neurosurgery happened with the microscope, the imaging, and the neuroanesthesia. This, by the way, on the left, the microscope with which I started my residency, the Opni 1. And it is used now for restoration of pictures in the Vatican. And our new microscopes provide us not only with magnification, but also light, total balance, and also with total integration with our navigation system. So we work in a team, and in the team, I would like to mention the pediatric neuroradiologist. On the left is the air cysternography. We don't do that anymore. Actually, I don't have any personal experience with it. On the right is a high-resolution MRI on an NF2 patient. And sometimes I wonder, do we see too much? And of course, we all agonize on the questions on how often to do the MRIs, how to follow, and who should be the one reading all these multiple MRIs that we do to our patients. This is a little acoustic on the left side over there. So about 18 years ago, we published the first paper on DTI. This is the cover of Journal of Neurosurgery, showing that you can show in an MRI the tracts and not only the cortex. This was a revolution. We use it on a daily basis, but the challenge is how to bring those beautiful pictures to improve the care of a single patient. And this is another problem we have, the comparisons of MRI. On the left is a very common sin. We compare the MRI to the last MRI done 3 months before, when in fact, we need to look at the bigger perspective of our patients who do multiple MRIs over time. Each number here is a single MRI. We break the volumetrics of our tumors into solid enhancing and non-enhancing, cystic and total, and superimpose the treatment on it. So when we sit in an oncology meeting, we get a graph. This is a single patient, and you see, and you can take decisions based on the overall picture and the response to treatment. This is a huge amount of work. The monitoring, of course, has become indispensable. It's far more than the MEPs and the SCPs and the mapping of the flow of the navigation of the brainstem, of course, in any epilepsy surgery. But how can you use navigation on a single patient to improve safety? So this is our paper from 10 years ago, looking at the intensity you need to have to provoke the corticospinal tract and the distance that you have from the corticospinal tract to find this wonderful, simple to understand relationship. If you get a response at 10 milliamperes, you're 10 millimeters from the corticospinal tract. We use it with the electrified CUSA. It's simple to use. The adapter is commercially available and non-expensive. And this is just an example. This is a thalamopedunculaire tumor. The bright white is the DTI of the corticospinal tract. So when we did it with the electrified CUSA, and we left tumor behind because as we approach more medially at about 5 milliampere, we got responses. This is the time to stop. Otherwise, you will get a hemiplegic child. The imaging people also alleviate the need for biopsy in some cases. Examples, this is a tactile tumor. The treatment is by ETV, no need for a biopsy. The next is a hypothalamic hamartoma, usually presenting with either precocious puberty or gelastic seizures. The look is so typical that you make the diagnosis based on the MRI. The third example is the neurofibromatosis-associated optic pathway gliomas. They're typical. Even when you need to start biological treatment, oncologists will not demand a biopsy in order to do it. Then the diffuse pontine glioma. The look is typical. So anybody who's got a typical look does not need a biopsy unless he's on a study or the family insists to look at it and get the genetic information. Personally, I've never seen that genetic information has helped a single child. Then there is the double tumors, pineal and suprasellar. They're always germ-cell tumors. Then you have the tuberous sclerosis-associated SEGAs, subependymal giant astrocytomas. In a patient with DS, you know this is a SEGA. You can embark on medical treatment without the need for a real biopsy. Then the neuroanesthesiologists are terribly important as well. There's nothing to say. We cannot live without them. And just a few examples. This is the old machines. They provide us with long operating time, relaxed brain, blood replacements, and total metabolic control. There is a camera at the lamp so that anesthesiologists can see the field and smell, especially in infants when they need fluid. This is just examples. A 2-month-old with an ATRT that bled 7 body volumes during the operation. This cutie was operated at 1-year-old, also had 5 body volumes during the surgery. And this is how she is later on at the age of 7 years. Could have never done without a very experienced teams of pediatric neuroanesthesiologists with you during this battle. The anesthesiologists are important also for craniosynostosis operations. These babies bleed. The positioning is awkward. You've got to be very careful of extubation during the surgery. You cannot do it with a green anesthesiologist. Location in the brain is not that trivial as it looks on the MRI, and it started in the 18th century. It has matured to the frames, the CRW, BRW, and now we're all using the standard navigation systems. With markers or without markers, they're beautiful. Well, you have the cameras, you have the antennas, and you can see exactly where you are in terms of trajectory, the view from the microscope, integrated into the navigation system. Beautiful pictures. However, these standard navigation systems are based on old imaging because the brain is moving. Look at the picture of the MRI on the top. Not only that the surface of the brain is moving once you do a craniotomy, also the midline structures, they move because gravity takes them down towards the Earth. So standard navigation is useless once you go into the brain. And this took about 10 years. We needed navigation systems that are based on real-time navigation, on real-time information. This is the intraoperative MRI by Odin, an Israeli company that was sold to Medtronic a few years ago. And this is the 0.12 Tesla that grew to 0.15 Teslas. And it is quite ergonomic, but it is still a lot of pain, believe me. We needed something which is less expensive and less pain to operate. So the solution came from the ultrasound. The intraoperative ultrasound can provide us with real-time navigation. We have to learn to integrate the ultrasound pictures to correct the old navigation pictures. This is, by the way, my son. They're from SonoOne, and now you have it in several other systems like BrainWeb, etc. We do not open the dura in the spine or the brain without doing an ultrasound first. And look, the pictures, they're wonderful. On the left is an MRI, on the right is an ultrasound of a 2-year-old with a choroid plexus papilloma. So the technology is expensive, it breaks often, it creates accidents, it may mislead you, it creates dependency, and it introduces options. So on the left is the Inca, on the right is our operating room from 20 years ago. We already had the microscope, the navigators, the intraoperative monitoring. So what has really changed? This is, by the way, a couple of years ago, I counted an absurd number of 25 computers and 19 monitors in the room in total. So when you get a new machine, you're first very happy. Then you go into depression because you find the problems, and then you stabilize somewhere in the middle. Common sense is more important than any technology. Low tech is more important than any high tech advent. And this is an example showing that you have to combine the technology to understanding the biology. This is a 15-year-old with a tectal tumor, with a beautiful anatomy to perform an endoscopic third reticulostomy. And this indeed is the first case I did 27 years ago in Israel. So what are the new tools we really have? We have better imaging, there's no question about that. We have interventional neuroradiology, we have endoscopy, it's a revolution. We have better IOM that we had before, the electrified CUSA I've shown you before. We have better chemotherapy for pediatric brain tumors, especially the biological treatment with BRAF and MEK inhibitors. We have better radiotherapy. The planning is better, not only with protons, but also with photons. But most importantly, I think we know today better when to avoid surgery and how to tailor our surgery to combine quality of life and not only length of life in our decision making. Well, prevention is more important than anything. Many patients arrive to our doors late in the course of the disease. So we have invested some research into the concept of DID, delaying diagnosis in pediatric brain tumors, and later on in spinal cord tumors. Well, 50% of the children coming to our doors are delayed in diagnosis, and about half of them have what we have coined unacceptable delay. Interestingly, about half will have a normal neurological exam, and only 1 in 5 will have papilledema. So the history may be more important than the physical examination in some children. How about headaches? Headaches is very important in children, but it's very common. So when headaches becomes alone, it is usually a very poor prediction for having a brain tumor. If headaches comes with vomiting, it is a posterior fossa tumor until proven otherwise. When you look at it from the other side of the primary care, there's a paper by my colleagues. They looked at 300 children with chronic headaches and scanned them. Nobody had a brain tumor. Well, which child with a headache should be screened and which not is a dilemma we have to face on a daily basis. But in order to reduce the incidence of DID, delayed diagnosis in pediatric brain tumors, we have done this short video Look at it. It's on YouTube. It is simple. It is our job to educate. We've translated this video 4 minutes to 6 different languages. Show it to yourself, to your pediatric neurologists, pediatricians, or anxious mothers. Neuroendoscopies is really a revolution. There's no question about it. And when it came in, we were so provoked by it. The principle is you have a block here, you make a hole here. This is how we make it. We go into the lateral ventricle, we make a hole at the floor, and this is how it looks. You see the classical anatomy of the fornix, then the basilar artery bifurcation. You make a hole at the tuberous cinerum. You dilate that hole either with a Fogarty or with an endoscopic forceps, as we did here. It's a bit cheaper. You put the endoscope through it to make sure you are through the Lilliquist membrane to visualize the basilar artery and the brainstem naked. This is an ETV, an endoscopic third reticulostomy. And this is what I've done 27 years ago with this 15-year-old who never needed another procedure for his CSF problems or for his tectal tumor that has never changed in shape since then. Endoscopy has also revolutionized the way we treat tumors. In the posterior third ventricle, we do an ETV and we take a biopsy. This case, by the way, was a germ cell tumor. No need for open biopsy, but you have the foramina of Monro on your way. So how to combine between the ETV and the biopsy? You can do it by 2 bear holes. You can compromise on your bear hole, or you can use a combination of rigid and flexible scopes. This is our paper from Journal of Neurosurgery. Well, decision-making in little evidence-based data is difficult. It's got to be team-based. You have to use what we call intuitive integration, and there are many options. You've got to choose between options. How to do it? Experience is mainly learned from our failures. So we have to keep remembering our failures in order to take a good decision for the next case that walks into our office. Look at those 4 types of tumors. Type number 1 is a medulloblastoma, goes for surgery, oncology, or follow-up. Type 2 is an cystic pilocytic astrocytoma, goes for surgery only and then follow-up. This is a DPG, diffuse pontine glioma, no surgery, oncology and follow-up. And this is a tiny tumor in a kid with neurofibromatosis, goes only for follow-up. What is common for all these groups is the follow-up period. And it is during that follow-up period that you learn mainly, anecdotally, on many of our cases and how to do and how to treat the next case. The follow-up is tremendously important in our profession. Well, pediatric brain tumors are interesting. Many of them go for second surgery. About 50% are high grade and 50% are low grade. Most of them are non-genetic. Secondary tumors are rare. This is very different from the adult surveys. Metastatic tumors are very rare in pediatric neurosurgery. Many of our tumors are in the midline. Midline operations are also more difficult than any operations on the side. And each of these places that are typical for pediatric brain tumors have typical signs and symptoms and flags that show when they surface and how to diagnose them. Well, we have the astrocytomas, the medullos, and the ependymomas in the posterior fossa. This is the classical cystic astrocytoma. This is a joy. You can treat and cure a child by removing the solid part. The ependymomas are still a problem because they are terribly chemo resistant. There is no chemotherapy at the moment for ependymomas. So the treatment is by aggressive surgery. You've got to get a totally clean field in surgery and in the MRI, followed by optimal radiation to the tumor field. You don't need to irradiate craniospinal like you do with medulloblastomas. When ependymomas recur, and they do recur, it is very difficult to cure the children. A few paradigms to it. It's a subject by itself. The medulloblastomas are terribly interesting because we have a proof of concept that we can cure many of them, but not all of them. They're terribly malignant tumors. The challenges are to reduce the toxicity of the treatment, to reduce radiation doses, especially in young children, and to improve our results, especially in young children and the ones that are present at a very young age. The gliomas are interesting. In the gliomas, we've understood some things over the years. Well, this is a kid that presented with this tegmental tumor. I've operated on her twice. She received focal radiation and chemotherapy, and she's wonderful. So we have to combine between surgery, sometimes radiation, chemotherapy, and doing nothing. How to combine it is an art by itself. So we make better decisions. I hope that we know better when not to treat. We know better how to talk to our patient. Do we really know better? What we do know is to collaborate better. Patients cross-referral inside the department, among your country, internationally, and to collect data together. I just want to show you this case, a crazy case. It's a CV junction ganglioglioma that I operated through a posterior fossa craniotomy, C1 to C3 laminectomy. This is the intraoperative picture. And this is how it looked. It comes to the surface on the right side. And this is what we achieved after the surgery. I left some tumor. Of course I did. The kid is wonderful, stable for 24 months, stable for 5 years. And then the tumor starts to come back. The kid is still asymptomatic. It comes back. The edema goes down over here. What to do at this stage? I got advised to irradiate this kid, but then we realized that his ganglioglioma is V600 mutation positive and fusion negative. So we gave him the Brafamid, and this is how it looks after 6 months. Look at the difference between pre and post the Brafamid. He's already pre and post. He's already more than 3 years on the Brafamid, feels great, and his tumors is like 5% of the original after recurrence. So we use inhibitors of BRAF, and by the way, this is our paper on brainstem tumors that is available in a talk on YouTube. So we make better decisions. We know how to talk to our patients. Is it really true? I strongly recommend you read this paper. It's available on the internet. Why Doctors Hate Their Computers. This is a little bit of our problems in the modernized world. So to talk to the kid, to his family, to the referring physician, it takes a lot of time. And this is also a paper I would not go through, but I strongly suggest to read it in Surgical Neurology, how to get into another head without losing your own. There's a myth of informed consent. The patients sit in front of us. They don't really know what we tell them. How to explain, how many times, how much to discuss mobility, including difficult mobility, is a challenge that we face daily. Modern imaging is a problem. This is Sir Richard Highwood, who said, vomit is victims of modern imaging technique. We discover a lot of incidental lumps in the brain. There's a widespread of using neuroimaging. We see a lot of incidental tumors. They are many times suggestive of a low-grade astrocytomas. What to do and what are the options? There are very few studies available, and what to do. So to wait and see, to do needle biopsy, surgical resection, upfront chemo radiotherapy. We started to invest this field of incidentalomas and published between 6 and 7 papers. You're very welcome to follow them on the literature. This 16-year-old with a cerebellar lump presented with seizures, stable over many years. Is malignant transformation really so rare? In adults, it is common. So the dilemma in pediatric incidentalomas is the risk of resection or biopsy vis-a-vis the risk of malignant transformation and chances of regrowth. Look at this kid, 10-year-old, presented with this lump at the basal frontal area. I followed him for 6 years. Then after 7.5 years, the tumor changed its pattern. We took it out. It was a glioblastoma. So malignant transformation can happen in children, but it's extremely rare. We published this case. You're very, very welcome to read it. So there's a change in paradigm. If the lesion is accessible, remove it. If it is deep-seated, leave it alone. When not to operate, temporal arachnoid cysts very rarely need an operation. Septum pellucidum cysts do not need an operation. Retrocerebellar cysts do not need an operation. Pineal cysts do not need an operation. Posterior plagiocephaly, mild metopics, they do not need an operation. Cystic craniopharyngiomas can go for Ommaya and proton beam surgery. Residual low-grade tumors, high-grade hypothalamic hamartomas, Segel, Teckel, and OPGs can be followed by MRI. And medulloblastomas, do we really have to remove everything, including the peduncle and the floor of the brainstem? This, I'm sure this will go over a change in the next decade. So there is a change in mixture in pediatric neurosurgery. There's no question about it. Open spina bifida is going to disappear. IVH post-prematurity is going to go down dramatically. Medulloblastomas, I predict, will go to biopsies. Astrocytomas will be treated by medication. Patient is the center, cross-referrals, internal collaboration, brainstorming, build a team, get help to take your decisions. Brain Surgery for Dummies is a very helpful book, and this is how we try to collaborate in a teamwork. This is our international fellows. Come to visit us in Tel Aviv and join us in the AACNS in Jerusalem next year. Thank you very much.
Ladies and gentlemen, it's my great honor to be here. I want to thank Professor Senfo Shi and Professor Yoko Kato's invitations. Thank you for having me here. Today, my topic will be total unblocked spondylectomy, an oncological procedure. I'm Dr. Feng Yizhuang from National Taiwan University. I'm a specialized spine tumor surgeon. I did about 200 spine tumor cases per year. So this is my disclosure. And I also want to thank my mentors, Dr. Stefano Boriani from Rizzoli Institute at Bologna, Italy. And of course, two mentors from our university, Professor Yong Kwang Tu, previous president of WFNAs, and Professor Han Mingzhen, previous president of Asia Society of Neuro-Oncology. What you need to know today, the first is diagnosis. You must know what you are treating. Also, the indications of unblocked resection and the surgical planning of this procedure. The first scenario is that this is 47-year-old male. He has total thyroidectomy for the papillary carcinoma in our hospital. The surgical staging was T1N0M0, but he complained of upper back soreness at postoperative day 2. MRI at postoperative day 2 showed this is a T2 hyperintensive lesion at T2 image at this is T6. And you can see the pure intraosseous lesion without any paraspinal extension. The thyroid surgeon consulted radiation oncology for radiation therapy as well. And we suggest CT guide biopsy. The surgeon wants to know what the pathology it is. So the final pathology shows negative for thyroid globin, but it's positive for CK, S100, and breast urea. It turned out to be a chordoma. So it's a good case for the end-block resection. And luckily, we achieved wide margin after the surgery, and there is no adjuvant radiation therapy needed. So the patient have no evidence of disease after 5-year follow-up. This is another typical appearance of the spine chordoma. I'm going to show you another case. It's a 61-year-old male. He has slow-growing Botox mass lesion noted at least for 3 years. He visited a lot of pediatric neurosurgeon, and the meningocele was told. So they suggest the patient have serial observation and follow-up. But the patient came to me, and you can see this hyper-intense lesion on T2 edit image and pure soft tissue lesion. We cannot observe the significant bone involved. Maybe at T1 image, the last coccyx may have the bone involved. So we did a CT guide biopsy. It turned out no atypical cell. Actually, we did the biopsy twice. So we decided to do a surgery for him, but we consider this is malignant tumor. We did an en-bloc resection of this lesion. The pathology shows wide margin. It turned out to be another chordoma. So this patient have no evidence of disease at 3.5-year follow-up. We'll keep follow up this patient. So the first thing I'm going to tell you today is please to think not as a spine surgeon, but as an oncologist first. The surgical planning of this procedure based on the biological behavior of a lesion. The biopsy is mandatory for the diagnosis. The pathology must be informed of clinical and radiological remarks. The biopsy should not contaminate extracompartmental space, and CT guide trocar biopsy is suggested to minimize the risk of contamination. An endocrine classification for the bone tumor was applied on the spine tumor as well. The stage 1, 2, 3 for the benign bone tumor on the spine, and stage 1A, 1B, stage 2A, 2B for the malignant bone tumor on the spine. We are talking about a primary bone tumor. So then we know the pathology, we know the biological behavior, then we select the appropriate margin for the surgery. So there are a lot of surgical options for the spine tumor. First is palliation, we just decompression the spinal cord to improve and restore the neurological function. There's no oncological purpose. You can also do intralesional excision, curative debulking, or gross total excision with microscopic or gross residual tumor. You can also do en-bloc resection. The goal of this treatment is no residual tumor. The prognostic role of the margins is very important regarding those primary bone tumor on the spine. For the metastasis, there are also several kinds of surgery. You can do the palliation, debulking, or total vertebrectomy with piecemeal fashion or en-bloc fashion. The stage 1 usually do the observation. Stage 2, you can do the intralesional excision. Stage 3, benign bone tumor on spine is a good case for the en-bloc resection. Stage 1A, 1B malignant bone tumor on the spine is also suitable for en-bloc resection. And stage 2A, 2B, sometimes neoadjuvant therapy is required to downsize the tumor. Then you can do the en-bloc resection afterward. We are going to talk about this more detailed. The stage 1 is means the tumor growing is slow and it's latent. So there's a well-defined capture around the tumor. So in most cases, observation is enough, and sometimes stabilization is indicated in some cases with the pathological fracture. This is a case of 61-year-old female with no malignancy history. She came to me for the spondylolisthesis, but we find there's a T12 lesion. The MRI shows well-defined lesion and no paraspinal extension. the bone scan showed uptake, and the PET scan showed uptake as well. We did biopsy. It turned out to be a fibro dysplasia. So we keep observation on this case for 5 years, and no interval change. The surgery may be needed while the lesion is larger, but so far we just keep the observation. Akin stage 2 means the tumor has some more aggressive behavior, is growing, but it's still slow, and tumor, when there's a pseudo capsule around the tumor. The most common type of tumor is osteoid osteoma and osteoblastoma. Intralesional excision is adequate for this kind of tumor. Stage 3 benign bone tumor is a good case for the unborn resection. The most common type of tumor is the giant cell tumor. The tumor behavior is more aggressive. There are pseudo capsules around the tumor, and tumors sometimes grow beneath the previous compartment margin. So that sometimes tumor have paraspinal extension. So it's a good case for unborn resection. And if you cannot achieve wide margin, or the margin was involved by the tumor, we consider it's an intralesional excision. Post-operative radiation therapy should be considered. This is 32-year-old female. She presented with mechanical back pain, and the image shows it's a T12 giant cell tumor. Of course, biopsy confirms the diagnosis, but the first surgeon did the intralesional incision and debugging for this case. And posterior fixation, 6 months after the first surgery, the tumor recurrence and the tumor extended to the upper and lower vertebra. You can see the image middle. So we decided to do the 3-level and bar resection for this patient. She had no evidence of disease at 4-year follow-up. Another good case for unborn resection is the stage 1 malignant bone tumor on the spine. The most common type of tumor is chordoma and chondrosarcoma. I'm going to show you the case. This is a 69-year-old male. He presented with the sacral tumor found incidentally in the digital rectal examination, and the tumor arising from the S3 with lower extension. So it's for us, it's a good case to do the subtotal sacrectomy and with preservation of bilateral S2 root. You can see we also resect the biopsy tract along with the whole tumor specimen, and there's no recurrence at 5-year follow-up. There are more complicated sacrectomy cases. It's regarding with the spinal pelvic fixation and sacral reconstruction. It's more complicated, but I'm going to show you the image, but I'm not going to talk about more about this at this talk. Next case is 21-year-old male police officer. He presented with spasticity gait. MRI shows a T4 bone lesion with spinal cord compression surround the spinal cord more than 270 degrees. The biopsy shows a grade 2 chondrosarcoma. We try to remove all, but it cannot be removed in one piece and bar resection. So in this kind of case, we have to design the approach to go intralesional in some cases, and the intralesional should be protected, avoid further contamination. So we do this kind of tumor with 2-piece and unblocked resection to remove the lesion, and the pathology tells us where is the margin involved. And because it's a grade 2 chondrosarcoma, adjuvant radiation therapy was applied. There's no recurrence at 2.5 years. Regarding the stage 2 malignant bone tumor on the spine, this kind of malignant tumor is more aggressive, it's quite malignant. The neoadjuvant therapy should be considered to downsize the tumor, then try the unborn resection. The typical tumor are osteosarcoma and Ewing sarcoma. It's a case presented with L2 fracture. The first surgeon misdiagnosis the tumor, this misdiagnosis this lesion as a benign tumor. He just do the decompression and posterior fixation of the case. When the case present to us is like this: the tumor is surrounding the spine, the thecal sac, and it's a huge one. And the patient didn't survive through the neoadjuvant CCRT, so we don't have the opportunity to do the surgery for this case. So treatment for the osteosarcoma, the most effective surgical intervention is wide arm-ball resection, but usually neoadjuvant therapy is necessary. The radiation therapy alone for osteosarcoma is not. It comes with poor response. So according to the ESMO guideline, if you suspect the primary bone tumor on the image, you should do the biopsy and histological evaluation and grading, then go further treatment planning. So in the bone sarcoma, like Ewing sarcoma and osteosarcoma, usually neoadjuvant chemotherapy or radiation therapy is necessary for the management. So back to our topic, what is en bloc resection? The whole tumor resection encased by a continuous shell of healthy tissue, and the thickness of the shell is called margin. Wide margin means the margin is thicker than 3 millimeter. The marginal margin means the margin thicker than 1 millimeter and less than 3 millimeter. We consider the margin was involved. The concept was first proposed by the Professor Bertil Stenner from Sweden. And he's a general surgeon, and he applied the resection of the colon cancer to the resection of bone tumor on the spine. Of course, Professor Tomita from the Kanazawa University, Japan, he is the first one to standardize the total en bloc spondylectomy procedure, and he called this test surgery. And the single posterior approach for the total en bloc spondylectomy on thoracic spine is called test surgery. So now, following Professor Tomita's legacy, Professor Kawahara and Professor Murakami from Japan is quite well known for this kind of procedure. And Professor Stefano Boriani, he proposed the WBB staging system. He divided the spinal vertebra from the dimension 1 to 12, and the layers, paraspinal layers, from layers A to layer E infradurally to plan the en bloc resection, not only as thoracic spine, also for the cervical spine to the lumbar spine, especially L5's en bloc resection. I will talk about that later. So the concept first is that if the tumor involves only one pedicle, it's very easy for remove the posterior element in piecemeal or one-piece fashion, and then you can do the posterior approach for the total en bloc spondylectomy. This is we so-called test surgery, and the tumor involved from the area 2 to area 5 or area 8 to area 11. This is good case for the sagittal resection, also called hemivertebrectomy. Sometimes the tumor involves the posterior element only. You can do the posterior element en bloc resection. And with more and more experience, they propose the en bloc resection from type 1 to type 7. The type 1 means the tumor occupying the anterior column only, and the paraspinal extension is not much. So you can do a single anterior approach to do the en bloc resection. This kind of tumor quite rare. I don't have any experience on this kind of tumor, but I'm going to show you one case. This is a 64-year-old male. He presented with left C5 palsy. About 5 years prior to this presentation, he had hypothyroid cancer, and he had high-dose radiation therapy. Right side is his radiation therapy dosimetry. So you can see there is a tumor growing from the previous marginal area of the radiation dose. So, but the previous spine surgeon didn't recognize this a bone tumor. He did a laminoplasty for him because the anterior spine, anterior cervical soft tissue is quite rigid and stiff due to the radiation therapy effect. It's very difficult to do a dissection. So previous spine surgeon decided to do the posterior decompression, but you can see then the tumor progress surround the spinal cord and out there everywhere. So we cannot do about it anymore. The type 2 WBB en bloc resection means a single posterior approach for the total en bloc spondylectomy. Type 2A means posterior resection. Type 2B is the most common type, test surgery. Type C is the hemivertebrectomy, also called sagittal resection. I'm going to show you some case with the type 2B en bloc resection. This means you can do the first step, you remove the posterior element in piecemeal or one piece fashion, both is okay. And then you do the anterior release from the posterior approach and take out all the vertebral body. This is a 62-year-old female. She had leiomyosarcoma with solitary metastasis. And at first, this lesion like this. After 3 months of immunotherapy and the target therapy, the disease progressed like this. So we decided to do the en bloc resection, and the margin is free, and we do reconstruction. Another case is 57-year-old female. She had cholangiocarcinoma with oligometastasis, and the PET scan showed only one lesion, and you can see that there's L1 spine metastasis. Biopsy confirmed the diagnosis, and then we do the en bloc resection of this kind of tumor, with single posterior approach. The picture of specimen and pathology show wide margin. Because it's thoracolumbar junction, we do a double rod reconstruction for this case. For the spine metastasis, we have Tomita survival score and Tokuhashi survival score to predict the patient's survival. With good survival, sometimes excisional surgery with the en bloc resection is indicated. But we all know that so far, the medical oncologist progress is quite much. So the patient survival is longer and longer. Usually, Tokuhashi survival score and Tomita survival score, the prediction rate is only around 60%, and usually those scores underestimate patient survival. This is also the protocol of the resolving, showing that sometimes you still need en bloc resection for the spine metastasis. So from our institute, our experience showing a good indication of test surgery in the spine mets is breast cancer, thyroid cancer, because the survival of these patients is quite long, and the renal cancer and the liver cancer should be considered. From the preoperative angiography, you can see there are a lot of arterial venous shunting in this kind of tumor. So usually that's just like doing the AVN surgery. You cannot go inside the AVN, you can go surround the AVN. So if you do the en bloc resection in those hypervascular spine mets, you can control the bleeding better than do the intralesionally. I'm going to show you a case. This case presented with acute paraplegia in 3 days, and the patient had medical history of liver cancer. This is T4 lesion with spinal cord compression. So during our preoperative evaluation, we find the vascularity of this spine mass just similar to the aorta. So we send this patient to angio room. You can see that this lesion like similar to aorta. In the angio room, we find there's a pseudo-aneurysm inside this pathological fracture. So it's quite vast. The vascularity is quite high. If we go intralesionally, the patient might die on the table. So this is a good case for the en bloc resection. Then we're going to talk about type 3 en bloc resection. It means that sometimes we do the anterior release first, and then we do the posterior approach to achieve en bloc resection. Sometimes in cervical spine, if the patient's vertebral artery is is involved on one side, the other side is healthy, you can do this kind of procedure. Or sometimes in the thoracolumbar spine, if we do the revision surgery for the unblocked resection, we usually choose this type 3 unblocked resection approach. We do the anterior release to dissect the major vessel from the lesion, and then we do the posterior decompression and then remove whole the vertebral body from the posterior approach. I'm going to show you one case with the type 3B WBB and block. This is 49-year-old male. He presented bilateral anterior thigh pain for 6 months. And we can see there's the large chordoma at L1 level with bilateral psoas muscle invasion. So we decided to do the anterior approach first to dissect the tumor away from the great vessel, and we transect the psoas muscle for the margin. So specimen was like this. We do a 2-level unbound resection with resection of bilateral psoas muscle head and achieve the wide margin incision. There's no evidence of 2.5-year follow-up. It's another case with a 60-year-old male. He presented with back pain, and there's a bone tumor at left T9 costal transverse junction. And at first surgery was done by a thoracic surgeon. They do the open surgery to remove the rib head and some transverse muscle. This is a typical wrong operation on the wrong patient by the wrong surgeon. It's a typical 3W scenario. Then you can see the tumor contaminated the operation field everywhere. The tumor recur 6 months later. And he visits another spine surgeon. They do a decompression again to do the fixation, and tumor recur. They do another decompression, and then he come to me, and we do the vascularity evaluation. And left side, you can see we do the anterior approach. It's a thoracic cage, it's iliac. This is patient abdomen, this is patient's back. It's oblique incision, and it's a retropleural approach, and we dissect the aorta away from the vertebra. The aorta was covered by the Gore-Tex membrane, and then we turn the patient from the back. We do the posterior approach, and you can see a pleural here, and this is the aorta protected from the anterior approach, and we dissect the spinal cord and then decompress the cord wider, and then we can remove the 3 level of the body from the posterior approach to achieve the unblocked resection. And this is the reconstruction we did. And I'm going to talk about type 4 WBB unblocked resection. It's suitable for the cervical tumor. You do the posterior decompression first, and you dissect the tumor away from the healthy vertebral artery, and then control the other vertebral artery from the lesion side, and you remove the tumor from the less anterior approach. This is 44-year-old female presenting with neck pain for months, and the tumor was diagnosed right after her lung adenocarcinoma. The lung adenocarcinoma stage is T1N0, and this is a C5 lesion, and the tumor is quite large and compressed bilateral vertebral artery. The tumor is quite large with extension there. And the patient left vertebral artery is occluded, and the right vertebral artery is also quite stenotic. We can see the posterior circulation was supplied by bilateral P cone. So during this surgery, we decided to ligate bilateral vertebral artery, and then to achieve an intralesional unbound resection. Of course, this margin was involved, and radiation therapy was suggested after the surgery. The pathology shows it's a grade 2 control sarcoma. Type 5 WBB unblocked resection. It means we do the posterior approach first, and then combine lateral approach to remove the tumor. It's usually regarding the upper lumbar lesion. This is 32-year-old male. He presented with mechanical back pain with radiation to thigh. Here see the pathological fracture at L3 is a giant cell tumor, biopsy confirmed. So we do the embolization first. Left side is a pre-embolization field. You can see the vascularity was reduced a lot after the embolization. Then we do the posterior decompression first and fixation, and do the end block resection after the anterior release. And the specimen was like this. Type C WBB end block is regarding L5 lesion. I'm talking about this later. And type 7 is the WBB embolization with the large tumor at anterior and medial colon. So you do the posterior decompression first and do the whole tumor resection from the anterior. I have no experience on this lesion because in Taiwan, we don't have such large tumor. So I'm going to show a case of L5 end block resection. This is 68-year-old male with no malignancy history. He presented with L5 pathological fracture. The first surgeon do the posterior fixation and decompression for him and also do the biopsy. It turns out to a giant cell tumor. And after 3 months, the tumor is growing larger and larger. So this is the image, the X-ray before my operation. The previous fixation instrument, and you can see the coil here. My interventional radiologist do the embolization for me. So it's a residual giant cell tumor, anakin grade stage 3. So we require a wire margin. And anatomical constraints that it's a L5 lesion. It's deep between iliac wings and close and countered by common iliac vessel. And high function role L5 roots cannot be sacrificed. We do the CT and MRI evaluation and also do the angiography because there is no anenchyma, so it's an easy part for us. And we do embolization. So like this, we do the first anterior release from the healthy side and do a posterior decompression and posterior release. Then do the anterior release, remove whole the tumor. So like this, we do the anterior release from the healthy side and posterior release and to perform the posterior fixation. And the final part to do the anterior release from the lesion side and remove whole the tumor. So this is cranial, it's caudal, it's dorsal-ventral. So it's a right retroperitoneal approach. You can see the vena cava and right iliac vein here and do the whole L5 tumor after L4-5 discectomy and L5-1 discectomy. Or we can see the right L4 and right L5 root and left L5 root after tumor removal. So it's the picture of specimens, and this is how we reconstruct the L5. So this is my last slide. Actually, this surgery cannot rely on the surgeon alone. We need a lot of colleagues to help me to perform this surgery and manage the patient. We need radiation oncologists, pathologists, and oncologists to help me, and we have specialized anesthesiologists to help me on the surgery. So special thanks to National Taiwan University spine tumor teams. We are a team to perform this kind of procedure. Thank you.
Hi everyone, this is the last topic. My name is Jamin Chen. I'm the president of the Taiwan Society of Endoscopic Spine Surgery. My topic is talk about a full endoscopic decompression for the spine stenosis. There are 3 endoscopic procedures in the spine surgery. One is a full endoscopy, and the second is a MED procedure. Then you can see now is a new technique, biportal technique. For my topic, I talk about from the background, technique, example, and the conclusion. We know the spine stenosis include facet hypertrophy, thickening of the fragment, and maybe discoloration, and later stenosis degenerative change. The treatment is ranged from the conservative treatment to the surgical procedure, maybe some the steroid injection, epidural steroid injection. Sometimes it's failure for the conservative treatment. You also can see my paper talk about how to do the interlaminar approach. You can see this paper from the neuroscope. The decompression, we know the commercial laminectomy is the gold standard treatment, the symptomatic lumbar stenosis. But you maybe do the facet preservation laminectomy. But now new technique for the posterior decompression, we will try to limiting the bone decompression and avoiding the removal of midline structure like the spinal process, vertebral arch, and the interspinal ligament, supraspinal ligament. Now you can see the conventional laminectomy. You try to remove all the structure posterior. Now you will preserve more small process and ligament, so you will do the unilateral laminectomy for the bilateral decompression, or you can do the split small process laminectomy. After the decompression, you can see the different technique will have a different dural expansion, but anyway, you need to try to enlarge the dural expansion and preserve the facet. The full endoscopic decompression include two techniques. One is the endoscopic uniportal contralateral approach, or one is the endoscopic transformal approach. First one, we talk about the endoscopic uniportal contralateral and the application guide, and you can see my how to do the interlaminar approach. Now the instrument has more large one working space, so you will be more effective for do the decompression. Long time ago, you just only have the small working channel, so it's not easy to quickly to do the decompression. So we will use a large one for the decompression, the posterior interlaminar approach. And you can use the cutting burr and flexible burr. And you also have the large one cutting burr 6 millimeter. So like the open surgery or microscope surgery, you have a large one instrument to do the decompression, so it will be more quickly. You have a diamond burr for the more detailed decompression, and you have a punch for the remove some spur. So you can see the small one and the large one, but they have a different portion. Sometimes the small one will be into the nucleus and to remove more the nucleus. The large one is more easy to more effective for remove the lamina. But during this surgery, you also can do the I showed a case about 61 male. They have the clarification for the 2 years. You can see that there is stenosis for the spinal canal and some disc herniation. And also you can see the facet hypertrophy. You can see the facet hypertrophy here. And from other the CM locate the at 1, 2, and you do the so we do the uniportal bilateral decompression. The technique a little like tubal retract. So for the beginner, you will see the spinal lamina junction, and then this is tubal imaging, and this is my endoscopy image. So from the spinal lamina junction, and then you try to specify some lamina, and then you will see the you see the framing and you see the top of the fragment and you dissect away from the lamina. Then you can see the dural sac. I use a punch to remove the small fragment. After you remove the epistatal fragment, you will try to remove the contralateral fragment, and then you can get more the dural expansion. So if you do the posterior uniportal bilateral decompression, you will from here, and you do the same side laminectomy and contralateral decompression. But if you are into the spinal canal, then maybe if the large one endoscope has some problem because the large one endoscope has large sheath. So it's not easy to put the sheath into the spinal canal. So sometimes I will keep the sheath and then I will use the small sheath and then the endoscope is a channel procedure. So into the spinal canal, I will use a small endoscope and then remove the nucleus. Show the technique. This is a channel technique. So you will keep the sheath, but you put a small sheath inside and then the scope inside. A little like the traditional Chinese Taiwan's food. So this is the contralateral side, and you try to remove the lateral decompression, and then you pull the sheath. This is a small sheath, and then you can put away from the dura. You know, this is a full endoscope, so the water also will have some pressure to put away the dura sac, so prevent you to damage the nerve root. So I will use a coagulation, and then you put away the dura sac, and then you can do some decompression. You can put a sheath inside and you can dissect gently and step by step. The water will inside the space, into the space. So there will be some pressure in here that will pull away the Durasac, and then you can use the coagulation. So this is annual fibrosis. You need to keep in mind don't to destroy the annual fibrosis too large one, because the too large one will easy to cause the recurrence problem. So this is a 3 millimeter the hole for the annual fibrosis. So that's not easy to let the residual nucleus go outside the annual fibrosis. So to prevent the recurrent problem, you can see all the Durasac. So this is well done the decompression. Okay, so you can see some bone structure. You can remove some nucleus here. Before the surgery, you can see the spinal canal very small stenosis. And then we do the bilateral, uniportal, bilateral decompression. So only the 1 day hospital stay, the patient can go home in the next day. Other technical we talk about the endoscopic transforming approach. I show a case first. This is a 64 years old female. That's a lumbar L4-5 stenosis for left radicular because this patient has the foramen stenosis in the left side. So I decide only the one side syndrome transforming approach. You can and the foramen stenosis in here. So I do the transforming approach for the left side. If the pin into the spinal canal, that will be cause damage. But sometimes the patient will give it some response. So you can put back the needle. And then you put a dilator, put a sheath, remove the dilator. And then you in the SAP and the pedicle area, in the AP view, and use a burr and into the spinal canal. This is the lateral recess decompression and keep it decompression. And you can try to remove the contralateral ligament and remove more ligament. So this is the transforming approach. First one, you find the SAP and the pedicle junction, and then you use the burr to enlarge this foramen space, and then you can see the ligament here. You can remove fragment, but now you need to be careful because there's stenosis is a long-time stenosis. So adhesion is another problem. So you need to step by step, and then get the water into the dura and the fragment space. So I just step by step, piece by piece, and then you can see the dura cells here. So I try to remove more the contralateral ligament, but you need to keep in mind to control the breathing and careful to see any vessel here. So this is the dura cell. So after the surgery, you can see all the dura cells here, but you can also see some dura fall. Why? Because there's a long time stenosis. So even after the decompression, it's not easy to see the dura expansion very well. So then you need to be careful to prevent cause the dura tear. This is the contralateral side. I will do some coagulation, The patient's other local anesthetic, so they will give you all the response to you. In this procedure, you need to prevent to discharge the facet joint to more than one two-third. But transformer have some limitation. If you do a transformer, it's not easy to do the controllator decompression. So if you want to do a controllator decompression, maybe you can do the both side transformer portion. So you can do the well done the decompression for the patient. Other you need to do the posterior. So after the surgery, you can see here the pre-surgery, pre-operative, post-operative, and you can see the decompression here. But I also can see some calculated fragment in IED to remove it. So there was some residual fragment have the symptom free. Endoscope, the decompression, if the patient has both sides, you need to do the posterior decompression, because posterior you can do the both facet hypertrophy, you can remove both the fragile ligament, and you also can do the bilateral lateral recess stenosis. Your patient has just the one side symptom, and you can do the transformer approach, like a fragile ligament thickening, just one side, and unilateral recess stenosis, or the one side, the former stenosis. You also can see my paper talk about how to do the percutaneous transformer full endoscope decompression for treatment lumbar stenosis. They also have a good result for. But how about the cervical and the thoracic decompression? You know that because the spinal cord and the nerve root on the caudal equinal. So you need to keep in mind in the thoracic or the cervical, do the no touch technique. The how to do the no touch technique, by more bone, you can keep away from the dura. So you can maybe pay manipulation, small manipulation the nerve root. I show one case is 36 years old, have the C6 and the C7 right side HIVD. This technique is a posterior approach, and according to the tube system technique. First one, you find a V point, and then you try to enlarge the V point, and this procedure we call it posterior foramen plus otomy. So after foramen otomy, you can see the nerve root here, and then you will see from the maybe you can from the ACL or from the shoulder. In this case, I found the ACL area and use the hook into the ACL area, and then this is the HIVD here. So I can remove this disc herniation. Use the coagulation to dissection the nerve root, but this have a little direct here. No problem. You don't damage the nerve root. You also don't try to remove the molecules. Okay, so you can do the decompression well. A small direct here, there's no problem. So after the surgery, pre-operative, post-operative is well decomposed. But sometimes you need to keep in mind the vertebral artery, if you do the two more lateral, more deeper, you cannot see the nucleus. You will not to the disc. Maybe you will see the vertebral artery here. Here's the vertebral artery. So you need to careful. It's very big trouble. But how to do the cervical decompression? This is traditional. It's a tube system. Also same with the tube system. You will do the uniportal bilateral decompression. Use the endoscope here. So the tube system also have the procedure, the same procedure with the endoscope procedure. I show case C6 and C7 spots. It's a navigation gun. That's from the viewpoint. You find a viewpoint. And then enlarge the viewpoint, and then you can see the spinal cord here. But you need to keep in mind, don't put your sheath into the spinal canal. So you have some distance away from the spinal canal. And then you see the spinal cord. Then you step by step to careful dissection and then remove some nucleus. we will use the calculator approach. After calculator approach, you will see here. There's a spinal cord here. I try to use a floor seal to stop bleeding. So after surgery, I don't put any drain here. Pre-operative, post-operative for the wound. The other case is show the high grade migration. The spinal cord is very, very stenosis. So in this case, the same procedure, 3 point, find the 2 point here and here, and then you drill the lamina. So you need to decide how large one you want to remove. So I remove the lamina, then you can from the side to the vertebral body and the sacrifice partial vertebral body. So you can keep it away from the spinal cord, and then you add the near the facet to the body to remove, pull out the nucleus. First one, you find the 2 V point. Then this is the lamina. You sacrifice the lamina. Then you small cord here, and here is the facet joint. So you use the hook to dissection, and then you sacrifice. You create a small hole in the vertebral body. So you can pull the forceps, the curved forceps, and to remove the herniation disc. And then you check from the ACL to the dura area. So you can check this is spinal cord. Okay, you can see after the surgery, the patient, the power and the pain, power has improved and the pain has totally gone. But in thoracic is different from the cervical. Thoracic, they have the river, have the transport process, the decompression. They have 3 techniques, but I just introduced the interlaminar approach and the atrial approach. The first one is a transforming approach. You need to try to remove and enlarge this foramen space. You will fast to the transport process, and you need to remove some facet. Sometimes you need to remove the head of rib. So that will let your endoscope into the canal. So you can see the transport process into the head of a rib, and then this foramen space. Okay, you can use the CM AP letter, and then you find the head of a rib and foramen space, and then you try to enlarge this space, and you can put an endoscope into here. But first one, you will see the acetinal root. Sometimes you can see the dorsal root ganglion. So this is the atrial foramen approach, not the transforamen approach. So the thoracic thoracic spinal canal, you need to try to enlarge this space. Okay. How about a posterior approach? I think a posterior approach is more easy to transform. You only have you need a meters river in transport price, so it's not easy. And then I show the posterior approach. Okay, this is case is theoretical diagnosis in E12. So I use an and then I located the. Then I calculate how large one. Then use the other navigation. I try to in the end. So I decided to do the enlarge the spinal canal. So I find the lamina, and then you can use the navigation. You show where is where, because in the endoscope view, the only structure you will know is the bone structure. But the thoracic is not easy to know where you are. So you maybe use the CEM or use the navigation. It's more easy to do the surgery. So I do the laminectomy and up and down. Try to remove the lamina so you will see the frequency. And then controllator, you are careful. In the cervical and the thoracic and the cervical, you need to be careful. Don't put the sheath into the spinal canal because they will cause the damage to the spinal cord. And then you can see the sparkle and try to remove some nucleus. You can gently to put away the sparkle, but you need to keep it in mind, just gently and just touch, the small touch. Okay, after the surgery, you will see the sparkle here, and then I will put some force field to start bleeding. Okay, so force field. But you need to keep in mind, don't put too much force field, because they also will cause the pager and they will cause the sparkle. Everyone, this is the last topic. My name is Jeremy Chen. I'm the president of the Taiwan Society of Endoscopic Spine Surgery. My topic is talk about full endoscopic decompression. This is a good result. We know the full endoscopic decompression can achieve a step-by effect after well step-by-step. Right. Pre-operative, post-operative, you can see the dural expansion very well. I doesn't have many cases in the thoracic or in the cervical, because most cases in the lumbar come to Taiwan damage. This wind is navigation reference wind. This is my endoscope wind, very small. Pre-operative, post-operative. You can see the dural expansion very well. I didn't have many cases in the cervical because most cases in the lumbar, all the cases are good result. We know for those condition can achieve a step-by effect after well step-by-step training and experience. I think through the advanced the training and some cadaver
A very good afternoon. Is Sachin there? Okay, thank you very much. I think we have many technical issue. There was a few interruption in terms of presentation, but overall, I would like to thank all the speakers. We have 6 speakers over a period of, I think, almost 3 hours in the neurospine and peripheral nerve session. So it was excellent talk. We enjoyed very much, but unfortunately there was no Q&A session because we have to allocate according to the time given. So I would like to pass over back to Dr. Sachin ataupun or Dr. Liu in order to proceed with the next session. Okay, maybe yeah, I would like to invite speakers to give some comments while waiting for the, I think, next announcement. Yes, Prof. Suresh, you want to say something?
No. I was just waving at everybody so that you thought you want to end the session.
Okay.
Okay, I thought to say bye to all of you. Not
okay.
Okay.
Thank you.
Okay.
Thank you, Suresh.
Hello, Professor.
Hi, how are you?
Good.
Thank you for your nice lecture. Thank you very much.
Hello, Professor Yoko. How are you?
Good. Thank you very much for a nice lecture.
Yeah, thank
I
you.
want
Thank
to
you.
listen more.
Thank you. Thank you. Thank you, Dr. Azmi. How are you?
Very good. Very good. I enjoy your presentation. I have many questions to ask.
I know.
Yeah.
This is different. This is different concept, different thinking. But I'm very positive that this thinking will eventually get more strength. I have to, explain the concepts a little more because these concepts are different, they are new, and they can be complete game changer in the field of spine surgery. So let us see how it goes, Dr. Azmi. They are different, so that is why they are controversial for people to hear, but not for me when I speak with my experience. So
exactly.
That is the... In any case, it is a great opportunity that I have got to present my work. And I thank Dr. Yoko Kato, of course, always. And you, Dr. Azmi, and many others I see on the gallery. Thank you very much.
Thank you so
Thank
much.
you, Professor.
Thank you. Thank you again, Professor Yoko Kato, Asmi, and all my friends. Looking forward to future such meetings. Thank you again.
Thank you very much. So I pass back to Leo. Probably you want to make some announcement before the lunch break, right? According to the schedule.
Yeah, thanks, Prof. Azmi. We supposed to have YNS award presentation, which we actually schedule at 3. Now it's almost 3 o'clock. So I'm not sure whether all the YNS are they all here? Hopefully all is here. Our judges, I'm looking for our judges. Thomas not here. Two Street. Okay, our judges also not here yet. But I think we can start our session. Let me share my screen. So for all the audiences, this is the first time we organize 2 days seminar with the largest number of young. Hello. Yeah, with the largest number of young neurosurgeons. We have 24 participants from various countries. The biggest delegate actually in this seminar is from Indonesia. And all are having very nice presentation, a lot of new ideas and concepts that we learn. And the end of the seminar is to see who are the best speaker. How we make the judgment, all the young neurosurgeons have submitted their videos 2 weeks before the event. And we have 4 judges who have evaluated all the videos. So they need to go through all the 24 videos and give the scoring. And we just got the result. And before we proceed with the result announcement, I would like to, it's my great pleasure to call upon Professor Yoko Kato to give her remark on this, and especially for the young neurosurgeon session that we held yesterday. Thank you, Professor.
Thank you, Liu, and thank you, Azumi, and thank you for all core members of ACNS. So when we start to have the young neurosurgeon session, because of we want to educate the more knowledge for them, I think. So that's why we started to have such a YNS session. But this time is the huge number of the YNS from the world. I thank you very much for participants this time. And on behalf of the Asian Congress and also the collaboration with the Egyptian Society and Algerian Society and also Uruguay Society. So this time we unfortunately the Mongolia and also Albania, they cannot join at this time. But anyway, so with those representatives, we decided to the 3 awards for from the YNS. So and also I want to thank you very much for judges, because the paper is so critical and so nice paper, and to read and make a decision to which one is the best, because it's quite difficult to make judges, I think. But anyway, the 4 alumni members, they decided finally the top 3 awards. The 4 judges, the name is already Dr. Liu, that he showed our slides. The one is Professor Albelt. He's from Italy. Now he is moving from Bologna to some other place. He's on the plane now, I think. So he apologized, he cannot join us today. And second one is Dr. Sandeep from India. And third one is Dr. Tsusit Mewada from, again, India. And number 4 is Dr. Tommy from Indonesia. So I really thank you very much. And also the Dr. Liu is organized everything. So that means is kind of the Dr. Liu and Dr. Azumi's work hard the day and night last the 1 month, we see. So then we will have some announcements. So you will expect who will get the 3 awards. Thank you very much. Dr.
Thank
Liu?
you. Yeah, thank you. Hello, can you hear me?
Yes, we can hear.
Yes, okay. So we supposed to have our judges to announce the result, but I think our judges are quite busy. I think probably tired looking at all the videos for the past 2 weeks. Anyway, the first result already shown here. I wish to congratulate Dr. Rohadi Muhammad Roshidi from Indonesia, who won the third highest score from all the 24 candidates, as you can see from the screen, sorry. So, and his topic is on effect of MLC 901 on brain derivatives and neurotropic factors, level BNDF, mRNA expression, TNF alpha levels, and brain histopathological in Dowley rates in with traumatic brain injury. So it's a laboratory study. Congratulations to Dr. Rohadi. Are you around, Dr. Rohadi?
Yes, Dr. Liu.
Can you give a short speech from your side to congratulate yourself?
Thank you, Dr. Liu. Good afternoon, all professor and colleagues. Thank you for your opportunity, this award. I dedicated this award to the encouragement of myself, my institution, and young neurosurgeon in my country and around the world. My impression, a young neurosurgeon is always motivated to innovate it and become the best neurosurgeon. Thank you. Thank you.
Thank you, Dr. Rohadi.
Thank you. Thank you, Prof.
Dr. Rohadi, you want to make some announcement on the August, the web seminar? You want to make some announcement? Can you hear? Can you hear my voice?
Yes, yes.
So you want to make some announcement in the next month, the second web congress, please.
Okay, Professor.
Rohadi, can you say something about the upcoming second virtual ACNS conference?
Yes, okay. Yes. About the progress, maybe maybe it's inshallah ready for the virtual second ACNS, and I think it's finalization. Maybe in next weeks we send a full seminar booklet, maybe Professor Azmi and Professor Kata. Inshallah. Thank you.
Yeah, for your information, Prof. Rohadi will be the host of the second ACNS Virtual International Conference, which will be held from 6 to 8 August. Yeah, this year. So congratulations and all the best to you.
Thank you, Professor. Thank you.
Thank you, Dr. Rohadi. Thank you, Professor Kato and Prof. Azmi. And second place won by Dr. Sachin Chimet. He presented on endoscopic optic nerve penetration for idiopathic intracranial hypertension. I think he showed a case series done in his institution. Congratulations to Dr. Sachin. Dr. Sachin, are you around, Sachin? Dr. Sachin?
Yes, Dr. Liu. Am I audible?
Yes. Please give your winning speech.
Yes, first of all, I would like to thank my mentor, Professor Bala Murugan, under whom I have done this research. All these patients were admitted under him, and together we've done all those surgeries. Second thing, I would like to thank our President, Chairman, Professor Yoko Kato, and certainly my friend Dr. Liu for organizing this wonderful webinar. I think this time we had stretched our YNS competition beyond our limit. We can go further, but 24 competitor was a good number. I would like to congratulate my colleague, the other participant of the YNS who had presented their work. It was wonderful papers this time we've got, very nice research work. I think we can collaborate together and do more research. And in the research field, we can do more. So thank you very much. Thank you very much, Professor Kato.
Congratulations. You deserve it. Thank you very much.
Thank you.
Congrats, Sachin.
So,
Professor Azmi, I'm sorry I forgot to mention your name. You are a constant mentor and advisor for the YNS community. Thank you for being there.
Yeah. Azmi, thank you.
Nice, Dr. Sachin.
So the final, the first place, based on the evaluation done by our judges, won by Dr. Nirav Patel from United States of America, who presented on why embolize brain AVM. Dr. Patel is here. I think it's not in the list. Patel, are you around? No, he's not around. Okay, so we congratulate him. And before we end, probably we can, since there are so many young neurosurgeons in the audience list, probably we can get some encouraging message from our senior faculty. Probably Professor Suresh, you want to say something to our young generation, young neurosurgeon professor?
Yeah, I think it's a very good initiative by giving an opportunity for these young neurosurgeons to come out with their work and excellent papers. And I am sure in future we'll get more and more young people to join this forum. And again, my congratulations to Professor Kato for taking us to a dream neurosurgical world. Thank you.
Thank you, Professor Suresh. Probably we call again Professor Atu Goel, how to tell our young neurosurgeon to do it my way. Professor, are you still around? Professor Atul is not here. Probably we call his great assistant, Professor Adibasha. Adibasha, are you around, Professor Adibasha?
Hi, Dr. Liu. Good morning.
Hi,
thank you for your thank you for your excellent presentation, Professor. You want to say something to the young neurosurgeon, Professor?
I think Professor Kato has built this beautiful platform and has brought the world together, all people from all across the world. I mean, it's so easy to connect with everyone and to exchange our ideas and thoughts. And I think this is a beautiful platform for both young neurosurgeons and senior neurosurgeons to connect. And I hope that we have many such conferences in the future. Thank you, ACNS. Thank you, Dr. Liu.
Thank you, Prof. Adiba. And probably we also ask our Chief of Women in Neurosurgery to give some encouragement to especially female young neurosurgeon here. Dr. Sharon. Dr. Sharon, are you around? She's on duty today, actually, she told me. Probably she's not free at the moment. And Professor Azmi, you want to say something for the young neurosurgeon, Professor?
Excellent, well done. Keep up the momentum and fly away. Okay, everybody, have a round of applause to everybody. All are winners.
Yeah.
So, since we still have time, probably I open to anyone here in the audience list who wanted to say something. Anyone can just on your video and say something.
Hello. Am I audible? Yes, I'm Dr. Rushabh from India. I'd like to take this opportunity to thank the ACNS committee and especially Professor Yoko Kato for giving us the opportunity to present our work at the stage of YNS. Thank you.
Thank you.
Thank you very much.
And anyone else from the young neurosurgeon?
Dr. Liu, you can unshare your screen.
Okay, sorry. So if there's no further comment, maybe we call upon our president, Professor Yoko Kato, to give her closing remark for this Young Neurosurgeon Award session. Professor.
Thank you so much. We are so happy to have a nice the three awards doctors. I think always young doctors should think about not only the clinical, not only the surgical things, but also the theoretical, how you can face to the patient's pathology. That is very, very important. It maybe connect to the such kind of the award. Thank you very much for your contribution to the ACNS. Thank you so much.
Thank you, Professor Kato. Now we close the session. Please do come back in 15 minutes where Professor Adibasha will give a keynote lecture shortly. Thank you. Thank you for everyone. Bye-bye.
Bye. Thank you.
Thank you. Well done.
Prashant, are you there?
Hello, Sachin. Can start screen share.
Hello, everybody. I am Dr. Abhida Shah, and I work at the Department of Neurosurgery of KEM Hospital, Mumbai. I'm associate with Professor Goel, and I'm going to present today on clinical correlative cortical and subcortical anatomy as it is relevant for glioma surgery. Before starting my lecture, my message to young neurosurgeons is you have to learn the rules of the game and then you have to play better than anyone else. This very famous quote by Einstein is completely applicable to intraaxial brain surgery, where you have to understand the nuances of cortical and subcortical anatomy before you go into the surgery. To understand these nuances, there is only one way. You have to go to the laboratory, you have to do cadaveric dissection, you have to do white fiber dissection, and then only you will be able to attain mastery. Another important message for young neurosurgeons is it is important to have a great mentor. I have been very lucky to be trained by one of the world's best neurosurgeons, Professor Atul Goel, as you are all aware. I have also been mentored by Professor Yoko Kato, and I'm thankful to her for all that she has done in promoting me and my message to young neurosurgeons. So to start my lecture, this is the magnificent organ that is our human brain, and you can see how it is adorned with vessels. You can see the gyri and the sulci, and you can see how majestically it is sitting on the anterior and middle cranial skull base. So when you remove the vessels, this is what you see, the naked surface of the brain. And it is important to know that it's not just the frontal, parietal, temporal, occipital lobes. There are other many important parts of the brain that are very relevant to all of us as neurosurgeons. So this portion that is made up of the pre and the post-central gyri is also the central lobe. The lobe that is hidden between the frontal, parietal, and temporal opercula is the insula. And on the middle aspect of the brain, you have the limbic lobe. So basically, till now, we have always been used to a traditional theory that there are eloquent areas in the cortex, and these are important. You protect these, and you will have a good surgery. So traditionally, they have been the Broca's area and the Wernicke's area. But as we have evolved, we have realized that both the cortex and the underlying subcortical white matter pathways are important for function. You can study this by direct electrical stimulation, and you can study the anatomy by cadaveric white fiber dissection. You should also remember that sometimes some of these cortical areas can come back to life by plasticity. If you damage an area, and another area might take over function, and the patient will start recovering. But if you damage the subcortical pathways, it is irreversible because you have broken the circuitry. You have cut the wire that connects two regions, and that cannot be repaired. So some important pathways that you must remember while going into intraaxial brain surgery, I'll just show you some few pathways. So basically, this is the language has a dual pathway, and this is one of them. This is the semantic or the ventral pathway. And what are its components? The superior and the middle temporal gyrus, the dorsolateral prefrontal cortex, the inferior frontal gyrus, and the most important subcortical fiber tract is the IFOF for this pathway. If you damage it in the dominant lobe, you will have semantic paraphasias, and in the non-dominant lobe, you will have non-verbal comprehension disorders. The other language pathway that is important is the phonologic or the dorsal pathway, and its important constituents are the inferior and middle frontal gyrus and the superior temporal gyrus, which are connected together by the arcuate fasciculus, as you can see in this image. For spatial awareness, there are important gyri are the supramarginal and the superior temporal gyri, and the important tracts that maintain spatial awareness is the SLF2 and 3. Naming is correlated by the middle posterior parts of the superior temporal gyrus, middle temporal gyrus, and the inferior parietal lobule, mainly the angular gyrus, and the fiber that is involved in this function is SLF3. And all this area comes in this junction, that is the temporoparietal occipital junction, and I will show you in the anatomy images later how so many fibers accumulate in this region and how important it is to understand the anatomy of this region. So some important cortical landmarks. So you see this region, this is the central sulcus, this is the precentral gyrus and the postcentral gyrus. This region that connects the pars opercularis of the inferior frontal gyrus to the precentral gyrus is the classical area where you stimulate, you will get speech arrest. So this is the ventral premotor area. And this whole area, the region of the pars opercularis and the pars triangularis, is classically known as the Broca's area. On the superior surface of this hemisphere, the yellow circle that you see here is the supplementary motor area that helps in performing learned activities. The area in front of this is the pre-SMA, though they are not well defined. This is the region where they occupy. And the pre-SMA is important for learning the movements, complex movements. The SMA executes them, the pre-SMA learns them. This region where the superior frontal sulcus meets the precentral sulcus is the region that is known as the dorsal premotor area. And this region, this orange circle, where the superior frontal sulcus indents into the precentral gyrus, is the hand motor activation area, or the omega region, as you can see on the MRI. This is another important point where the superior frontal sulcus meets the precentral sulcus in this region. This is the superior Rolandic point. On the middle aspect of the hemisphere, you can see that the precentral and the postcentral gyri are connected together, and the whole region forms the paracentral lobule. This is the cingulate gyrus, which goes around on top of the corpus callosum and ends in the temporal lobe as the parahippocampal gyrus. The SMA region is also here, right in front of the paracentral lobule. This region, this purple circle here, where the middle frontal gyrus meets the precentral gyrus, is the area that it has the frontal eye fields. So basically, these are some important cortical points that are very essential for performing interaxial brain surgery. Now, going to the subcortical anatomy, we recently published this article on the architecture and function of the white fibers of the brain. We divided, you first see this table. These are, what we have done is we dissected each gyrus and labeled the fibers that come underneath each gyrus. So from all the approaches, each gyri was dissected and all the fibers that come underneath the gyri were identified. Then based on our understanding, we divided white fibers into these 5 groups, 4 horizontal groups and 1 vertical group. The horizontal group, the most superficial of them was the short association or the arcuate fibers. The middle group contained the long association fibers, that is the SLF, the arcuate, the ILF, the uncinate, the IFOF, etc. The deep group are the fibers that were present in relation to the ventricle. And the central group consisted of commissural fibers, as you can see here, which are labeled here. The vertical group, that is the projection fibers, mainly constitutes the internal capsule and the thalamic radiation. So you can see in this image, this is the superficial group, short arcuate, middle group, long association, red circle is the deep group in association with the ventricle, the green circle are the commissural fibers, and the orange circle are the projection fibers. So let's go into the relevance of this cortical and subcortical anatomy. So again, you can see this brain from the lateral aspect. Once you start dissecting, you remove the gray matter on top of the cortex and the gray matter in the sulci, and this is what you will see. You'll start seeing the short arcuate fibers. This is a wonderful DTI image that is made on a 7 Tesla MRI, and you can see how innumerable the short arcuate connections of the brain are. So once you remove all the gray matter on the surface of the brain and in the depths of the gyri and the sulci, this is what you will get. You see the innumerable short arcuate connections connecting the various gyri of the brain. Once you remove the short arcuate connections, on the lateral aspect, this is what you'll start seeing first. This fiber that you see running from the frontal to the parietal region is the superior longitudinal fasciculus, or the lateral part of the superior longitudinal fasciculus, as it is lateral to the projection fibers. This fiber bundle that you see here running from the inferior frontal gyrus all the way to the temporal region is the arcuate fasciculus, as it runs around the insula. More further dissection in this region reveals these fiber tracks more clearly. You can see the SLF here. Traditionally, they have been called as SLF 2 and 3. I like to call them the lateral SLF. This is the arcuate fasciculus. This is the gray matter of the insula has been removed, and you can see the extreme capsule. Now all the gray matter on the lateral aspect of the hemisphere has been removed, and you can see all the white fibers in the region, the SLF, the arcuate, the ventral occipital fasciculus, and the corona radiata. This is another image where the fibers of the temporal region are also seen. So beginning here, this is the SLF, this is the arcuate, this is the middle longitudinal fasciculus that connects the temporal to the parietal region. And this fiber right in the inferior aspect of the temporal lobe is the inferior longitudinal fasciculus. On the middle aspect of the brain, the most important fiber is the cingulum here. And you can see how the cingulum connects to the precuneus by this connection. And it also connects to the superior frontal gyrus by another connection. The fiber tract that runs on top of the cingulum is the SLF1, or the medial part of the SLF. I call it medial because it lies medial to the projection fibers. So based on this understanding, based on this cortical and subcortical anatomy, we have recently come with a concept regarding gliomas. And we are saying that gliomas are confined to a named white matter tract. That is, they originate from a named white matter tract and they displace the adjoining normal tract. So if you understand this, you can develop a plane of resection around the tumor and remove it. So this is a recent paper that we have written where we have evaluated the anatomical extension of the gliomas based on the fiber tracts seen on MRI and diffusion tensor imaging, and have divided the gliomas into two types. The localized type that arises from the short arcuate fibers and remains confined to the gyrus. If it spreads to the adjoining gyrus, it will go by means of its short arcuate connection, and that is how it will spread. That is a localized group of tumor glioma. This is the first type. And the other type is the diffuse type. The diffuse type arises either from the long association fibers. As you can see, this is a tumor of the cingulum that goes along the path of the cingulum, extending along the precuneus. And I will show you in later images how the gliomas of the cingulum look like. So this is one type of diffuse glioma. And the other type are commissural gliomas, gliomas that originate from the commissural fibers. As you can see here, this is a glioma of the corpus callosum. And most of these tend to be bilateral, and they spread to both the sides of the hemispheres, but they are limited by this vertical group of projection fibers on either side. So this is the recent paper, and this is the strategy devised by Professor Goel. Is en masse tumor resection a safe surgical strategy for low-grade gliomas? And I'm going to show you various images, clinical photos, and videos showing how we perform this surgery and how we have reduced the need of intraoperative monitoring by using this strategy. So you see this patient, see this tumor. This tumor is in the supplementary motor area. You can see the central sulcus, the precentral gyrus, the postcentral gyrus, and this is the region. This is the tumor in the supplementary motor area on the left side, as you can see in this anatomical location. You see that the corticospinal tract has been displaced posteriorly. So now this is the video. Earlier we were using monitoring for all these tumors, and you can see that the leads are being inserted for phase reversal to identify the central sulcus. After that, we start the tumor resection. We use sonography and navigation while doing the resection. Neuronavigation is used in the initial part of the surgery, not every time, but quite a few times, and it is used to localize the low-grade glioma mainly. Sonography is used when we start the surgery to show the location of the tumor, to define the anterior and the posterior aspects and the middle and lateral boundaries of the tumor. So this is the resection. As you can see that a plane is being developed around the tumor and an en masse surgical resection is being performed. As you can very clearly see in this video, you can see this plane which has been clearly able to be formed around the tumor. I'll just go ahead. And you can see, you can easily identify this plane of dissection. And you can identify the normal from the abnormal and perform an en masse surgical resection of the tumor. You can see now the video is progressing and the whole tumor has been excised with minimal coagulation, as you can see in the surgery. And this is the en masse tumor resection that has been performed. And this is the post-operative MRI of the patient showing the en masse resection. If you see the MEPs, you can see that there is no change in the MEPs. They are completely maintained. However, as the tumor was in the supplementary motor area, the patient developed a supplementary motor area syndrome. As you can see here, she's having some difficulty in making speech. She's not able to say much. She's just attempting to make a few sounds, but she's not able to speak. You can see that her right side is not moving. Her left side is spontaneously, she's able to move and she's obeying commands, moving the left side. So there is very minimal movement of the right side. She's having difficulty in initiating the movement. You can see here, the hand is, there is stone in the hand. She's able to, it does not fall, but she's not able to voluntarily move it, as you can see in this video very clearly. And this is a few days after surgery. It's before 10 days after surgery. You can see she has already started improving. She's verbalizing. You can see that she's verbalizing clearly and she's able to move both her hands. And she's able to walk. She has a little difficulty, but she's able to walk on her own. And after a few months of surgery, she has become completely normal. So this supplementary motor area is very commonly seen in these tumors in the region of the supplementary motor area. There's another tumor in this region, and patient developed a supplementary motor area syndrome after the surgery, but a few days after that, he was absolutely normal, as you can see here. And you can see the radical tumor resection in this post-operative MRI. This is a dangerous tumor right in the precentral gyrus. As you can see here, this is the central sulcus, and the corticospinal tracts have been pushed laterally and posteriorly. And again, you can see the strategy. Once you understand the anatomy of the cortical and subcortical fibers, you understand that the normal fiber is pushed behind. This is a tumor arising from a named white fiber tract, that is the short arcuate fiber. So you go around it, you develop a plane of dissection, and you perform an en masse resection, and you will be able to do it without causing a deficit to the patient. So this, you can see the video, is the initial part. I'll go ahead. And you can see a good plane of dissection is being developed and an en masse surgical resection is being performed. If you see this area, this cortex here is that of the precentral gyrus, and you will see that it has been completely preserved at the end of surgery. This is the en masse tumor resection. And the tumor is being resected completely. And this is the end of the surgery here. And you can see that the gyrus is completely preserved. There is hardly any coagulation, and a beautiful radical resection of the tumor has been performed. And this is the post-operative image of the patient, and you can see the patient. There are no deficits, absolutely. This is in the immediate post-operative period. This is another tumor in the region of the pars opercularis. You can see that the functional area, the speech area, has been pushed posteriorly. These are the fiber tracts that will be in relation to this opercular tumor. And once you understand this, you can go ahead and perform a radical resection. There's another tumor in the region of the middle frontal gyrus, and you have to understand that it will be medial to the corticospinal tracts, and the SLF will be pushed inferiorly. And this is the en masse tumor resection that has been performed, and you can see beautifully the patient has done well. There's another tumor in the region of the SLF. This is a tumor in the region of the middle part of the SLF. You see how it is spreading along the SLF, along the named white fiber tract. And you perform an en masse resection. Sometimes you have to do a piecemeal resection for a diffuse type of glioma, but in this we were able to achieve an en masse resection by developing a plane of dissection. And you can see the post-operative image showing the tumor resection. This is another tumor that we have recently performed, again in the region of the pars opercularis, where it is abutting with the precentral gyrus, as you can see in this region. But you can see that the corticospinal tracts are displaced medially and posteriorly. So the same way you can go ahead and perform an en masse resection. And this is the patient in the immediate post-operative period. Even his dressing is not yet out. And you can see that there are no deficits, absolutely. He is able to perform all his activities without any problem. So this surgical strategy helps. Once you understand the anatomy, you can do this kind of surgical strategy and perform a good, safe radical resection. This is another tumor in the region of the orbital frontal gyri, and you can see the tracts that are displaced by the tumor. This is the forceps minor, which are laterally displaced, and you can see the en masse resection that has been performed. This is another tumor. It is exactly in the premotor region, and you can see that the en masse resection has been performed, and this is a delayed image showing no tumor absolutely, with no deficit to the patient. Now, this is a tumor in the speech area. This is your classical Broca's area. So we've used navigation to get to the tumor. You understand the fiber anatomy, that the arcuate fasciculus is around the tumor, displaced medially by the tumor, and you will be able to perform a resection. This patient was not at all cooperative or awake monitoring, so we had to do it under anesthesia. And you can see that again a plane was identified. The tumor was identified on the surface of the brain. Once you get more experience, you start identifying the tumor just by looking at it. You can differentiate the normal from the abnormal. As you can see here, this is the normal. This whitish area is the abnormal. Also, you can tell by the feel of the tumor. Once you start developing the dissection, you can differentiate normal and abnormal, and you are able to get a good plane of dissection and perform the surgery. As you can see here, again, the abnormal has been identified. Of course, we can use sonography to help identify this area. It gives a good idea about what is the extent of the tumor. And again, a plane is being developed. As you can see here, all the vessels are being preserved in this region. Most of them are en passage vessels, and it is very important to preserve this, as you will see here. So this is the en masse resection that is being performed of the tumor. And I'll just go to the end of the surgery. And you can see that there is this vessel here. This vessel here is completely being separated from the tumor, and it is being completely preserved without any coagulation. So it is important to preserve these vessels to avoid any deficit also in these patients. That is another reason why the patient gets deficit if there is a vascular injury. And this is the immediate post-operative period, and you can see that the patient is able to verbalize. There is some mild dysarthria, but he's able to verbalize quite well. This is on the second day of surgery, and after a few days, he was completely normal. So going ahead, this is another patient with a tumor in the region of the postcentral gyrus. You can see the fiber tracts are displaced medially and little anteriorly. You go ahead and perform an en masse resection, and this is the patient in the immediate postoperative period. So going to the posterior aspect, going to the temporoparieto-occipital junction, as you can see here, this is the superior temporal gyrus as it goes into the supramarginal gyrus. This is a tumor in the region of the superior parietal lobule. As you can see here, you will see here that it is medial to the corticospinal tracts. It displaces the SLF, the arcuate inferiorly, and you go ahead and perform a radical resection, and you will be able to give a new dimension to the patient, a new life to the patient by reducing the bulk of the tumor. So these are the fibers that are important in the temporoparietal junction. So now you see this is the arcuate fasciculus, and it has been cut here. And you start seeing these fibers. So this one is the IFOF. Below that you have the optic radiations. Above the IFOF you have the middle longitudinal fasciculus. So this junction has a lot of fibers. So they are the fibers of the sagittal stratum. So basically they are the middle longitudinal fasciculus, the IFOF, the temporal fibers of the anterior commissure, the optic radiations, below that the tapetum, and this whole junction forms the temporoparieto-occipital junction. So when you go deep, if you go beyond the gyrus, then you will damage these tracts. You have to understand which tracts come in the way, and you'll be able to preserve them. So this is a tumor in the parietal lobule, and you can see how the tracts are displaced, and you can see the en masse resection and how beautifully and radically the tumor has been resected. So there is another tumor in the region of the parietal lobule, again on the left side, but patient was done without any awake mapping, without any monitoring, by just understanding the cortical subcortical anatomy, and you can see the en masse resection and the postoperative image showing the radical resection. Now going into the region of the insula, so this is the region of the insula. You have the frontal, parietal, and temporal operculum. Once you open the operculum, which are the curtains, you will see the hidden island of the insula, which is made up of these short and long gyri. This is the central sulcus of the insula, which continues with the central sulcus of the hemisphere, lateral aspect. And this is the image showing the relation of the insula to the ventricle and to the other various structures. So this anterior aspect of the insula is related to the caudate head. The posterior aspect of the insula is related to the atrium. This is the choroid fissure, it running between the thalamus and the fornix. Once you dissect in the insula, this is the operculum has been removed. These are the gyri of the insula. This is the limiting sulcus of the insula. Once you remove the gyri, you start seeing the extreme capsule and the claustrum. Once you remove the extreme capsule and the claustrum, you see some fiber bundles that connects the insula to the cortex. These are the costrocortical fibers, and this is the region of the claustrum. Once you remove that, you start seeing the external capsule. Below that is the putamen, and below that will be the internal capsule. So these are the fibers of the external capsule. And you can see here the classical spoke and wheel appearance, where you have the external capsule, the putamen, and underneath that you have the internal capsule. And this is the fibers of the IFOF. So basically the external capsule is made up of dorsal and ventral parts. So this is the ventral external capsule, which constitutes of the IFOF and the uncinate fasciculus. And the dorsal external capsule are these fibers that go beneath the arcuate to form the corona radiata. So this is the IFOF as it originates from the frontal lobe and goes all the way to the temporal lobe in this region as constituent of the sagittal stratum. This is the image that I'd shown you earlier, and you can see how the IFOF forms part of the sagittal stratum. This is after the whole putamen and the base globus pallidus has been removed, and you can see the entire extent of the internal capsule, the anterior limb, the genu, the posterior limb, the retrolenticular portion, and the sublenticular portion of the internal capsule. Now, this is an image showing the relation of the hippocampus and the temporal horn to the fibers of the IFOF and the optic radiations. I will show you in detail this later. This is the entire extent of the internal capsule. So this is a DTI image showing the important fibers, the arcuate, the IFOF, etc. So now going to insular tumors. This is a tumor in the region of the perisylvian region, and you understand the anatomy, you understand the fibers are displayed displaced medially and a radical resection of the tumor has been performed. This is a proper insular tumor that is arising from the short gyri of the insula. You know which fibers are going. Medially is the IFOF, around it will be the arcuate, and more medially will be the internal capsule, which you have to avoid damage to both the internal capsule and the IFOF. And once you understand the anatomy, you will be able to remove these tumors. There's another small adjunct that can be used, indocyanine green ICG, to identify the perforators. I will not go into that for the lack of time. This is another insular tumor. You understand the anatomy of the cortex and the subcortical anatomy, and a radical resection of the tumor can be performed as seen in this image. See the fibers, how they are displaced around the tumor. Going to the inferior aspect, so this is the region of the uncus. This is the parahippocampal gyrus. This is the fusiform gyrus. These are the important structures in this region. And you see how the uncus is closely related to the cerebral peduncle. This is the region of the anterior perforated substance bounded by the middle and lateral olfactory striae. Once you do perform dissection in this region, you remove the gray matter in the inferior aspect on the parahippocampus, and you start seeing this fiber bundle here, that is the radiation of the cingulum. So the cingulum comes from medially and all the way in the entorhinal and the parahippocampal region as the radiation of the cingulum. Once you start reflecting that, you will see the ependyma of the temporal horn. Once you remove the ependyma, you start seeing the hippocampus with the head, body, and tail. And this is the choroid plexus. This is the amygdala in the roof of the temporal horn. Once you deflect the hippocampus posteriorly, you start seeing the Mayer's loop as it comes from the lateral geniculate body, curves into the roof anteriorly and the lateral aspect of the temporal horn posteriorly. So this is the Mayer's loop. You can see it curving nicely here in this image. And this part of it, when you see from laterally, this is the Mayer's loop as it forms part of the sublenticular form of the internal capsule. So now to understand this for epilepsy surgery or for approaching middle temporal tumors. So this is a lateral image. You see this is the fibers of the IFOF. Now I have turned this image. So now you see how these fibers are related to the temporal horn. So this is your IFOF going like this, and this is the head of the hippocampus. So this region here is devoid of any fibers. There are no white fibers here. So if you enter from the middle temporal gyrus in this region, you're going to avoid fibers to both the optic radiations and to the IFOF. So this is a safe entry point to enter the region. And this approach for amygdala hippocampectomy was described by Professor Goel, and we have been using it in our departments in the 1990s. And this is the region where the corticectomy has been made. And you can see how the hippocampus can be identified here. And this is the extent of lobectomy and amygdala hippocampectomy that we perform. As you can see here, this whole area can be removed safely without causing any damage to any fiber bundles. So again, this is an image, inverted image that I showed you. So you see here, this area here is devoid of any fibers. So the optic radiations are initially in the roof and then in the lateral aspect of the temporal horn. So here there are no fibers and you can safely enter from this region. So this is a medial temporal tumor that I had operated, as you can see in the region of the parahippocampal gyrus, using the same approach by entering the middle temporal and inferior temporal gyrus junction, and a radical resection has been performed. This is another medial temporal region tumor of the parahippocampal gyrus. So you understand the fibers are displaced superiorly. You can easily enter from the middle temporal gyrus and perform a radical resection. This is a tumor of the inferior temporal gyrus arising from the short arcuate fibers of the inferior temporal gyrus. There is no fiber tract that will be damaged in this, except maybe the ILF, which again is sometimes displaced superiorly. So again, there may be no problem, and you can en masse do a surgical resection of this tumor. So the occipital gyri and sulci are quite indefinite, but largely they are divided into superior, middle, and inferior occipital gyri. On the middle aspect, the lingual gyrus continues as the parahippocampal gyrus, as you can see here, and so cingulum also continues, and the lingual gyrus both continue into the parahippocampal gyrus. Again, on this inferior aspect, you can see how the cingulate gyrus is continuing into the parahippocampal gyrus. And these are the fiber tracts. So the important thing to understand in this region is this is the ventricle. This yellow structure is the ventricle. Medial to the ventricle, you have the fibers of the forceps major. These are the fibers of the forceps major. And lateral to the ventricle are the optic radiations, as you can see here in this image, E. So this, if you remember this relation of the tumor to the ventricle, you'll avoid injury to the fiber tracts by understanding the anatomy. So you see this tumor, which is medial to the ventricle, which is medial to the forceps major, and you go in from an interhemispheric approach and a middle approach and perform an en masse surgical resection. This is the delayed image showing the tumor resection. There is another tumor that is present in the isthmus of the cingulum. You see this tumor right in the isthmus of the cingulum. It is medial to the forceps major. Use navigation to enter this tumor, and you can see the en masse resection that has been performed beautifully. This is the post-operative image. Now, going lastly to the inferior aspect of the brain, this is the orbital surface of the frontal lobe. This is the H-shaped cruciform sulcus of Rolando, dividing it into the medial, anterior, posterior, and lateral orbital gyri. So we devised an approach to resect lesions in around the frontal horn, deep-seated lesion, which are relation to the frontal horn of the lateral ventricle. This was initially described by us in 2008 or 9. Then recently, we have devised two trajectories and to approach lesions of the caudate head, deep-seated tumors that have been used. This approach has been used by us to resect these tumors. And you can see this is the medial trajectory and the lateral trajectory. These are the entry points, medial corticectomy and the lateral corticectomy. And this is some anatomy of the region. This is the region of the anterior commissure. These are the fibers of the uncinate as they are turning to go into the temporal lobe. And once you upturn the specimen, this is the frontal brain, this is the temporal brain, this is the frontal horn, this is the region of the caudate. And you can see by both the trajectories, if you come from medially, you're avoiding maybe just some injury to the forceps minor. And if you come from laterally, you will avoid all the fibers, especially those of the IFOF, and you'll be able to perform a good resection. So this is just an example showing the caudate head tumor and approach from a lateral orbital trajectory, and you can see the radical resection. Now going to the limbic lobe, which is another important constituent of our human nervous system. And you see this middle aspect of the hemisphere. This is the cingulum, cingulate gyrus. Once you cingulate gyrus, as it becomes the parahippocampal gyrus, the parahippocampal gyrus turns upon itself to form the uncus. And once you start dissecting in this region, this is the region of the thalamus. You remove the gray matter of the thalamus. You start identifying the mammillothalamic tract. So here, this is the fornix that is becoming the columns of the fornix, ending in the mammillary body. This is the mammillothalamic tract. And this is an image showing the dissection superficial to the corpus callosum. And you see the cingulate gyrus has been removed. This is the entire extent of the cingulum as it curves into the temporal lobe, ending in the radiation of the cingulum. This is the connection of the cingulum to the superior frontal gyrus and to the precuneus, as I told you earlier. So going further into the dissection, once you identify the mammillary body, mammillothalamic tract, this is the anterior nucleus of thalamus. Then I've cut the corpus callosum and you see the caudate head. Now to dissect further, you have to lift the caudate head and you can see the anterior thalamic radiations. So this anterior thalamic nucleus connects to the cingulum by means of this anterior thalamic radiation. And the whole thing constitutes the Pappé circuit, which you can see here. This is the hippocampus, this is the fimbria, this is the fornix, columns of the fornix, mammillary body, mammillothalamic tract, anterior nucleus of thalamus, anterior thalamic radiation, cingulum, and back again, ending as the radiation of the cingulum in the entorhinal area. And this is the whole Pappé circuit that has been constituted outside to show how beautifully it is done in this image. So this is our paper on the subject, which is a very highly cited paper. Now, why understand the anatomy? To approach tumors of the limbic system. So this is a tumor in the region of the parahippocampal gyrus. Easily you can approach it from this inferior root because there are no fibers in the way. You can lift the inferior temporal gyrus or go through the inferior temporal gyrus. The ILF is displaced superiorly and you can go ahead and remove this tumor as you can see in this image. Now, as I had shown you, a tumor of the cingulum. So you see this cingulum, the fiber going to the precuneus. You see this tumor arising from the cingulum and extending along the course of the fibers of the cingulum. And you understand this. So this is a diffuse type of glioma Also, the important thing is the corticospinal tracts will be lateral. The tumor will not cross the vertical group of fibers, so it will remain medial to the corticospinal tract. And you go by an interhemispheric approach and you can resect the tumor. Lastly, corpus callosal tumors, which form the another diffuse type of gliomas. And you can see this. We have recently published this anatomical paper on the corpus callosum and its connections. So this is the entire corpus callosum, and you can see how widely it is connected to the brain. So if you see here in this image, I will show you, these orange fibers are the forceps minor. These purple fibers we have called the dorsal callosal radiations. This orange, pink and green fibers are the ventral callosal radiations that actually curve inferiorly. So this connects to the caudate head and the basal ganglia region, and this parts the tapetum, forms the tapetum as it forms the lateral wall of the atrium and the temporal horn. And this yellow fibers are the forceps major, and this blue color that you can see is the IFOF. You can see how closely related these fibers are to each other and how extensively the corpus callosum is connected to the entire brain. So these are safe points to perform a callosotomy. A callosotomy should be performed in the transverse direction. So in this direction, so that you splay the fibers, you do not incise the fibers. And this is the region of corticectomy in front of the fibers that connect the motor region for the anterior interhemispheric approach. And this green rectangle is the area that is safe for a posterior interhemispheric approach to perform a callosotomy. This circle here is a no-no because the motor fibers are in this region and you will definitely cause a deficit. Again, in this region of the splenium, you should try to avoid entering in this region. However, when you are performing for epilepsy surgery, the whole callosotomy has to extend from the anterior to the posterior, involving these motor fibers. Otherwise, you will not get a good result. So why to understand the anatomy? Because the glioma spread along these fibers. So if you see this tumor, it appears completely bizarre. But if you understand how it is arising, it is going along the forceps major, it is going along the dorsal radiation, it is going along the ventral radiation, and you understand this anatomy, but in spite of going along the radiation, it is not causing the corticospinal tracts. As you can see in this image, it is completely bounded by the corticospinal tracts. So the best way to approach this is an interhemispheric approach, as we have done, and you can see the beautiful resection that has been performed, and the patient did well after the surgery. So to end my lecture, basically it is very important to understand the cortical and subcortical anatomy of the brain before you are trying to go into any kind of intraaxial brain surgery. Thank you very much.
Hello, my name is Yokazu Takami from Department of Neurosurgery, the University of Tokyo Hospital, Japan. Today's topic is about evolving management schemes surrounding gliomas. Recent updates. First, I'm going to introduce myself a little bit. I graduated from Tokyo University in 2005, and I did neurosurgical residency at Tokyo University Hospital and affiliated hospitals for 7 years, and I got board certified in 2012. And I did basic research on transcriptomic analysis on germ cell tumors, and I got PhD on that topic. And I crossed the Pacific Ocean to the United States, and I did clinical fellowship for 2 years at Mayo Clinic in Minnesota. And I crossed the border to Canada, and I did a surgical neuro-oncology fellowship at Toronto University for 1 year, and I came back to Japan. I was appointed as assistant professor at Tokyo University since 2019. My clinical interest is about awake surgery for low-grade gliomas, and my research interest is about genomic analysis on brain tumors. Today's talk overview is about glioma management updates, including role of surgical resection, surgical equipment and modalities, white matter fibers, adjuvant treatments, and molecular classification updates because we have been using WHO 2016 for classification, but maybe very closely we are going to see WHO 2021, which is very unique and uses a lot of molecular classification. So I'm going to introduce a little bit about it. So low-grade glioma is not a benign tumor against the name because low-grade glioma is not stable. It increases by 4 millimeter per year on average, and it transforms to malignancy. For example, diffuse astrocytoma goes change into grade 3 anaplastic astrocytoma for 2 to 5 years, and oligodendroglioma changes into anaplastic oligodendroglioma during the period of 5 to 10 years. So low-grade glioma is not a benign tumor, even if it is diagnosed as grade 2. And in treatment of low-grade gliomas, external resection is a predictive factor in terms of progression-free survival on the left side and in terms of malignant progression on the right side. And this paper shows that even tiny residue after the surgery can affect survival in the long term. If there is no residual tumor after surgery, the prognosis is very good for low-grade gliomas, but even a tiny bit of tumor after the surgery on post-op MRI leads to a poor prognosis. With that, the idea of supratotal resection emerged. Like in this case, there is a small flare high lesion in the right frontal lobe, which was resected supratotally, including the surrounding normal tissue. The idea behind this concept is that 10 to 20 millimeters from the flare high area, there are still a lot of tumor tissues reflected by high MIB1 index, but more than 20 millimeters away from the flare high region, there are not so many tumor cells. So there is a conversion from image-guided treatment surgery based on MRI's navigation into functional guided surgery by resecting the tumor until we reach the functional area. This idea was applied to GBM as well. In GBM cases, flare high area was resected more than 53%, and the overall survival was better compared with less than 53%. And with this result, the term flarectomy was coined. Also, while the tumor is still small, the prognosis is better compared with a large lesion. So we have to detect a lesion while it is still small. And brain MRI checkup was suggested for 20 to 40 years old because the median age for low-grade glioma is 36 years. By doing brain MRI checkup, we can screen the tumor while it is still small, meaning that we may be able to resect the tumor as a whole without any residual tissue. So we have to strike a good balance between extent of resection and multiple very important brain functions when we do a surgery for invasive gliomas. And also, we have to know that right-handed people have dominant hemisphere on the left side for most of the cases. For left-handed people, dominant hemisphere exists on the left side as well for 76%, but the rest of the patients bilateral hemispheres are working. There are a lot of modalities and ways to increase extent of resection, including diffusion, tensor imaging for visualize white matter fibers, 3D images to integrate CT, MRI, fibers and PET, etc. to make one beautiful image. I'm going to show an example later. Functional MRI and what a test to determine the dominant hemisphere and cortical important functions, interop navigation, fiber ARA, interop CT and MRI, electrophysiological monitoring, including MEP, SEP, interop cortical, subcortical stimulation, and awake surgeries. Functional MRI is used to determine preoperatively the dominant hemisphere using a language task to probe the positional relationship between tumor and functions, including motor, sensory, and language. FIBE-ARA is an abbreviation of 5-aminolevulinic acid. A paper from Lancet Oncology in 2006. They compare the cases when they used FIBE-ARA during the surgery versus just white light of microscope. The gross total resection rate increased from 36% to 65%, and also there was a significant longer progression-free survival when they used FIBE-ARA, comparing with white light. In terms of interop CT or MRI, a paper from Lancet Oncology, the authors showed that the post-operative tumor volume significantly decreased when they used interop MRI versus conventional surgery without interop MRI. Although the difference was not statistically significant, there was better prognosis when they used interop MRI versus without interop MRI. For interop stimulation, a paper from Journal of Clinical Oncology showed that the total resection rate significantly increased from 58% to 75% when they used interop stimulation. For awake surgery, a paper from neurosurgery showed that near total resection rate increased from 40% to 82% when they used awake surgery method. Even the patient is asleep, we can use MEP, SEP, VP to monitor motor, sensory, and visual functions. But fine motor skills, position sense, visual fields cannot be evaluated with these methods. So to preserve these functions, we have to do an awake surgery. For a long time, we paid much attention to the cortical surface of the brain, including Broca's areas, Wernicke's areas, visual field, and motor and sensory cortex. But this is just kind of a tip of the iceberg. There's a lot of important functions below the cortex. So these white matter fibers are very important, and also they are more vulnerable to surgical damage and also has less plasticity than cortex. So in this sense, white matter fibers are the limiting boundary for tumor resection. We have to understand white matter fibers, including SLF, ILF, uncinate fasciculus, and IFOV, and arcade fasciculus, because every one of these has specific brain functions. For example, in this 35-year-old male patient with a left frontal lower grade glioma, it was diagnosed as grade 3 on a pathological slide. Before the surgery, there is a big left frontal tumor, and 3D visualization enabled us to identify the IFOV, inferior front occipital fasciculus, which is functioning as a semantic speech, and also there is a frontal afferent tract just behind the tumor, which has a function of speech initiation and motor initiation, and also there is a cingulum, which is not visualized here. So we did an awake surgery, and almost all of the tumor was resected, except for some tumor close to the cingulum, and also there is a left behind tumor close to the frontal afferent tract, because the patient started to show speech problem during the surgery when I was resecting the tumor here. Of course, it is not so easy to understand these white matter fibers precisely. So there are several dissection courses around the world, including Santander in Spain, Istanbul in Turkey, Zurich in Switzerland. I attended some of these courses, and a course in Istanbul in Turkey. There are international doctors from around the world, including Lebanon, Kazakhstan, Croatia, and Russia, and me from Canada at that time. And this kind of white matter dissection course give us a good image and good visualization in our minds about white matter fibers. Based on these ideas, the basic strategy for gliomas, it is a little bit busy slide, but if it is diagnosed with low-grade glioma without molecular features of malignancy, I'm going to talk about the molecular features of malignancy later in this slide, in this presentation. We have to think about maximal safe resection, hopefully supratotal resection, because it can lead to cure of this disease. And if the total resection was achieved, maybe just imaging follow-up is okay. Some doctors insist on radiotherapy or chemotherapy, but they have a long-term side effect. So we may just do imaging follow-ups. If there is a residue on the post-op imaging, some doctors insist on just imaging follow-ups and another resection at growth. If the residue is still small after the surgery, after the first surgery, or the options include plus minus radiotherapy, plus minus chemotherapy, and there's no clear recommendation about the residual tumor because it depends on the age, the size of the residual, the performance status. But in general, temozolomide plus radiotherapy for astrocytomas and PCV, or temozolomide plus radiotherapy for oligodendrogliomas. If the tumor is diagnosed as high-grade gliomas or low-grade gliomas with molecular features of malignancy, still we need to aim at maximal safe resection, hopefully flareectomy, resection of the flare high regions as well. But but many of the times the tumor is kind of broad or close to the important functions. So we usually do temozolomide plus radiotherapy plus minus novel TTF. I'm going to talk about this later. For the elderly, there are several publications. Temozolomide only for MGMT methylated cases and radiotherapy, but this is performed for short course, and radiotherapy alone plus minus temozolomide for MGMT unmethylated cases. Temozolomide addition has some good long-term prognosis effect, but not so striking. There's an option of using PCNU warfare indicated for high-grade gliomas and recurrent GBMs. There are papers from Europe because this warfare was accepted in North America very recently. So studies almost from Asian countries or Europe. And there was a benefit in terms of overall survival and for newly diagnosed high-grade gliomas and recurrent GBMs. But there are some cautions. It is only effective for cases with gross total resections, hopefully without ventricular openings, and some patients show overt brain edema after the surgery, and also increases the risk of cerebrospinal fluid leak after the surgery and the infection. So we have to do a watertight dural closure during the surgery. Novo TTF, a paper from JAMA showed that there was an increase of progression-free survival and overall survival when patients used this device by around 3 months for PFS and also 5 months for overall survival. And there was not a significant clinical sequela because of this device, except for some skin rash. The problem is that it is very expensive, around $2,100 per month, and also it has to be worn for more than 18 hours a day. Bevacizumab for recurrent high-grade gliomas, there are two important reports about using this medication, including Abgurio and RTOG 0825. The important thing is that there was a significant betterment of PFS for both of the trials, but there was no difference in terms of overall survival, like on steroid. The cautions, including proteinuria, high blood pressure, DVT, intratumor hemorrhage, have to be kept in mind. So finally, we are going to talk about molecular profiles of diffuse gliomas. There are two distinctions. One is astrocytoma and the other is oligodendrogliomas. It is called diffuse astrocytoma for grade 2 and anaplastic for grade 3. The same for oligodendrogliomas. So these are IDH mutant. Glioblastoma is totally different. This is an IDH wild type tumor. So these two tumors are totally different. And for astrocytomas, there is usually a TP53 mutation and ATRX mutation. And for oligos, it is characterized by 1p19q co-deletions, and also there's a TART promoter mutation at the same time. Glioblastoma also has TART promoter mutation, but these tumors are totally different. These tumors are outlined like this in terms of tumor malignancy. GBM with IDH wild type is worse. Oligodendrogliomas with IDH mutant and 1p19q co-deleted is the best in terms of diffuse gliomas. When IDH is mutant, GBM is a little better. And also, IDH wild-type tumors are generally worse compared with IDH mutant cases. And astrocytomas are generally worse than oligodendrogliomas. And during the period from 2016 to 2021, there are a lot of molecular investigations, and this paper identified really malignant low-grade gliomas, including IDH wild type and chromosomal 7 gain 10 loss, TART promoter mutation, and EGFR amplifications. If one of these molecular features is identified, so in this Kaplan-Meier curve, cases with one of these features was grouped into group 5, and it is very close to GBM in terms of PFS and overall survival. So these cases, even if they are diagnosed as grade 2 or grade 3, these are molecular type GBM. And although TART promoter mutation in EGFR amplification chromosome 710 are important, most of these cases have TART promoter mutation. So at least these molecular features should be investigated if a case is diagnosed as grade 2 or grade 3 IDH wild type astrocytoma. For IDH mutant cases, CDKN2A is very important. This red dotted line shows GBM IDH mutant, and this blue dotted line indicates grade 3 anaplastic astrocytoma with CDKN2AB homozygous deletion. The Kaplan-Meier curve is very similar. So even if it is grade 3, when it has CDKN2AB homozygous deletion, it is similar to grade 4. So this is a very busy slide approaches for that, but we have to follow this roadmap to reach the best treatment for patients. If the pathology is low-grade gliomas, we have to check the immunohistochemistry for IDH R132H, and if it is positive, it means that it has IDH mutation. Then we have to do a 1p90q assay by FISH or MLPA, and if there is a co-deletion, it is diagnosed as oligodendroglioma, IDH mutant, 1p90q co-deleted. And also, this type of tumor is characterized by TART promoter mutation as well. It is checked by Sanger sequencing. And if there's no co-deletion on 1p90q, then we are going to reach diagnosis of astrocytoma IDH mutant. And usually this tumor has TP53 mutation and ATRX loss by checked by immunohistochemistry. And if it's diagnosed as astrocytoma, we have to do an CDKN2AB investigation assay by FISH, MLPA, or methylation array. And there is a deletion, it is called as grade 4, and if not, grade 2 or 3, based on pathological diagnosis. And if IDH mutation was not detected on immunohistochemistry. If the patient is younger than 55 years old, there may be an IDH mutation on other spots. So we have to do a Sanger sequencing. And if it's positive, then we are going to move to here because IDH mutant. Then we have to follow this. And if there is no mutation, then we are going to go here. And we have to check the TARC promoter mutation by Sanger sequencing, chromosomal 7 gain 10 loss by FISH MLPA, and EGFR amplification by FISH MLPA PCR or methylation array. And if one of these is positive, it is diagnosed as glioblastoma IDH wild type, and if it is negative, maybe it is pediatric type diffusion glioma. I don't cover this type of tumor in this presentation. And if the tumor is diagnosed glioblastoma pathologically with microvascular proliferation or necrosis, we have to check the MD methylation status by a PCR parasequencing or methylation array. So it is very confusing, but we have to remember this kind of roadmap. Recently, there is a molecular investigation called methylation classifier. We usually use this for cases when the case is very difficult to be diagnosed just on pathological specimen. We need to perform Illumina methylation array 450K or 850K. Then we can submit the file to the website from Germany, DKFZ. Then just based on the methylation, the website returns the methylation diagnosis. For example, in this case, the tumor was diagnosed as pineal parenchymal tumor. So this was a PPTID case. So we can obtain the diagnosis based on methylation classification, and also the website shows us this kind of copy number status. So we can check the 1P92 EGFR copy number status, etc. But the drawback is that it is very costly, $500 to $1,000 per case. Recently, there's a move forward oncology panel for personalized medicine. We submit blood and tumor specimen and run next generation sequencing to detect a mutation out of the panel of genes. And based on the results of the mutations, we hold an expert meeting. And grounded on that opinion from the expert panel, we can suggest molecular targeted therapy for a specific mutation, and also there is a possibility of entering clinical trials for the patients. In summary, low-grade glioma is a curable disease, and surgical resection is of the most importance. Maximal resection is advantageous for GBM as well, including flare-high areas. Sophisticated pre-op and intra-op modalities and ways help maximize self-resection, but we know that not all the equipments are available in all the hospitals, so we have to choose the best mix of the modalities. Molecular analysis became indispensable for the diagnosis in updated WHO classification and for selection of most appropriate treatment. However, installation of necessary immunohistochemistry and molecular assays are very costly and demands lab skills, which has become a conspicuous issue worldwide. Thank you very much for your attention.
Ladies and gentlemen, I'm Dr. Sanford P. Shi. I'm coming from Taipei Veteran General Hospital, now the Associate Professor at the Department of Neurosurgery. I'm also the visiting professor in the Department of Neurosurgery of University of Virginia in the States. Today, I would like to talk about the surgical approaches to deep-seated brain lesions. At the beginning of my lecture, I will shortly introduce myself. I have done fellowship at UMS Little Rock between 2007 to 2009. At the time, the UMS of the Department of Neurosurgery was deemed as the mecca of microneurosurgery because we have three great mentors at our institute. The first one, as you have known, is very well-known Professor Yasacho, and also the chair of the UMS is Professor Osama Mafti. And I also learned the cerebrovascular and cavernous sinus surgery from my mentor, Professor Ali F. Krisht. All these three great men have won the laureate of Herbert's Olive Crown Award in 1978, 2011, and 2019. This slide was the slides I made for Professor Yashiko. The first time he visited to Taipei in 2006, he write down several key points about his microneurosurgery. Several key points, the most important of them is we have to rediscover of the cisternal anatomy, which can allow us to explore the lesions in each side of the CNS through the subarachnoid space, so-called cisternal navigation. Also, we have to recognize the compartmental anatomy of the CNS and the related predilection size of the lesion. Not only the neoplastic, but also the vascular lesion and degenerative or congenital disease. And the end of the microneurosurgery is to complete elimination of the lesion, and we have lessened or even to do the surgery without a rigid brain retraction, so that we can do the minimal invasive to the brain. So in summary, the essence of the safe maximal microneurosurgery by Professor Yashiko, simply to say, is using the minimal invasive techniques. For example, we're using the cisternal navigation, retractless and transosseous approach to the lesion to totally remove the tumor based on the compartment concept and the basic coagulation techniques. And the anatomy basis of Professor Yasuko of his microneurosurgery is based on the embryology and also the 1 meter tracks, which he learns from Professor Klingler with the fiber dissection technique. So, since I would like to talk about the deep-seated lesions, what kind of lesion is belong to the deep-seated lesions? Usually, people say we have the central core of the anatomy. The central core is deep-seated sites within the brain, including the insula, basal ganglion, thalamus, and also the ventricular system and the brainstem. Lesion in such kind of deep-seated lesion is very difficult to approach. And also we have to apply the concept and the techniques of microneurosurgery to the deep-seated lesions, so that we need to find the best ways, the best approaches to the lesions compatible with the minimal invasive techniques. So I summarize several common surgical approaches to different compartments of the brain and including the deep-seated lesions. As you can see, we highlight several approaches with the asterisks, which I will mention later in my lecture. So we can use the transylvian to the insular region, to the mesial-basal temporal. We can use the transcallosal to the intraventricular space, to the caudate, to frontal horn. We can use the transpecunious approach to the posterior thalamus, to the limbic, paralimbic, trigone region, and also the supracerebellar, transtentorium, transcoroidal, supracerebellar, infratentorium, televelar, pretemporal, transcameral approaches to different parts of the deep-seated lesions. So in these slides, you can see the number in different parts of the deep-seated structures of the brain, and which I summarized the best approaches to the corresponding sites. So let me using the case illustration to make the to demonstrate each surgical approach. The first case I showed is the typical hippocampal lesion, hippocampal tumor within the mesiotemporal region. So the lesion involving the uncus, amygdala, and the hippocampus. So what is the best approach to this kind of lesion? As you have known, the best approach to this kind of lesion is pterional approach, and we have to open the sylvian fissure, following the N2 to N1, widely opening the sylvian, so that you can expose the piriform gyrus just by side of the N1. And if you open the piriform gyrus, like this picture showed, you made a cortical incision on the piriform cortex lateral to the M1 segment, then you can go deep into the temporal horn and expose the hippocampus. So in this approach, using this trajectory, you can reset the hippocampus as long as the amygdala. This is a common used approach not only to the tumor, but also to the epilepsy surgery, for example, the mesiotemporal sclerosis. Also, such kind of the typical insular tumors, although it is large, but everything is pushed away. So the tumor is originating from the extreme capsule of the insula. For such kind of lesion, the typical approach is also the pterional approach, widely opening the sylvian as long as the Heschel gyrus, exposing the pyramidal shape of the insula. For example, you have to expose the anterior limiting sulcus, superior and inferior limiting sulcus. So you have got 3 corners and 3 lines. But for such a case, as the tumor rising from the insula, when you remove the tumor, most of the people are afraid that you go too deep into the posterior limb or the internal capsule. So the anatomy helps you a lot. And also, people are afraid of the lenticular artery. If you damage or sacrifice the artery, the patient will suffer a sequelae of hemiparesis or hemiplegia. So, if you learn how to remove insular tumor, you have to know all the anatomy surrounding the insula and also the vasculature anatomy. If you know all this blood supply is coming below, not on the insular surface, then you realize you can sacrifice small branches from the N2 and 3 segment, and you cannot go too deep below the putamen. If you see the small blooding spots from below, then you realize that you go too deep behind the putamen because the blood supply is from below. Also, you have to know the venous anatomy. All the drainage veins is going to the ventricle. So when you remove the tumor and you can follow the venous structure and it direct you to the frontal horn. For example, in this case, you using the microsurgical technique, you expose the sylvian, and when you widely open the sylvian, then you dispose the tumor within the insula. In this case, you also need to open the hexogyris, the most difficult part of opening the sylvian. The color of the tumor is different from the normal brain, so when you're the experienced getters, you can easily recognize the difference in the color. Then you have to coagulate the small branch, like I said, from the M2 or M3 branches. All these small arteries supplying the surface insula. So you can sacrifice them and you can debulk the tumor. When you find some small bleeding spots from below, and you also can see some different color change when it turned from the white to a little bit gray, then you realize you have reached to the putamen, so you have to stop. So in this picture, you can see the color is different from the tumor than the putamen. Then you remove the residual of the tumor and identify the anterior limiting sulcus, superior limiting sulcus. Then you find the venous structure and it directs you, you give you the direction to the frontal horn. This is called medullary veins. Then you go ahead to remove the remaining of the tumor, following the medullary veins. Then you know you almost to the caudate. The caudate also has some little different color than the normal brain. So you stopped. Then at the posterior corner of the pyramidal shape, you can use in the monitoring using the subcortical stimulation to realize how far is the point to the corticospinal tract. If it's 5 milliampere, it elicits the response of the corticospinal tract, then usually I will stop because it's almost 5 millimeter to the corticospinal tract. So in these techniques, also with the knowledge of anatomy, you can totally remove the insular tumor. And the another important steps, you have to keep the lenticular striate intact. Then the terminal approach is the best basic approach, and actually you can deal most of routine surgery like the ACAN aneurysm, PICA aneurysm, or the tumor in the insula, mesiotemporal, or the frontal basal. But some lesion within the frontal horn or caudate, then the second most common approach is transcallosal approach. Like this picture showed, it's very easy. Just open the, just using the interhemisphere and expose the corpus callosum and medial incision, then you can get entry to the frontal horn, to the ventricular system. But for the lesion in the anterior ventricular system, you can use in the anterior transcallosal approach. But if the lesion is arising from the trigone, such in this case, this is a typical trigone meningioma. How can we approach into the trigone? In this picture showed, if you go from lateral, you may destroy a lot of the fibers especially when the lesion is on the left side, you may damage the visual fibers or damage the language function, especially in the left side. So the surgical approach is to trigon. The best way is using the precuneus approach. You go into hemispherically and you localize the so-called precuneus gyrus. Then you make the cortical incision, then you can get into the trigon. So the color shaped is the precuneus gyrus. Using the precuneus approach, the most important step is to identify the splenion of the corpus callosum, because the splenion, the point to the corresponding to the gyrus is the precuneus. If you go too anteriorly, you may mistaken the postcentral gyrus as the precuneus gyrus. That's what cause people, the patient, some sequelae or the neurology deficit. So you made a cortical incision in the precuneus gyrus, then you can get entry into the trigon. Like this case showed, not only the trigon meningioma, but also the posterior thalamus tumor, you can also use in the precuneus approach into the trigon. Then you can identify the choroidal plexus. Medial to the choroidal plexus is the thalamus. So you can remove the lesion from the posterior thalamus region. And this is a post-op picture. And usually we're using the IOMN with the subcortical mapping, like I showed in the insular tumor, to localize the cortical spinal tracts. Then you can keep the patient neurologically intact. The next, the case showed the patient has a lesion arising from the basal temporal, the so-called fusiform gyrus. In such a case, if you're using the terminal approach, you open the temporal horn, then you can see the normal hippocampus. If you want to remove the lesion, you need to open the hippocampus. You need to make a cortical incision within the hippocampus and reach the lesion. But this is not reasonable, because the hippocampus is important, especially on the left side. The hippocampus make you in charge of memory function. So it's not feasible for terminal approach to reach the basal temporal region, like the fusiform tumor or the cavernoma. So what's the best surgical approach to such kind of lesion? Another case. This is another case arising from the parahippocampal gyrus, or even when you do the long segment or the hippocampectomy. When you do the terminal approach from anteriorly, it's very difficult to reach the posterior part of the hippocampus. So in such kind of case, what is the best approach? In such cases, we can use in the supracerebellar transtentorian approach from behind. You open the posterior fossa and you open the dura, and usually we're using the park bench with a semi-sitting position to let the cerebellum drop down by gravity. And you can expose the tentorium when you tackle the dura up, and avoid the damage to the drainage vein. You can open the tentorium. After opening the tentorium, you need to identify the fusiform gyrus, the parahippocampal gyrus. The parahippocampal gyrus is just lateral to the brainstem. So this is the fusiform gyrus. So in this picture, these surgical photos, you open the posterior fossa, then you open the tentorium, you expose the basal part of the temporal lobe. You need to recognize the fusiform gyrus, parahippocampal gyrus. Then you made a cortical incision in the fusiform gyrus. Then you can get entry to the temporal horn, so you can expose the hippocampus. Using this approach, you can remove the posterior part of the hippocampus and also go deep anteriorly and deep to the tip, the head of the hippocampus. So you can totally remove the hippocampus using this kind of approach. This approach has several advantages, especially using this approach rather than the Tirano approach. The Mayer's loop of the aortic thread is preserved. But this approach, the disadvantage of this approach, you have to be familiar with the anatomy of the basal temporal region. So in this patient, also with the hippocampus tumor, then we're using the supracephallar transtentorial approach to totally remove such kind of lesion. And the post-op visual field follow-up show the normal visual field and no visually deficits. Now, if the lesion is within the thalamus or midbrain, and in this case, the nearest, the shortest distance of the lesion to the surface is from top of the, from the bottom of the third ventricle. It's very close to the bottom of the third ventricle. So if you need to get access to the third ventricle, you need to use in the transcoroidal approach. So people can refer to the paper written by the Professor Hongzu Wen. He beautifully describes a step-by-step transcoroidal approach to the third ventricle. Into the third ventricle, the most important landmark is the thalamostrial vein, the coroplexus, and fornix. You just identify the coroplexus. You open the fornixial, the choroidal sulcus at the fornixial site. You follow the vein and open the tela choroidea to expose the thalamostrial vein and the internal cerebral vein, and some artery branch from the medial posterior choroidal artery. And you can also identify the massa intermedia within the third ventricle. And this is the real surgical photos. You follow the fornixial side of the coroplexus, preserve the fornix, open the tela choroidea, and expose the internal cerebral vein, and you identify the massa intermedia. And this is a third ventricle. Then you can open the bottom of the third ventricle to reach the thalamus or the midbrain region. But in such a case, the lesion is more close to the posterior part of the midbrain. So in this case, we can use in the supracephallar infratentorial approach. Using this approach, you have to be aware of the basal vein, internal cerebral vein, and you have to identify the pineal region. So this is the surgical photos. You push the cerebellum down to identify the dorsal aspect of the midbrain. Then you can remove the tumor, preserving the posterior part, posterior aspect, dorsal aspect of the midbrain, and you remove the tumor. And this photo show that you also enter the third ventricle from behind. But in this case, the lesion, although it's in the posterior part of the thalamus and midbrain, but the lesion is more laterally localized. So this is post-op picture. The tumor is totally removed, but how I do it? In this case, I'm using some variants of the supracerebellar infratentorial approach, so-called the supracerebellar lateral approach. In this approach, the most important is you have to identify the lateral mesencephalic sulcus. Usually you have to localize the tragus nerve and the lateral mesencephalic vein. Then you make a cortical incision just behind the vein, and you can enter the lateral aspect of the midbrain and also the thalamus. So this is the surgical photo. You push the cerebellum down, identify the lateral sulcus, and make a cortical incision. Then you can get access to the lesion. And this is the post-op. But if the lesion is more close anteriorly, almost is bulging out in the ventral aspect of the brainstem, in such a case, by using the pretemporal transcavernous approach, you need to go through the cavernous sinus, then you can expose the prepounding space, and you can go get access to the ventral part of the brainstem. So this is surgical photos that I go through the cavernous sinus. Then I identify the trigeminal nerve, the entry zone of the trigeminal nerve. Then I made it a cortical incision medial to the trigeminal entry zone to get access to the ventral pons to remove the lesion. So you can refer. I published the case, and you can refer to the neurosurgical focus, the October 2019 Volume 1 Issue 2. You can see how I do it to remove the pontine glioma using the pretemporal transcavernous transcavernous approach.
Pretemporal transcavernous transtentorial approach for right pontine cavernous malformation. This is a 57-year-old.
So I published a similar case in neurosurgical focus, and you can refer to this video. Then, if the lesion is down below the brainstem, like the medullary or the fourth ventricle, or the foramen luschka, or the cerebellar peduncle, in such a case, usually we're using the televelar approach. Using this approach is very important because it's similar to the transcavernous approach. And you open in the sylvian like you open in the tonsil, and also the tela choroidea like you open in the sylvian. Using this kind of approach, you can totally expose the fourth ventricle. You identify the limiting sulcus, and you can, using the monitoring, to localize the 7 nucleus, or the lower cranial nucleus, and made a cortical incision or the shortest distance to the lesion. Using this approach, you can deal with cavernoma, glioma between the pons and medulla. So I briefly introduced several important and basic surgical approaches to deep-seated lesion, including the ventricular system, the basotemporal, and the thalamus and brainstem, and considering and applying the anatomy, and also the most important of the microneurosurgical concepts, we can meet the needs of the patient, and also we can reach the real minimally invasive to the lesion. In the past decades, we have several topics of hands-on anatomy dissection courses. Because if you want to do a good microneurosurgery, the anatomy is the most important. So you need to learn, starting your lectures, your career from the lab. You have to be familiar with every kind of anatomy. Then you apply your knowledge to your patient, and the patient will benefit from you. And also you have to learn a lot from all these great mentors. So welcome to Taipei, and this is our the museum of the microneurosurgery, and we have very beautiful posters and handprinting, all courses and great mentors. Thank you very much.
Good morning, everyone, and it's a real pleasure to be here with you. My topic is sound therapy for brain disorders, that is, using ultrasound to treat brain disorders, and we're going to take on this topic in three different phases. One is we're going to discuss the use of ultrasound to make therapeutic lesions in neurosurgery. Secondly, we're going to discuss the use of ultrasound to stimulate the brain. And lastly, we are going to discuss the possibility of using ultrasound to open the blood-brain barrier for the delivery of chemical and biological agents to the brain. Now, the history of ultrasound and the brain is long. For at least 70 years now, neurosurgeons have been using ultrasound. The problem has always been the skull, and in past years, it was necessary to drill holes in the skulls, as in these trephines shown here, with the view of letting the ultrasound go through the dura and to make a lesion in the brain, as is shown here in the figure on the bottom left. Over the course of time, however, these problems have been improved, because now it is no longer necessary to expose the dura to let the ultrasound go through. Although 90% of the ultrasound energy gets blocked by the skull, if you use 1,000 beams and you focus these beams on a specific target point, then there's enough energy that accumulates at the focal point to make a therapeutic lesion. So that's been one advance, is using these multiple arrays of ultrasound to focus them to a single point. And secondly, the entire procedure can now be done in the MR machine, and we can use MR thermography to actually monitor in near real time the temperature of the ultrasound. So this then permits us to really go just about anywhere in the brain, and to make very precise therapeutic lesions with the resolution of what the MR is, in the order of 1 millimeter. The way this works is the patients have their head shaved, and they get into the ultrasound helmet. This particular helmet has 1,024 transducers. The entire procedure is done within the MR environment. Usually the patients are, and we're able to aim the ultrasound energy at a specific spot. In this case, we're doing a thalamotomy for tremor, and we are applying the ultrasound energy for approximately 13 seconds, and this results then in a temperature rise of up to 62 degrees at this target in the thalamus. And so this is a 2 by 2 millimeter voxel where the temperature rise has gone up to 62 degrees. And this, of course, is going to result in making a therapeutic lesion in the thalamus. So you can see here the temperature rise, 13 seconds, then it goes down, and this is the location of lesion. Now, these lesions are immediate, of course, and instantaneous, and over the course of time, the magnitude of the lesions can change. So initially on day 1, for example, there's edema following a central core necrosis. There's still some edema, hemosiderin and necrosis on day 7, but then by day 30 or day 90 after this right thalamotomy, you see that the lesion is starting to get smaller. So let me show you what this looks like in a real patient. So this particular patient has essential tremor, and you'll see that he has tremor involving both sides. And we are going to target his right dominant hand. So we are going to make a lesion in his left thalamus. You can see how disabled he is. He's unable to take a drink of water because of his tremor. He's unable to sign his name because of his tremor. So he goes into the MR machine scene here on the right, and now he's going to drink some water. And you'll see that in fact he's able to now drink water quite well.
When's the last time you could do that? More than 10 years.
I asked him when's the last time you could do that, you can drink water. He said it's been more than 10 years. So we've published our first paper on this now 8 years ago. And since then, there have been a large number of publications, including this one in 2016, where a multi-center trial where the safety and the efficacy of ultrasound was examined. And basically, what we know now is that this procedure is extremely efficacious and is quite safe. There can be side effects related to speech and gait difficulty, especially if the lesion is too large or if the lesion is inferior to the thalamus. If the lesion is too posterior, you can get sensory deficits, and if it's too lateral, you can get corticospinal effects. Altogether, though, I tell our patients that there's a 2 to 3% chance of producing a serious adverse effect related to these lesions. But this then lends us to consider the various options that we have for treating patients with tremor. And there's, of course, radiofrequency lesion through a burr hole. There's deep brain stimulation as an option. There's radiosurgery with gamma knife. And now the new option is magnetic resonance focused ultrasound. Each one of these modalities has specific benefits and drawbacks. Of course, the radiosurgery and the focused ultrasound are non-invasive, does not involve any drilling, no skin incision. The difference between radiosurgery and ultrasound, however, is that the ultrasound is immediate. With radiosurgery, as you know, there's a delayed response, and you can never be quite sure that you did the right thing. There's also some unpredictability in the radiobiology of the brain. On the other hand, with MR, you get an immediate lesion. It does not grow after the lesion is made, and it takes about 15 minutes to do the actual ultrasound procedure once everything is lined up. So now we are indeed offering this procedure to patients on an outpatient basis, and we are doing 3 procedures per day. We now give the patient this choice. So we give them a menu where we say you have tremor, and there are 4 operations, and these are the 4 possible operations that you can have. And increasingly, the patients are opting for focused ultrasound to treat their tremor. So now this is the most common procedure we do for tremor is focused ultrasound. And indeed, throughout the world now, focused ultrasound has overtaken gamma knife and DBS and radiofrequency lesions as the most common procedure for patients who need a thalamotomy to treat their tremor. So this is really, it has changed the way that we treat tremor and has been a major change in functional neurosurgery, the advent of focused ultrasound to treat tremor. Now, you can imagine that if you can use ultrasound to make tremor, to make lesions in the thalamus to treat tremor, you might also be able to use it for other things, including treating Parkinson's disease, ablating tumors, pain targets, psychiatric targets, etc. So what I'll do is I'll just give you a few examples of the other possible indications, the other possible applications of focused ultrasound to treat neurological disorders. And this, of course, is a work in progress and things are evolving. So in the context of Parkinson's disease, we have several targets, including the internal segment of the globus pallidus, the thalamus, the subthalamic nucleus, and the pallidothalamic tract. And indeed, one is able to target any of these areas with focused ultrasound, and there are now examples of efficacy and safety profiles of targeting these various areas with focused ultrasound. For example, this group from Korea, led by Dr. Jinwoo Chang, has produced pallidotomies, very effective in treating Parkinson's disease. Another group in Switzerland, led by Daniel Jamino, has treated the pallidothalamic tract to treat Parkinson's disease, also very effective. And a third group in Madrid with Jose Obeso has made subthalamic nucleus lesions to treat Parkinson's disease. So these are three additional targets that are now being examined in the context of Parkinson's disease. But now, other than movement disorders, focused ultrasound is also emerging as a therapeutic modality to treat psychiatric illness. In particular, it can be used to treat obsessive compulsive disorder by doing lesions in the anterior limb of the internal capsule, as was done here by this group from Yonsei University in Seoul, led by Dr. Chang. And so anterior capsulotomy is certainly something that can be done. Focused ultrasound. The group of Daniel Jamino is also treating pain by doing bilateral central lateral thalamotomies. So these are the interlaminar nuclei that are being lesioned for patients with various pain, including central pain procedures. Now, there are also some very interesting therapies in development. Now, it is possible to, for example, use ultrasound for thrombolysis and for dissolving blood clots. So in this particular example, this is work from Virginia. This is a cadaver study where an intraventricular clot was made by injecting blood into the ventricles. And what you see here on panel C is that in the mid portion of the clot, there has been a sonication, and in fact, you see that the clot has been cleared. So you see the dark area in front and behind, and the area of clearing where the ultrasound has been applied. So this indicates then that it is possible to treat intraventricular and also hopefully intraparenchymal hemorrhages of the brain by using sonothrombolysis to dissolve blood clots. So this is something that's in evolution. Perhaps this will find a role in the neurosurgical armamentarium. Interestingly, it is also possible to do thrombolysis of intravascular clots. And here's an example in an animal study now in a rabbit that it is possible to open a thrombosed vessel for dissolution of a stroke in an embolic model using ultrasound and reestablishing blood flow in a vessel that was previously obliterated by an embolic stroke. An exciting possibility is the possibility of treating hydrocephalus with ultrasound. One of our residents in Toronto, Ryan Alkins, took this project on of doing third ventriculostomies using ultrasound. So this would be a non-invasive ventriculostomy, no skin incision, using ultrasound. The way this would work is, of course, we all are familiar with using an endoscope to do endoscopic third ventriculostomy, but in this particular case, in 6 pigs, he was able to apply ultrasound to the lamina terminalis of the third ventricle. And some good news and bad news. He was able to open the third ventricle, as shown here in panel B. So you see that there's a communication between the CSF space and the ventricle. However, there was quite a bit of collateral damage in the hypothalamus. And so this clearly requires some additional polish before it's ready for prime time in humans. But nevertheless, it does establish a principle that it is open. It is possible to open the CSF circulation using ultrasound, and in this case, using a third ventriculosity. So it would be fantastic if one day we were able to treat hydrocephalus in this non-invasive way by using a third ventriculosity. But considerable more work, especially on the safety side, has to be done before this becomes a reality. Now, so far we've been discussing ultrasound to discuss making lesions and some novel applications, but in terms of dissolving things or making openings in the brain. Now we can also consider the possibility of using ultrasound to stimulate the brain. And we know that ultrasound can stimulate either on the surface or at the depths. We can aim the ultrasound several centimeters deep, 6 centimeters, 8 centimeters deep. And what this means is that we can now stimulate not only the surface of the brain, but we can also stimulate deep brain structures non-invasively. So this is done with a single ultrasound transducer and can be done by non-invasively. And just to prove to you that indeed one can stimulate with ultrasound, this is an experiment in an animal, and this is a rat, and they're being stimulated with ultrasound at 1 hertz, 1 time per second. And you'll see that every time that the ultrasound is applied, it produces a contraction of the hemibody and the tail. And so this is an example of ultrasound driving the corticospinal tract, in fact, bilaterally. You see that in both forelimbs are moving with ultrasound. So it's very clear that ultrasound can be used to stimulate the brain as well. And what does this mean? Well, it means that, number one, we might be able to use ultrasound for cerebral mapping, for example, preoperatively to identify motor, sensory, speech areas, etc. Another interesting possibility is that we might be able to use ultrasound to stimulate deep targets, for example, the STN and the GPI. And in this way, we might be able to predict what the effects of chronic stimulation might be. So it's a way of screening, if you like, what the effects of DBS might be by using ultrasound as a non-invasive way of stimulating and reaching these deep targets and seeing what the effects of stimulating these targets could be. And finally, one could also imagine that if you could stimulate chronically, that perhaps it would be possible to apply chronic ultrasound stimulation instead of chronic deep brain stimulation as a therapeutic modality. And this would be done, we know that there's already some equipment available, so there are ultrasound transducers available that can be put in burr holes and could be used for chronic stimulation of using ultrasound. So this is a possibility where here you would just simply do a burr hole and there would be no penetration of the brain with any hardware, but the burr hole would be the source of the ultrasound transducer, which could then stimulate at deep targets. So also some pretty interesting possibilities. The last thing I want to tell you about is the possibility of using ultrasound to open the blood-brain barrier. And this is done with the aid of injecting microbubbles. So microbubbles are available. They're a contrast agent. People use them for cardiac and hepatic imaging, for example. So you do an intravenous injection of microbubbles. And then these microbubbles, of course, enter the circulation and enter the capillaries in the brain. And with the application of the ultrasound, the microbubbles will contract and expand. And you see here on the panel on the left where the microbubbles change in size from small to large. Usually these microbubbles are 3 to 5 microns. They can expand quite a bit. And as they expand, they can actually part the endothelial cells on the tight junctions that hold them together. And so in the example here in the video, you'll see these tight junctions, these 3 little dots that interconnect the endothelial cells. And as the bubbles expand, the tight junctions are open, and then the therapeutic molecules, in this case, these purple spheres, can then enter the brain parenchyma. And so it looks like this then is a possible mechanism through which one can focally open the blood-brain barrier almost anywhere you want in the brain. So what does this mean? Well, normally molecules greater than 400 molecular weight do not enter the brain very well. And so this means then that new molecules, including most drugs, antibodies, nucleic acids, antisense oligonucleotides, antibodies, even cells and chemotherapeutic agents could now enter the brain. And in fact, this has already been used in animals and increasingly is being used in humans. In this particular example shown on the left, there is an example of an injection of a virus, an AAV virus that carries the tomato gene, and where the virus is expressed is seen in red. And so this is a direct injection at the bottom where you see the expression of the tomato as a proof of viral transduction of these cells. But in the upper panel, the virus has been given intravenously, and the blood-brain barrier has been opened with ultrasound. So here, using ultrasound and the bubbles, it's possible to open the hippocampus, and then intravenously the virus leaks out of the capillaries into the brain where the BBB has been open, and then there the virus is able to enter the cells and transduce the cells. So this is gene therapy by delivery of viral vectors without an incision, where only the blood-brain barrier is open, and once you give it intravenously, it only enters into the brain where the blood-brain barrier has been open. So this is quite exciting because it opens the possibility for gene therapy and other therapies non-invasively. There are some drawbacks, of course, to giving intravenous or intra-arterial gene therapy, because when you give it intraparenchymally, the dose is about 1/1000th of the dose required when you give it intravenously or intra-arterially. So there are some issues to resolve, but nevertheless, this establishes the possibility that one can do things like gene therapy non-invasively by opening the blood-brain barrier focally and delivering gene therapy in this way. Just to give you an examples of the delivery of chemotherapeutic agents using this approach, Todd Mainprize and colleagues in Toronto have opened the blood-brain barrier in primary brain tumors for the delivery of additional chemotherapy, either doxorubicin or antibodies. So this particular example, there's an 8x8 matrix of spots in the brain where they've opened the blood-brain barrier. And we know that it's open because you can give gadolinium and the gadolinium will leak where the blood-brain barrier is open. And so in this particular example, you see the 8 dots of gadolinium corresponding to where the blood-brain barrier has been open. Typically, at these doses, the blood-brain barrier seals up after 24 hours. So if you repeat the gadolinium injection after 24 hours, it's no longer leaking into the brain. And this tells you that the blood-brain barrier is open transiently, so you have a window of 24 hours to get in the chemotherapeutic agents or the biological agents into the brain after opening the blood-brain barrier in this circumstance. So in conclusion then, we've discussed 3 different ways where ultrasound might become important in neurosurgery. The first application is the use of ultrasound to make therapeutic lesions in the brain. And we've talked about the possibility of thalamotomy, the possibility of doing lesions to treat Parkinson's disease. Obviously, this could be expanded to make lesions to treat epilepsy. We could consider doing amygdalohypocampectomies. We could consider trigeminal neuralgia, tumors. So there are a large number of possibilities in terms of the ablative potential of ultrasound for therapeutic means. Second, increasing interest in the possibility of using ultrasound to stimulate the brain. And here we're talking about using ultrasound to map cortical function and subcortical function. We also could envisage using ultrasound, because it can go deep into the brain, 8 centimeters into the brain, to predict or mimic what DBS might do. In this way, we might be able to predict what the consequences of DBS might be in a particular patient. And in the future, one might even envisage chronic stimulation through an implant in the skull to deliver chronic ultrasound stimulation as an adjunct or as instead of deep brain stimulation. So that's quite an exciting possibility. Thirdly, we've also discussed the possibility of opening the blood-brain barrier using focused ultrasound with microbubbles. And here, really, we're talking about delivering chemotherapeutic agents, delivering cells, delivering antibodies to the brain that otherwise would not get in. And so this also opens a large number of possibilities. Now, with respect to lesions and so on, as you know, DBS is at the forefront of Parkinson's disease surgery and tumor, but the lesions are coming back and with ultrasound. And DBS is very good, of course, but it's invasive, it requires batteries, it requires hardware. The patients are sometimes afraid of having DBS lesions. So it seems that then that the lesions are making a comeback, and this may seem like a step backwards, but for some patients, it's indeed a step forward, and it's something that we have to evaluate seriously in our patients. The use of ultrasound to make lesions is part of the general movement towards minimally invasive and low maintenance therapies. And so these procedures are done to make lesions as an outpatient. There are no incisions. They're well tolerated. And so I think that the acceptability of these procedures is quite high, and this is why they are becoming popular. And this is why the patients are preferring the focused ultrasound, because many patients who would never agree to have DBS are accepting to have focused ultrasound, and the same is true for some of their doctors. And so really, the number of patients that are now amenable to surgery and who are accepting treatment is now much higher, because in the past they were shut out. They would not accept DBS, for example, but now they will accept focused ultrasound. So this means that the number of patients that are candidates for therapy and who are accepting therapy is much greater. One of the interesting things about the ultrasound is that it's producing a rapprochement, a blurring of the boundaries between neurology, radiology, and neurosurgery, and increasingly all members of all of these disciplines are being bound together and developing these things. I think it's very important for neurosurgeons to maintain their leadership role in ultrasound as it applies to neurosurgical procedures. But obviously, just as there are, the radiologists and neurologists are becoming more interventional, I think it's something that we have to be aware of, that perhaps these procedures will also be taken on by our colleagues in the other disciplines. As far as the making lesions, so far the first approved indication is tremor, but as I've told you, there are several new indications that are in development, not only for movement disorders, but indeed for other psychiatric conditions, for tumors, for epilepsy, for pain, even perhaps for hydrocephalus. So it is clear that focused ultrasound may contribute not only to making minimally invasive lesions, but increasingly also that focused ultrasound could be used to stimulate and map the brain, stimulate for therapeutic reasons, and also to open the blood-brain barrier. So there are many interesting possibilities that lie ahead in this field of ultrasound and the brain. And with that, I would like to thank my colleagues in neurology, psychiatry, imaging, neurosurgery, as well as the companies that we work with to do these studies, and the 70 fellows that have trained with us and who are really the engines of our work. And so I'm very grateful for having been able to train fellows from all over the world. This is my funding. And lastly, I'd like to thank you for your kind attention. Thank you very much for this, the honor of this invitation, and it's been a real pleasure. Thank you very much.
Hello, Prof Itichai.
Hello. Yes.
Hello.
Hello. Can you hear me?
Yes, can hear you. I'm not sure whether we have any speaker now in the.
Can you hear me?
Yes, can hear you. I'm not sure whether we have any speaker now.
Can you hear me? Maybe we can ask the question to speaker. If we don't need to ask, maybe we can type in the as a text in the message. But now I no any question.
I think that there is one question in the chat. It's about re-irradiation recurrent glioblastoma for the second and the third for the second speaker, I think.
So if Prof Sanford is here. Just now he was here.
Professor Lozano.
The question was actually for Professor Takami. It was about about re-irradiation in recurrent glioblastoma. So I think that if he's not here, we can mail the question to him.
Yes.
And there is also another question for Professor Lozano. It was not a question. I apologize. It's a kind of comment.
Yeah, because our question need to specialize answer. So maybe we cannot answer to participants now. Maybe the professor he can reply the answer now in the via email or something to answer for this question.
I don't see Professor Takami on the list, so I think that we'll try to send the question to him and answer the person who asked the question. What do you think, Liu?
Yes, I agree.
tem que voltar. Bom, there are a lot of tumor placed anteriorly in skull base in and around the cella turca. With the development of the endoscopic approaches, nowadays you can choose which is the best for the patient. Some tumors placed on midline, some tumors we spread of the midline, logically require another types or traditional skull-based approach. What? There are many kinds of tumors arising from the lamina crivosa of the etimoide, do plano esfenoidal, do tubérculo da célula, da processo the anterior clinoid process, and the cellular floor, the dorsal cella, the posterior clinoid process, and the cavernous sinus. There are a lot of pathologies. These pathologies, most of the time, require another, different kind of approach. Tá bom? We have meningiomas, chordomas, radical cysts, pituitary tumors, neurinomas, and a lot, and some malignancies too, as you can see in the next slide. The purpose of this presentation is it shows in a series of skull-based tumors, most of them meningiomas and chordomas, which are suitable for endoscopic endonasal approach and microscopic approach. The advantage and disadvantage of each approach for each pathology will be discussed. Frontal skull-based meningiomas. We have a olfatory groove meningioma, plano esfenoidale, tuberculum cella meningiomas, diaphragma cella meningioma, dorsal cella meningiomas, anterior clinoid process meningioma, and more laterally, the cavernous sinus tumors. The first case I'd like to show is a tumor, is a olfatory groove meningioma invading the bone of the anterior cranial fossa. And I'd like to show is it possible to remove a big tumor like this with a small FOZF frontal orbital approach. With this approach, in one piece, you can remove the tumor totally, as you can see in the post-operative control. In this picture, you have the bone infiltrated by the tumor, and the lamina, the histopathologic studies showed the bone invasive by the tumor. Another case is I use the same procedure as the case before. Look at this. Plano esfenoidal meningioma is very confusing because if the tumors grow a little bit more, seems to be an olfatory groove meningioma. I used the same approach and the tumor were totally removed. The big problem here is most of the times you can remove the dura, you can deal in some bone, and the risk of CSF leak is not so low, and then you can prepare when you open the large size of fascia, pericranial fascia, and cover all this region with the pericranial in order to avoid the CFS leak. This is a large clinoidal meningioma type 2. Type 2. This meningioma is arising from the anterior clinoid process, cause a slight hyperostosis, but not in case the carotid artery. And then it's possible to remove all the tumor with a simple frontal temporal approach. With the simple frontal temporal approach, you can devascularize the tumor before open the dura. Some authors recommend the FOZ approach for this tumor, but I believe it's not necessary to remove this tumor. Here we have the type 3 tuberculous cell meningioma. The type 3 tuberculous cell meningioma is the smallest, but cause a serious problems in the vision on the vision of the patient. Look at the tumor, compressed the optic nerve. The patient has a loss of the vision, that has lose a vision on the left side, and then I did a small subfrontal approach and remove the tumor. As you can see here, the tumor placed more laterally. Sometimes the tumor can involve the tumor from superiorly to inferiorly, from medially to laterally, and you need to mobilize the optic nerve, and then sometimes this type of tumor needed for achieve a totally resection, you need to mobilize the optic nerve. And then is a very effective maneuver is open the optic canal, unroof the optic canal, open the dura and the ligament falciform, and then you can mobilize the nerve and remove all the tumor who invade in the optic canal. Look at the postoperative view. Look at the postoperative view. The tumor were totally removed. The patient recovered very well, her visual deficits. Is my number of cases, 93 cases, operated in more than 20 years. I have more cases from tuberculous cell meningiomas, clinoidal meningioma, type 1, type 2, and type 3. Most of them were totally removed, and the complication is very low, and I lost the patient with a clinoidal meningioma due to a tremendous vasospasm of the carotid artery, mechanical vasospasm of the carotid artery with the brain fart, and the patient died. Cavernous sinus meningioma. Cavernous sinus meningioma is a challenge for the neurosurgeon. Sometimes we need to do something for the patient. And some patient with a benign, well circumscribed lesions like a trigeminal neurinoma, patient who have a complexion of the nerve, the optic nerve, and the tumor, have a tumor who invade in the optic canal. A patient with some symptoms such as a retroorbital pain, and sometimes young patients who have a tumor, extra cavernous sinus tumor, compressed the nerves from the lateral wall of the cavernous sinus. And then, but believe me, the so-called whole cavernous sinus meningioma is, for me, is I don't see a field for remove the tumor, but you can decompress the optic nerve, you can decompress the lateral wall of the cavernous sinus, you can decompress the roots of trigeminal nerve to the skeletonize the nerves and the middle fossa. Look at this tumor. Is the whole cavernous sinus meningioma involving and causing stenosis in the carotid artery and invading the optic canal. The patient is a simple position from I did the pterional approach, little bit enlarged. I don't need the Dolenk propose all the time to remove this tumor to the traditional frontotemporal approach, and I try to do the same. This is a video from the cavernous sinus meningioma. Some maneuvers I used to do, like I make a peeling from the middle fossa. I dissect the dura from the anterior clinoid process and identify the meningeal orbital band. Meningeal orbital band, I try to preserve so much time because laterally to the meningeal orbital band, we will have a inferior orbital fissure. And medially, I have a anterior clinoid process. And then after started the peeling, I cut the meningeal orbital band and goes to drilling the anterior clinoid process, and continue the peeling until identify the nerves on the lateral wall of the cavernous sinus. Okay? Here, I deal in the optic canal, I deal in the anterior clinoid process, and after dealing the anterior clinoid process, I open and did the peeling of the middle fossa. I open the dura and goes and communicate the intra and extradural space in order to manipulate and remove the tumor. Look at this. Eu vou passar isso tudo. Look, immediate post-operative view. Look, the anterior clinoid process were totally removed, and parts of the sphenoid wing. Okay, as you can see here, there is no CSF leak, there is no complication in this kind of surgery. And the postoperative view, we can see here a good remove. The patient developed a third nerve death after surgery, but a few months later, she's recovered very well. And the patient was sent to the radiotherapy. Here is no meningioma tumor is much more easy to deal because the tumor doesn't adhere to the cranial nerve. Like is a pituitary tumor, is a type 3 kinosp, is posterior inferior to the carotid artery. I did a so-called transpterygoid approach, cellar and more lateral transpterygoid approach. As you can see here, the carotid artery, look at the carotid artery. You have the tumor here, displace the carotid artery more superiorly. Oh, look at this. Here, the pituitary gland, here, the posterior inferior part of the carotid. Here, you have the sixth nerve. And I could remove all the tumor here. Look at this. This is another case, a patient with a very well vascularized tumor, accommodated the pituitary fossa and the cavernous sinus and compressed the optic nerve. This is a so-called, it's a hemangioblastoma of the cavernous sinus, the patient with the diplopia, left side view 1, and dysesthesia. The patient were submitted anterior clinoidectomy by extradural route, and then I opened the dura and communicated both spaces, and you can see here the carotid artery, the optic nerve, the carotid artery, the third nerve, and the lateral wall of the cavernous sinus, and then I worked between the carotid artery and the third nerve, between the carotid artery and the optic nerve, and look here, you can see remove the tumors, the good space between the third nerve and the carotid artery, and we go to the lateral wall of the cavernous sinus and work between the V1 and fourth nerve, and you can see here the space after remove the tumor. Look at this. See? Fourth nerve, and here you have a V1, is the classical Parkinson triangle. Look at the postoperative view. The tumor is totally removed. The patient developed the third nerve death, but she's recovered very well a few months later. Look at the very common tumor in the orbit, one of the more common tumor in the orbit. This is a cavernous orbit, orbital cavernous meningioma with in a patient blindness from the other side. And then one side committed by the enormous cavernous orbital cavernous meningioma. And then I remove all the tumor, to the cavernous, to the FOZ approach. Look at this, is a frontal orbital approach, the dura, the orbital fat here, the dura mater from anterior and temporal fossa. Here, we displaced the fat over the tumor comes on, and then we can dissect the tumor from the more superficial nerves and the pedicle. The tumor is the last part to cut. Why I chose the approach? Because I can do the mini frontal orbital, superficial orbital incision, but I prefer this approach because the patient does have only one vision on the side of the tumor, and I need to have space for manipulate the tumor in order to preserve the function of the tumor. I can do a superciliar incision, but I prefer remove all the orbital hoof together the lateral wall in order to manipulate better the tumor, as we can show in the postoperative view. But I can do the endoscopic approach too. Look at the atypical meningioma from the anterior cranial fossa invading the orbit from the medial wall of the orbit. Look at this. And the tumor was removed to the enlarged transnasal sphenoidal approach. Endoscopic endonasal transsphenoidal approach, I could remove the tumor, as you can see here in the postoperative view. Look, here is the postoperative view, the space left by the tumor after the surgery without any complication. It's very interesting to have in mind when you have a tumor placed medially to the orbit, medially to the optic nerve, accommodated the medial wall of the orbit. I believe that endoscopic, transnasal endoscopic approach is a very good approach. It's a very unsafe approach. It's the fast approach. Skull-based tumors moving to our new approaches. What's the advantage of the endoscopic endonasal approach? Promote direct access to lesions located at the cilia, supracilla, and the anterior base enclavus. No need brain exposure or retraction, no needing for passing the nerves to reach the tumor, early devascularization of the tumor, best visualization of the ventral structures, which means the tumor, and better visualization of the supracellular structures than transsphenoidal microscopic approach. Disadvantages of this approach, logically, that exist. It's not suitable for lesions that extend posterior or lateral to the cranial nerves. CSF leak risk is higher, but recently lowered by the nasal septal flap. Long learning curve is necessary, more demanding in non-pneumatized sphenoidal sinus, but it's very rare, and calcified or hard tumors like some craniopharyngioma may limit extension of the resection. Look at the anterior skull-based tumors. We have some malignant tumors as a esthesioneuroblastoma, removed from the nose, and this approach is reach the tumor and allow us to remove the implant of the tumor and all the dura infiltrated by the tumor, and you can use the nasal septal flap for close the hole after remove this tumor. This is the number of the cases operated to the endoscopic endonasal approaches. Most of them, logically, are craniopharyngiomas and with the cavernous sinus invasive. Most of them are pituitary tumors with the cavernous sinus invasive. But you have a tuberculosella, esthesioneuroblastoma, mucoceles, lymphomas, clibochordomas, fibrodysplasia, foramen magnum meningioma and clivus, orbital meningioma, reticular cyst, where the tumor operated by us to the endoscopic endonasal approach. Tuberculosella meningioma. Some authors now don't discuss nothing. Use the endoscopic endonasal approach for remove the tuberculosella meningioma. But I recommended to think about considering your experience, you're successful in deal with the tuberculosella, or from the traditional cranial-based approach, or from below. Tumor placed on midline, strictly on midline, no vascular encasement, no invasive of the optic canal, and this consistent soft or cystic can be removed to the endoscopic endonasal approach. And the advantages are early devascularization, you don't need to retract the optic nerve, and you can achieve a preservation of the small perforated artery of the optic nerve. But remember, more than 50% of the tuberculosella meningioma invading the optic canal, And you can stay alert for this, because sometimes the resonance, the MIR cannot show this. And then the main cause of recurrence and tuberculous cell meningioma is the invasion of the optic canal. Look at this. Is a video showing the transsphenoidal route to remove the tuberculous cell meningioma who invading partially the cella turca to the diaphragma cell. Craniopharyngiomas. When to plan the surgery of the craniopharyngioma, you must have a good understanding of the disease and the treatment options. And what the patient present, what the symptomatology of the patient, visual impairment, endocrinological function, and you must define how can aggressive you be. What is the goal of the surgery? Decompression or radical resection? Decompression plus radiotherapy, decompression or total resection. You must have in mind, because if you do a total resection, probably this patient will need a endocrinological assistance all the life. Probably, that's it. And sometimes in my country, it's not possible sometimes. The patient have a endocrinological assistance during all the life. But some craniopharyngiomas is not available for endoscopic approach. Look at this. Lateral extension to the ventricles, lateral extension to the medial fossa or posterior fossa, and big or calcified fragments of the tumor. But look at this craniopharyngioma. It's entirely over the cella, partially cystic, and we can remove totally the tumor to the transsphenoidal approach. Extended transsphenoidal approach, because I need to have a anterior skull base, because I needed to cut the intercavernous sinus and approach the anterior fossa and the pituitary fossa. And then we can mobilize and remove the tumor in order to decomplex, look at the optic nerve. Look at the postoperative view. It's very nice removal. And as you can see here, the graft cover partially the anterior cranial fossa and all the cella. Look, sometimes the non-pituitary tumor like a hypothalamic granuloma. Unfortunately, I can decompress it, but doesn't remove the tumor totally because the strong adherence with the optic chiasma. As you can see here, the same approach as I did to the craniopharyngioma, between the lateral wall of the cavernous sinus, between the both carotids before entering in the anterior cranial fossa. Look at this. Remove the bone from the anterior cranial fossa. You can drill, and then after use a small pituitary hanger and remove the rest of the bone. You always have the control of the intercavernous sinus space, because the intercavernous sinus inside the dura can make a communication between both cavernous sinus. Então, bleeding a lot, you must prepare some anticoagulant sponges to stop the bleeding. Look at the optic nerve, and the firm adherence between the optic nerve and the tumor, as you can see here, okay? Is a postoperative view. The tumor, I decompressed inside the tumor. You can see the third ventricle. You decompress the both optic nerve, but the rest of the tumor is still there because the firm adherence with the optic nerve. Chordomas. That's the endoscopic approach bring to us a new perspective in the chordoma surgery, because most of the chordomas are placed on the midline. And then there is no better view to the midline than the anterior endoscopic approach to the nose. Look at the region between the dorsal sella until the foramen magnum can be seen to the endoscopic approach. Look at this. It's a clivus chordoma. And here, look at the carotid artery covered by the bone, the sella turca, and drill all the clivus. The bone is a little bit thin, and then I remove all the bone over the clivus from below until the dorsal cell. And then, as you can see, the tumor here, and the book in the tumor, smooth, sucker the tumor, drilling closer to the both carotid arteries in order to gain space. But believe me, for me, it's very difficult to go laterally, even with a endoscopic 7-degree endoscope. As you can see here, after remove the tumor and the arachnoid, there is a tremendous encephalocele seal, and then we try to compress it, and we try to preserve the integrity of the arachnoid sheath in order to avoid fistula. And here is the postoperative view. The patient developed a pneumocephalus, but she's recovered very well. And then here, look at this. There is a hole in the dura, and to the hole, the arachnoid comes from. And then I put fatty and flappy and wait the patient recover. And the surgery was very nice. And the patient didn't develop the problem in the postoperative. Look at this case, is another chordoma. Is a man with 80 years old man, completely oculomotor ulcer, but the pituitary function is okay, and no visual deficit. And the patient were operated to the nose too, and the tumor And we have an excellent removal of the tumor and the compression of all the history. And the patient recover very well the completely high oculomotor biopsy. Depois eu insiro o vídeo, senão não vou conseguir mandar. Is another case, another chordoma. This chordoma, look at chordoma complex invading the cavernous sinus, invading the cavernous sinus, and the prepontine cister, and operated to the nose too. And we did the same approach from the dorsal sella to the inferior part of the clivus, and we achieve a complete removal of the lesion. Look at the postoperative view. The area of the prepontine cister were totally removed. This is a graft put in this region. It's a 24 hours MIR. But some cases like this, look at this, is a tumor involving the carotid artery, involving the cavernous sinus, compressed the brainstem, the high part of the mesencephalic structures, and I did the frontal orbital FLG approach, and look at this, the orbit, the anterior clinoid process, remove the anterior clinoid process totally, and retract the dura. This is the peeling of the middle fossa, and after peeling the middle fossa, after remove the clinoid process, open the dura, and then you can work between the intradural and extradural space, as you can see here. Look at the optic nerve, carotid artery, third nerve, small part here. Here is the posterior clinoid process. Look at this. Posterior clinoid process were removed, and then you can, here is the posterior clinoid process, here is the tumor between the lateral wall and the carotid artery. You cannot see here the third nerve, a small part only. And then I could remove the tumor between these structures, and look at the postoperative view. The anterior clinoid process and the posterior clinoid process were removed. The medial wall, the lateral wall of the aorta, include the bone of the orbital fissure, were removed too. And then you can see a fantastic decompression and removal of the chordoma of the posterior clinoid process. And you can see here, 1 month later, the patient developed a sixth nerve, but 6 months later recovered the function. And foramen magnum, when the tumors placed on the midline, it's possible to remove the tumor to the nose. But if the tumor is spread laterally or posteriorly, forget the approach. Do a traditional approach. But if the tumor is totally ventrally, doesn't spread laterally, it doesn't so bigger, you can remove from posterior. Look at this. This is it. Clival tumors. The tumor were removed to the anterior endoscopic approach. Look at this. Open the clivus, Daily, all the bone, as you can see here, the vertebral artery, basilar artery, both vertebral artery, and below and behind them, you can see the tumor. Look at this, and you can remove the tumor. The tumor then spread laterally, and then you can see totally remove this tumor. Open the dura as much as possible. I used to open the dura on the midline, and sometimes I remove the dura with the pituitary hanger in order to have a big space for remove the tumor. And then you do a microsurgery, like a microsurgery. Look, the space, a small part of the tumor was left because the tumor is very adherent to the lateral part, and we follow the patient, look at the brainstem, look at the ICA. ICA artery is very beautiful, and here is the brainstem. Is another case, a small meningioma of the craniovertebral junction. The tumor, look, is above the odontoid process, and then you don't need to remove odontoid process. You don't need cause instability in this patient. Is a good approach. You go to the nose. And then the tumor were totally removed to the endoscopic endonasal approach. The paper was published on January 2020 on the World Neurosurgeon to look at the basilar artery, and the tumors were totally removed. And here you have the brainstem, the basilar artery, the vertebral artery, the pica, and the hypogloss. Look at it, the hypogloss nerve. Means the postoperative view, and the complication is not so bigger, and we have a good success. But most, some cases is more appropriate to remove from the nose. Some cases more appropriate to remove from the nose. One of the best tumor or removed to the nose for me is the chordomas, is some meningiomas placed strictly on the midline. Complications, we have some complications. Most of them doesn't require the reoperation. Look, 7, 8, 9, 15 complication, and 6 need reoperation for closed CSF leak. And mortality, only one patient with a clival meningioma. My comment is I review the literature and my experience. Transcranial approach offer a clear advantage over endoscopic approach for large olfactory meningioma, with higher resection rates and lower complication. Select case of plano esfenoidal and tuberculous cell meningioma, endoscopic approach, endoscopic sphenoidal approach has similar rates of resection with higher rates of visual improvement. The CSF leakage after the multi-layer reconstruction has similar rates between both techniques. The endoscopic approach is an ideal approach for chordomas placed on the midline. And considering endoscopic skull-based surgery for some clivus and foramen magnum meningioma. That's all. Depois, sabe o que eu vou fazer? Já parou? Isso.
Good afternoon, everyone. I'm Kotoe Kamata. I'm an anesthesiologist at Tohoku University School of Medicine. Today, I will talk about the anesthetic considerations for intraoperative electrophysiological monitoring. First of all, I greatly appreciate Professor Yoko Kato and organized committee of this seminar. Let me introduce myself. I have got MD license and a PhD degree from Tokyo Women's Medical University. For my 20 years of experience in clinical anesthesia, I spent most of the time in neurosurgical cases. My research and clinical interest is neuroanesthesia for awakeniotomy and pediatric stereotactic radiosurgery. Following a 3-year stay in Finland, anesthesia EEG has also become my main field. If you have any questions, just feel free to send an email to me. This is my message to all of you who are here today. A surgical operation is a kind of team approach. Please share your knowledge and experience with all staff. Understanding and cooperation among multiple professions are considered to be essential. Let's start my talk. I do not have any conflict of interest related to this presentation. The safe neurosurgical procedure consists of 3 elements: surgery itself, anesthesia, and neurophysiological monitoring. Today, I would like to emphasize that the choice of anesthetic affects the accuracy of neurophysiological monitoring, which can determine the quality of the surgery. This is today's agenda. First, I will talk about the characteristics of common anesthetic agents, then try to summarize the better choice of anesthetics for intraoperative electrophysiological monitoring. Anyway, have you ever minded what kind of anesthetics do your anesthesiologist use for your operations? The anesthetic agents used for modern neurosurgery are divided into 3 categories: intravenous general anesthetic agent, volatile agents, and others. How shall we use them for different purposes per the goal? An ideal anesthetic agent for use in neuroanesthesia and neurocritical care would allow rapid recovery of consciousness, permit early assessment of the post-operative neurological status, and have advantageous effect on cerebral hemodynamics. However, no agent currently available fulfills all the criteria that I show here. As you know, we have two different types of anesthetics used for induction and maintenance. One is intravenous agents. Roughly speaking, intravenous agents, except ketamine, have similar effects on overall cerebral hemodynamics and metabolism. Intravenous agents reduce the cerebral metabolic rate of oxygen, CMRO2, while maintaining carbon dioxide response and autoregulation. Another choice is volatile agents. All volatile agents decrease cerebral metabolism except nitrous oxide. They are cerebral vasodilators at higher concentrations, with desflurane and isoflurane causing more vasodilation than sevoflurane. Vasodilation causes an increase in cerebral blood flow, cerebral blood volume, and intracranial pressure. Then, cerebral autoregulation is progressively impaired. In addition, considering intraoperative neurophysiological monitoring, volatile agents suppress evoked potentials. I will talk about it later. Thus, the use of intravenous agents throughout the surgery has become the gold standard in neuroanesthesia. This type of anesthesia is called total intravenous anesthesia, TIVA. Before looking at the properties of individual intravenous anesthetics, let's see the pharmacological characteristics of intravenous agents. The context-sensitive half-time. The vertical axis of these graphs is the time required for plasma concentration of a drug to decrease by 50% after discontinuation of drug administration. In the left panel, propofol shows shorter context-sensitive half-time comparing to thiopental and midazolam. The right panel indicates the context-sensitive half-time of dexmedetomidine calculated from the different PK models. Comparing to propofol, the context-sensitive half-time of dexmedetomidine is longer than that of propofol. This fact indicates propofol provides rapid recovery even its duration of infusion was unexpectedly prolonged. Let's move to the details. Propofol is now the most widely used agent for general anesthesia, conscious sedation, and awakeniotomy. Concerning neuroanesthesia, propofol can have the effects that I show in this slide. It provides smooth induction with minimal excitatory effects and a rapid recovery. Propofol causes a dose-dependent reduction in arterial blood pressure, which may in turn compromise cerebral perfusion pressure CPP. Furthermore, propofol has anticonvulsive effect. Thiopental use is diminishing as a first-choice induction agent. Other than occasional use for rapid sequence induction, the clinical use of thiopental is mainly limited to neurocritical care for deep barbiturate coma to reduce ICP in patients with refractory intracranial hypertension. Significant accumulation and delayed recovery caused by the large distribution volume of thiopental is a critical issue. Next one is dexmedetomidine. Dexmedetomidine is a sedative which works as an alpha-2 adrenergic agonist. It has dose-dependent clinical effects, including anxiolysis, analgesia, and sedation. The nature of the sedation is similar to natural sleep in terms of EEG alternation and clinical effects. Its minimal effects on the respiratory drive are favorable for conscious sedation. Most benzodiazepines, except remimazolam, are associated with prolonged sedation. Therefore, its use is limited for induction or premedication with lower doses. The most prominent aspect of benzodiazepine is having a selective GABA-A receptor antagonist, flumazenil. The last one is ketamine. Ketamine is an NMDA antagonist with sympathogenic activity. The use of ketamine in neuroanesthesia has been limited because it raises ICP and has unwanted side effects, including emergency reaction, vivid dreaming, out-of-body experiences, and delusions. This is a summary of the pharmacodynamic effects of intravenous agents. Propofol, thiopental, and etomidate have similar effects on overall cerebral hemodynamics and metabolism. All these agents reduce CMRO2 consumption and maintain responsiveness to carbon dioxide and autoregulation. Among them, propofol is the ideal agent. Propofol can manage both induction and maintenance of anesthesia. Moreover, a rapid return of consciousness from propofol anesthesia facilitates the early assessment of postoperative neurological status. Let me talk about one more issue that is the pharmacological characteristics of opioids. This is the context-sensitive half-time of the common opioids. The context-sensitive half-time of fentanyl is entirely different from the other three agents because its context-sensitive half-time is constant at 3 minutes, just 3 minutes. Fentanyl provides sufficient analgesia and muscle relaxation during surgery without concern about delayed emergence. S. Total intravenous anesthesia with propofol and fentanyl is the ideal combination for neurosurgical cases. The next topic is intraoperative electrophysiological monitoring and anesthesia. Currently, we have two different modalities of electrophysiological monitoring during surgery. EEG, electroencephalography, and EMG, electromyography, are the recording methods of spontaneous electrical activities. On the other hand, evoked potentials are the techniques that apply a stimulus to elicit a response. These techniques can identify reversible changes in neurological function intraoperatively, thereby allowing intervention and possible prevention of injury. In general, multiple techniques are usually used together during surgery to provide the optimal surveillance of the nervous system. During monitoring, several factors can change the responses in addition to the surgical procedure. Both physiologic management and anesthetic choices affect neural functioning and monitoring responses. These include conditions leading to inadequate oxygen delivery, hypothermia, electrolyte abnormalities, and hypoglycemia. Because anesthetics modify the synaptic function, the neural pathway that consists of several synaptic connections may easily be affected by anesthetic agents. So, how shall we choose the anesthetics? I have tried to list up to 3 main concerns, just 3. Number 1, is a target neural pathway presynaptic? Number 2, what is the primary response? Is it muscle contraction? Number 3, do you plan to use other monitoring modalities?